Good morning, everyone. So we're going to start the event in 5 minutes, so please be seated. So I'm going to let you know when we start. So for your information, if you see the name tag that you have, then you're going to be able to see the QR code at the corner of the name tag. Then you're going to be able to access to the program book. So please use the information to get the information about the presentation. So we're going to start in 2 minutes. Right, so it's 9:05, so let me start the event. And good morning, everyone. I'd like to say thank you for attending this event early this morning, and welcome to the first exercise Oncology Symposium and Salutogenesis at Yonsei University. My name is Jin Soo-byun, and I'm assistant professor at Yonsei University in the Department of Sport Industry Studies. And it's my great honor to open this year's symposium as the moderator for the first session. We are also honored to have leading scholars from all around the world for this symposium, and thank you for being here and for contributing to the advancement of exercise oncology and salutogenesis research. First of all, let me briefly explain the host, sponsor, and objectives of this event. This symposium is hosted by the Department of Sport Industry Studies, the Center for Exercise Medicine and Salutogenesis, and ICONS at Yonsei University, and also the Cancer Prevention Center at the Yonsei Cancer Center. This event is also sponsored by the BK21, Salutogenesis-based Global Health Solutions Education and Research Unit. We deeply appreciate their leadership and commitment in organizing and preparing for this year's event. So the Yonsei Exercise Oncology Symposium was created as a collaborative platform, scholars and practitioners to share knowledge and the latest information in exercise oncology and related health sciences. We hope that this symposium will spark meaningful discussion and strengthen global collaboration over the next 2 days. To begin our program, I'd like to introduce our distinguished speakers who will open today's symposium. And we have 4 speakers for opening ceremony. And the first speaker is Dr. Yongjin Yoon, professor in the Department of Sport Industry Studies at Yonsei University. Dr. Yoon is the leading scholar and has made impactful research and teaching activities in sports psychology. Please join me in welcoming Professor Yoon.
Good morning, distinguished guests, colleagues, and participants. My name is Dr. Yongjin Yoon, a professor in the Department of Sports Industry here at the Yonsei University. It's my great pleasure to offer these warm congratulations on the opening of the Yonsei Exercise Oncology and Salutogenesis Symposium. I sincerely thank the organizing committee, speakers, sponsors, and the staff for making this important meeting possible. And I warmly welcome everyone joining us both in person and online. This symposium is timely and meaningful. Exercise oncology provides strong evidence that exercise can improve function, reduce symptom burden, and support survivorship. Salutogenesis broadened our perspective, encouraging us to focus not only on treating disease, but also on creating and sustaining health. Together, these approaches can help us translate evidence into real-world practice in clinics and communities. I hope today's discussions inspire new ideas, strong collaborations, and practice strategies that ultimately help patients and survivors live better. Once again, congratulations, and I wish you a productive and inspired symposiums and enjoy the rest of the conference. Thank you.
Once again, thank you, Dr. Yoon. And we have another opening speaker for the event, Dr. Junsung Lee. He is the associate professor in the Department of Sport Industry Studies at Yonsei University, and he is the leading scholar in the sport management and business at the global level. Please welcome Dr. Lee.
Good morning, everyone. It's my great honor to welcome you to the 4th Yonsei Exercise Oncology Symposium and Salutogenesis here at Yonsei University. This year's symposium themes Exercise Oncology and Salutogenesis from evidence to implementation brings together an exceptional community of scholars, clinicians, and practitioners. This year, we are privileged to host participants and speakers representing 5 countries. This truly international nature of this gathering reflects the growing global momentum behind research and clinical innovation in cancer exercise science and health promotion. Across the next 2 days, we will hear from more than 25 presenters, including world-renowned keynote speakers and leading scholars whose work spans survivorship, rehabilitation, behavioral science, implementation research, and the biological mechanism underlying exercise in cancer care. I am strongly convinced that their multidisciplinary expertise will drive this field strongly forward. I warmly encourage each of you to actively engage in discussions, challenge ideas, share insights from your own countries and institutions, and most importantly, explore new opportunities for future collaborations. The knowledge and connection built here have the power to create lasting impact for cancer survivors and for the global health community. Thank you all again for being part of this important event today. I wish you an inspiring and rewarding symposium. Welcome you all again to Yonsei University, and thank you once again for joining us. Thank you.
Right, so we have 2 more speakers for the event. By the way, thank you, Dr. Lee, once again for the insightful and warm welcome to the audience. The next opening speaker is Dr. Sung-Soo Baek, who is the president of the Korean Society of Exercise Physiology. He is also a professor at Sangmyeong University. He is widely recognized for contributions to exercise physiology, not just in South Korea, but at the global level. Please welcome Professor Baek.
distinguished professors, and esteemed colleagues. It's a great honor to stand before you today as we rewrite advanced mission of profound importance, the integration of exercise as a vital part of care and recovery for individual living with cancer. Your presence reflects both your expertise and your commitment to improving the lives of patients facing one of the medicine's greatest challenges. Exercise physiology has become a powerful evidence-based field, demonstrating how physical activity can build resilience, enhance treatment outcomes, and support long-term survivorship. The knowledge and insight represented in this room provide a strong foundation for expanding the reach of this life-changing intervention. Today's gathering is more than an academic meeting. It is a symbol of hope for better care, hope for recovery, and hope for future for countless patients. I am truly grateful for your dedication and compassion. I look forward to the ideas and excitement that will emerge from our time together. The Korean Society of Exercise Physiology will also do its utmost to contribute to the development of the Korean guidelines for cancer survivors. Thank you.
Thank you, Dr. Beck. Now we're going to move on to the last speaker for the opening ceremony, Dr. Ji-Suk Park, who is the chair of the Cancer Prevention Center in the Yonsei Cancer Center. She is the leading scholar in the area. And please welcome Dr. Ji-Suk Park with a big hand of applause.
Good morning, everyone. I'd like to extend my sincere appreciation to all of you for joining us today despite the cold weather. It is a great honor to deliver this congratulatory remark on behalf of our Yonsei Cancer Center and Cancer Prevention Center. It's hard to believe that the Yonsei Exercise Oncology Symposium has already reached its fourth year. I'd like to express my gratitude and congratulations to Professor John and his colleagues, whose unwavering passion has led to continuous research, development, and delivery of outstanding exercise programs for our cancer patients and survivors. I sincerely hope today's symposium will serve as an important step toward realizing Professor John's inspiring belief that exercise can lead us to win over cancer and to be healthy. Thank you very much.
Right, so now it's my pleasure to begin session 1, Salutogenesis and Cancer Outcomes, Shifting the Paradigm. The session will explore how salutogenesis can change our perspective from disease treatment to a more holistic, health-promoting approach in cancer care. And the session will be co-chaired by Dr. Ji-Suk Park from the Cancer Prevention Center and Yonsei Cancer Center, and Dr. Justin Jun from the Department of Sport Industry Studies at Yonsei University. I'd like to invite our session chairs to begin the session, and please welcome the chairs with a big round of applause.
Let me start the first session, Salutogenesis and Cancer Outcomes, Shifting the Paradigm. My name is Ji-Suk Park from Yonsei Cancer Center. This session will be moderated by me and Professor Chen. The session features lectures by two distinguished speakers. Dr. Georg Bauer has joined us in person, and Dr. Kerry Courneya is participating virtually. I'd like to introduce the first speaker, Dr. Georg Bauer. Dr. Bauer is the head of the Division of Public and Organizational Health and the Center of Salutogenesis at the University of Zurich. He is a physician and public health scholar with a PhD from UC Berkeley and a habilitation in public and organizational health from ETH Zurich. His research is focused on the occupational health psychology, health promotion, and salutogenesis. Especially, his pioneering work in salutogenesis has shaped global perspectives on how individuals not only survive, but truly thrive. Please join me welcoming him with a round of applause.
Good morning, everyone. Thank you very much for the warm welcome and the introduction, and certainly the honor to give the first opening talk. When we can put on the presentation here, or is it already on? No, it's coming. Okay, very good. So, you see the title, Salutogenesis in Healthcare, Moving Beyond Disease Towards Health. When I was invited to a symposium and also had certainly conversations before with my colleagues here, I noticed that you actually already do that, because combining cancer and exercise is already by itself a very salutogenic approach. So maybe I cannot tell you so much new, but maybe it's a little bit inspiring to know about this background of salutogenesis, which could be, I think, a very profound framework for even further strengthening your efforts for combining these two perspectives of disease and health. So what I would like to cover, first of all, I would like to give a short introduction into salutogenesis, and there we will see if there are actually three different meanings when people talk about salutogenesis. We don't really fully always agree what we mean by that, so I will show all three meanings, and there it's absolutely nice to have these three different meanings, because each of it really serves their own purpose. Then I will show that really the original salutogenic model still has some, let's say, room for improvement. It really could be completed to make it a real full model of the origin of health. And last not least, I will spend some time how we can then apply this model to the field of healthcare. So, you all certainly know about pathogenesis, which is about the origin of disease, where we normally look into risk factors of single disease outcomes, and that's certainly a very profound foundation of medicine to really treat patients well. And certainly we need this foundation and build on this foundation, and there we certainly meanwhile have a lot of different diagnoses, 55,000 different diagnoses in this newest edition of the International Classification of Disease. And still, we also want to go beyond that and add this perspective of the origin of health. So Aaron Antonovsky, who is the author of this concept of salutogenesis, really proposed this term salutogenesis, and I think that by itself, this term is already the greatest contribution he made, because by that he really offered this paradigm shift, not only to look into the origin of disease, but really looking into the origin of health as a more positive concept, where suddenly when we talk about health, not single disease outcomes are of interest, but the whole person, how the person lives and survives and thrives, and what we can do to really help this person to live a fulfilled life. So here we are much more interested in a whole disease continuum, not single disease occurrences, but how the person overall is doing, and ideally would move more to this positive end of this disease continuum. And in short, we could define salutogenesis as something where we look into how social and individual resources help people to manage stress, to survive and thrive simultaneously. So that's in essence what salutogenesis is about. And that's already the so-called salutogenic orientation, this paradigm shift from only suffering to also thriving and resources which help us to thrive. So I briefly mentioned already the name, Aaron Antonovsky. It's also important to know a little bit about the author. He is a medical sociologist, actually. He was raised in New York. His parents were immigrants themselves. They came from Russia in the 1920s. He was born there in the United States and got his education there. And then he again moved himself to Israel in 1960 and became part of the medical faculty. So suddenly he was surrounded by a lot of pathogenesis in this medical faculty and was still very much interested in this broader understanding as a sociologist about the origin of health. And how did he finally come up with this very concept and term of salutogenesis? Well, in 1970, he conducted a study among women. These were women in the menopause, and he was interested in the mental health of these women, how they deal with this transition of their life as women. And interestingly, as he is a sociologist or was a sociologist, he also asked about the whole life course of these women. And by that, he also found out that part of these women in their previous life had this horrible experience that they spent some time in a Nazi concentration camp during World War II. The most terrible trauma you can have, certainly as a human being. And luckily, they survived. And now when he really analyzed the data, he found that indeed the women not exposed, so to speak, had a much better mental health. 63% said they are in good mental health, and the others, the traumatized women, only 29% said they have good mental health. So from a pathogenic point of view, this is what we would expect. They were exposed to this risk of a concentration camp, so it reduced their health. Now Antonovsky went one step further, and he asked, how is it possible that after this traumatic experience, still 29% say, I'm well, I'm thriving, I'm really doing well. And that was exactly what led him to the salutogenic question. What is the origin of health in these women who still thrive after this horrible experience? And this is how he came up with this original question about the origin of health. And he did then conduct some follow-up interviews with people also who underwent traumatic experiences. And out of that, really inductively, this concept of salutogenesis emerged. And his answer of the question of the origin of health emerged. And actually, these are his main two publications where he laid out his concept of salutogenesis in much more detail. So what is his answer? Well, when he analyzed these interviews, a concept emerged, something which really was something shared by these women who survived so well. And he called this emerging answer the so-called sense of coherence. And he defines it really as a global orientation towards life, in the sense that people overall perceive a life as coherent. What does it mean? It can be best defined by these three sub-dimensions of coherence, which are also presented here. The first is with comprehensibility. It's more the cognitive dimension, where we are able to somehow structure things which are happening to us. It's somehow predictable, and we can find some order in it. And this is the case when we say, it's comprehensible what is happening in my life. That's a cognitive dimension. Secondly, it should be manageable. So if there is a difficult situation, I know how to deal with the situation, and I can mobilize some resources which help me to handle the situation when it's manageable. And last but not least, on an emotional level, it should be worthwhile investing my energy. So there is a purpose in what I do, and then it's meaningful. And then all three dimensions together constitute this strong sense of coherence. And the great additional thing, besides developing this concept, he also developed a scale, the sense of coherence scale or questionnaire, and that really has been translated in over 50 languages by now, and there really are virtually thousands of studies which show people with a strong sense of coherence indeed do much better health-wise if you look both on morbidity or mortality, and there's even a very strong decrease in longitudinal mortality when you have a strong sense of coherence. Now the big question is, sounds really wonderful, but how How is it possible that some people do have a strong sense of coherence and others have it less? And then again, you would need to look into these interviews, and again, you find the answer. It's really about the social resources which allow people to develop this strong sense of coherence. So people in this interview, they reported they had a childhood, an early youth, and also early adulthood, where they really always were surrounded by people taking care of them. They supported them, they also gave some appreciation, and if this is the case, then people really can develop a strong sense of coherence, which is equipping them for the future, for difficult situations. So it's really a combination, this interaction between us as individuals and the important environments in which we live, which creates health. So that's summarizing also the very complex model of salutogenesis, which had been developed by Antonovsky, and that's like the essence, which is also explaining how the sense of coherence is helping us to survive and thrive. Because when we have a strong sense of coherence and are facing with stressors, with demands in our life, then we are able to reassess them as maybe not so fretful. And at the same time, we are able to mobilize these resources to overcome them. And by that, we will rather end up on this ease end of the ease disease continuum, because we overcome the tension which is generated by the stresses. We are not overstressed, but we have some relief and can really handle it well. And this is why we are less disturbed and possibly thriving after this experience, and we can grow from this experience. And having made this successful tension management, again, is also strengthening our sense of coherence again. So it's really an interactive concept. So with that, I would like to leave the first part of my presentation, the three meanings of salutogenesis, which we now have seen. On the first hand, it's really this paradigm shift, not looking only at disease and risk factors, but really having this positive orientation towards resources leading to positive and well-being outcomes. That would be the first meaning of salutogenesis. And many people in health promotion just work with this paradigm shift and don't go much further. Then there's the second meaning, as we saw, this core concept of sense of coherence. Again, many scholars are mostly working with this concept as the essence, so to speak, of salutogenesis, but it's a little bit missing the rest of the model. And here I just have depicted the overall very complex model, the regional model, which is really quite complex and still, as I would suggest, a little bit incomplete. And this is, I think, the reason why hardly anyone is really working with this model empirically, and this is why I think we need to go one step further for really completing this salutogenic model, and also at the same time to make it more coherent and manageable by itself. So why do I think it needs to be completed? Well, when you look into this original salutogenic model of health, when Antonovsky is talking about stressors, he's really talking about very severe stressors. These are really crises, war, conflicts, and so on, which are really, let's say, very challenging situation at the best. But again, it's only a one-sided perspective of life, because on the other hand, when you think about everyday life, the Ottawa Chart of Health Promotion is talking about that health is created in the settings where we learn, work, love, and play. And all of these activities, I think, are not well characterized only by the strong stresses, but also by positive experience, which help us also to achieve our life goals and to achieve positive health development. So I think we really need to look beyond these very strong stresses. Secondly, since he is interested in these very strong stresses, resources only have this one function here. They are resistance resources. So they help us to prevent something negative, to avoid and to be combated the negative. So resources here don't really capture well that resources can also immediately provide us a positive life experiences, which we will call thriving resources in a minute. And again, that is also missing here. And last not least, he is talking about the ease end of the ease disease continuum, but again in a very negatively defined way, because he defines ease as really the absence of pain, of functional limitation, of negative professional prognosis, and last but not least, no need for treatment. So it's really just the absence of disease. And already in 1948, WHO said health is more than the absence of disease. It's a complete mental, social, and physical well-being. So I think here we can and should also move ahead. So the question is, why do I think we could expand this salutogenic model by also really expanding our assumption about life? Antonovsky's assumption was really that we always live in a dangerous river of life. And I think this probably was very much driven by his own life experience, having undergone 2 times very severe immigration experiences in different country contexts, where you don't often always feel very welcome, but really have to struggle to survive and find your space. And I really want to acknowledge that this is also based on his own life experiences, perceiving life as always dangerous and something you need to survive. But I think in addition, many of us hopefully also perceive life partly as something like I'm swimming in a river full of enrichment and I can also thrive in my life, not only fight for survival. And so that's an empirical question in the end. And I had the opportunity to run a very large study across 35 countries around the globe with 18,000 employees. And there I also introduced this item in this questionnaire. So do people think they're rather only on the left-hand side, my life is like swimming in a river full of danger, I fight for survival, or also on the right-hand side? And as you see on this 7-point scale, 80% are in the middle, so in both rivers simultaneously, or even more on the right-hand side, and only 20% say, well, the negative side prevails, and only 2.8 would fall into the category as Antonovsky had postulated it. So I think when we now want to capture this full life experiences, we also need to expand the model to also capture those 80% who are more in the middle or towards the right. And so I think we just can really expand the original salutogenic question. By Antonovsky, it was really more the origin of health, the disease-ease continuum in a stressful environment. And I would add, and what is the origin of positive health in a resourceful environment? Again, not saying the other question is wrong, but it could be just enhanced or added with additional question. Yeah, and I also mentioned that's very much in line with the thinking of the field of health promotion, where we really say health is a positive concept and is driven by resources. So if we do so, and that is the completion of the second part of my talk, we have this expanded, completed model of salutogenesis, where on the left-hand side, we just say resources have a dual function. For sure, resources are important in difficult life situations to survive them, to combat them, to cope with them. But in addition, resources also help us to achieve our life goals, to develop and to have a positive health experiences. And this is what we could then call thriving resources, and both resources are important. On the outcome side, I also would suggest a second continuum. Welfare has always this question, is health a single continuum or is it not rather a dual continuum? My point of view is the problem is when we now say I'm at ease, so I'm completely free of disease, and then only then actually well-being starts. It's a little bit tricky because then as soon as I develop a disease, such as cancer, automatically with a single continuum I would move away from well-being. Okay, only because I get this cancer, suddenly I cannot thrive anymore, which is not really true. And so I think a dual continuum would rather capture this much better, this idea that both can be in place simultaneously. So before I show this dual continuum, I just would like to also clarify a little bit what we mean by positive health. And I think there is this very useful definition of WHO, a more recent definition of health. Although they call it really mental health, I think it's really a complete definition of health. Because in order to achieve all these things which are listed here, it's not good enough just to have mental health. If you want to do all these things here, you also need to have good physical health and certainly also good social health. So it's, I think, a very comprehensive definition of health, where it says health helps me to cope with stresses in life, as the original salutogenic model really suggested, but it also allows me to realize my own abilities. I can also learn and work well, and I even can contribute to my community and society at large. And I think that's really a very nice, comprehensive definition of health. Also, it's very obvious, instead of disease, which is always defined by experts, health can only be defined by ourselves for each individual individually, because who is to tell me how I work well and how I want to contribute to society? This really should be left up to the human beings. So I think that's also the very nice, powerful thing about positive health, that it's really a participatory concept, if you want. Yeah, and that is then the idea of a dual continuum, because that would allow that some people are heavily diseased and at the same time have this high positive health, can make a contribution to society, really be the best in what they do. And I just used here 3 images to visualize that. On the very top we have this Paralympic hockey player. He for sure is quite impaired on the one hand, and on the other hand he will play hockey much better than me. Okay, so he's still very thriving, or despite his limitations. Of Frida Kahlo, you might know this famous artist from Mexico. This very picture of herself on the very left top, which really shows how she is reflecting the heavy impairment she had. She had a severe accident in very young years and was suffering her whole life from this impairment and often needed to lay in bed. And anyway, she also showed that in the picture, was reflecting the situation, and even this disease helped her to develop into this great artist, and this piece of art was just sold as the most expensive piece of art ever really created by women artists. So it's not exclusive, disease and health, it can be both there simultaneously, and here in the middle we have this cancer patient, which certainly is still embedded in social ties and can live a full life despite the cancer. So I think this dual continuum is quite helpful to reflect how we can do both good disease care and health promotion simultaneously. Yeah, with that, I think I have 5 more minutes. That's perfect, my timing. I'm very lucky about that. So I can also show a little bit how that then would play out more practically. To sum up what we have seen now, that's the model actually I already published nearly 20 years ago. Already there, we postulated, not surprisingly, that health has these 3 dimensions which are heavily interacting with each other: mental, social, physical health. And health is always created and recreated by our interaction with meaningful social, ecological environments where we learn, work, laugh, and play. Okay, these are the environments where we are both exposed to risk factors which could lead to disease, but luckily also are exposed to resources which help us to deal with risk factors, but also immediately produce positive health as a positive outcome. And certainly we always had this discussion, it's not an either or, it's both. Because unfortunately, sometimes we get diseased, and when we hope and get hopefully the best possible health care, and we can then prevent this disease, but simultaneously we can also focus on this positive side and try to do the best to have both experiences in a balanced way, certainly hopefully shifting more to the left. Okay. Now that's then also clear when we now look at this interaction of these 3 dimensions of health. We can look at that in a downward spiral way. So if you get this cancer diagnosis, that certainly is related to pain. People react to pain often by withdrawal from others. They also feel ashamed about their disease. It's also depressive for sure. So you can get into this downward spiral. That would be the pathogenic perspective, or you could try to shift it and say, despite this cancer, what you exactly do in your field, you encourage people to exercise, which then will actually lead to a better mood and really more optimism. And as we already heard about this thriving center yesterday, it's wonderful, which is really about bringing people together with cancer. So it's not only me, but also others are affected, and where really the social support plays heavily out, and then you can really create an upward spiral. And I think this is exactly what salutogenesis is inviting to. Yeah, then I just would like to show how you could also do or apply that thinking in research. In a self-critical example, I show this research actually which we have done in Switzerland. In Switzerland, we do have a MS registry, so people with multiple sclerosis, they are part of this registry. And then we get a survey every half year, and where people are asked, how are you doing with your multiple sclerosis, and we're only asked what got worse, what kind of neurological symptoms you have, do you have more depression, less ability to work, whatever. So all only negative outcomes. Now imagine every half year you get such a survey and only you see how things get worse and worse and worse. That's exactly the downward spiral. It's a little bit of one-sided perspective, I would say. So this is why I suggested to this team they could also add some questions about a positive development. On the one hand, with WHO well-being index, despite multiple sclerosis, you can have this positive feelings, feeling active and vigorous and calm and relaxed and with a positive spirit and so on. So you can also ask with positive things. And then there are other researchers also conducted qualitative research, talking to people with MS, but also other chronic disease. So what changed after you got this diagnosis in an open way, not just asking what got worse, but asked openly. And suddenly people reported very positive impact of the disease diagnosis. So they really found new opportunities in their life. They reflected what's really important to me and set new priorities. They experienced some spiritual growth. They were reflecting their lifestyle. They took much more care about their nutrition, their exercise, and so on. They really have personally grown out of these disease experiences. So, I mean, this is just, again, this reminder we should have this balanced perspective. Certainly disease is bad and we are suffering from that, and still disease can also help us in some positive development even. And that's just this invitation to do that in a balanced way. And actually when we did some more deeper research also what keeps people with multiple sclerosis in the job, and not surprisingly, it's not so much the degree of suffering which is predicting if they stay in the job, but much more the social environment. If they have supportive managers and colleagues at work, then they will stay in the job despite quite some severe health impairments. And when I was looking that up, certainly this has also been used for cancer patients, this whole idea of benefit finding. What I find interesting in this review paper, that benefit finding is a positive concept, a very salutogenic concept, but for now it's mostly used in relation to negative health outcomes. So does it help us to be less anxious, less depressive, less distressed? Here you could also look into more positive health outcomes. Does it also help us to thrive if we go through this benefit finding process? I think that would be a nice addition to have also some more positive health outcomes here at the bottom. And on the other hand, looking at the determinants, also certainly it's important to realize that not everyone is equally capable of going through this benefit finding process. There's even this concept of benefit reminding, where we as professionals could also engage in a dialogue with people, so what they change, and maybe you can also find some positive changes. And I think that's something really to be explored also very much in your field for sure. Again, on the right-hand side, a lot of positive aspects will also help people in this benefit finding. I'm sure if you would put here a sense of coherence, that also would be a strong predictor of benefit finding for sure. I didn't see any study doing that, but would be nice to do in the future. Yeah, and with that, that's my final slide. I would just like to sum that up a little bit. Certainly there are many people doing research on salutogenesis in the healthcare sector. And here I summarized 2 key chapters of this handbook of salutogenesis. And these people said, well, we could use these 3 dimensions of the sense of coherence to think about how a salutogenic dialogue or engagement with patients could look like. Here on the left-hand side, the comprehensibility is really about an open communication about the current and expected course of disease, so people know what to expect when they get this disease, be upfront and clear and open. Certainly considering the health literacy, often we don't really understand well what our partner or the patient is understanding or not, so we really need to align in the language level we choose. Certainly we need to acknowledge what resources are available to the patient or also lacking to deal with this difficult situation, and really set priorities, health priorities together with the patient, which is certainly very much now captured in the concept of shared decision making. On the manageability or load balance level, it's really about that we think about how to reduce stressors, induced. I mean, a cancer diagnosis is a severe stressor, so how can we help people overcome that stressor better, and also think about how they can really reach out to others around them in their friendship network at work to get the necessary social support they need in this difficult situation. Again, we prioritize life. Maybe they need to adjust certain things, cannot do everything the same as before, but that's okay. That's part of a disease adjustment process. Again, help them to go through this adjustment process. So overall, we would increase their confidence to really deal well with their own situation. And last not least, to find some meaning. I mean, we already talked now about this benefit finding, benefit reminding. I think that would be a very powerful way to go for that with different dimensions together and reflect, how is it changing for you? Shared decision making. I mean, the whole idea is that meaning really is then happening when I can influence things which are important to me in my life. So participation is really key to meaningfulness. And again, there are some suggestions for that. So with that, I would like to end. I hope I stick more or less to my allotted time. Thank you very much for your attention and much success in maybe further applying salutogenesis in your field in the future. Thank you very much.
Thank you for the excellent lecture, Dr. Bauer. And we now open the floor for the questions and comments. Let me start a simple question, Professor. Could you recommend some salutogenic effective strategy for our cancer patient in outpatient clinic? They have very hard life and can't resist to the disease and can't cope the cancer, have many pains and can't work. Could you recommend any recommendation our clinic to clinicians?
So if I understood you correctly, because they are suffering so severely for now, for example, they cannot work and need to find other ways to still find some meaning in life, I think that's a very important question. We do quite some work on a so-called crafting concept, which is really about reflecting what is really meaningful to me in my own life, and so I can shape my life accordingly. And certainly if such an important domain such as employment and also the social network related to your colleagues and everything is not available, easily accessible, I think it's really important to think about other communities which I can approach, such as we will hear then about this thriving center, which is exactly offering that. At least I can meet other patients with cancer who are in the same situation and we can support each other. So there is at least some replacement on this social level. And otherwise, I mean, still you are part probably of a family or a friendship network and can also still reflect what, despite your severe impairment for now, you could still be part of that community and also contribute to your community, be available despite your disease. Don't really completely withdraw, but still be available to your family and friends. Okay.
Hi, Dr. Bauer. Thank you very much for your talk. Pathogenesis and salutogenesis, I think it's an idea that I've always had and appreciated, but your framework with the dual continuum really gives me a good idea of structuring it in my head, so I really appreciated that. For me, the horizontal line, the medical system, defines where you are. But individually, a sense of control defines where you are vertically. That's how I understood it. In your opinion, as a physician yourself, how does the healthcare provider's role influence, in the context of providing those social resources, how does that influence how the individual travels up and down the vertical continuum?
Okay, very nice question. I think that's exactly getting down to this point that traditionally in healthcare you are mostly interested in the patient and his or her diagnosis, and so the person is absolutely reduced to this red line, so to speak, where you are on the red line. And I think the most important difference is exactly what Salutogenesis is suggesting, not looking only at the disease of this person, but the person as a whole and where he or she is on this vertical line, as you say, and that starts out with his recommendations I showed, but you really do a much broader social assessment. So when you now suddenly have this disease, also what you just mentioned with your question, and suddenly are drawn out of your network as an employee, and you're lacking all these resources, really do a broader assessment how the disease is impacting your overall life, your family life, your working life, your leisure activities you did up to now, and then reflect how you can do these things still in a modified way. So I think that is the way to go, really do this very comprehensive assessment of the whole life situation.
Okay, so this is not a question, but a comment. Okay, I really like to thank Georg Bauer for coming all the way to Korea. He's the leader, actually the president of a global working group for salutogenesis. So he's leading the whole world in the movement of salutogenesis. But then also I'm very deeply impressed how they operate. One thing is open access. So they share a lot of information online, open access. So can you tell us about STAR's website?
Absolutely. Oh yeah, sorry, I forgot the last two slides. Could you put on the slides again, sorry, at the end, because this is exactly what I forgot to talk about. And you just go all the way down. Yeah, exactly, to these books. That's perfect. Yeah. So thanks for inviting me to share that a little bit. One slide back, sorry. The books first, yeah, exactly. So, I mean, we try to disseminate the whole idea and concept of salutogenesis, not only disseminate it, but also advance it. I think that really goes hand in hand. And here are different outlets, so to speak. On the one hand, on the very left-hand side, which was just published this year, actually, it's the Hitchhiker's Guide. So it's a short booklet, only 100 pages thick, which gives a good introduction to salutogenesis overall, but then also very specific applications in the healthcare field, in the educational field, at work sites, even for planetary health, which is certainly also very pressuring issues nowadays. So I really would recommend that short reading first, and it's all open access because our center is making that possible. And if you want to dive deeper, there's this handbook of salutogenesis, and that's really highly cited. Meanwhile, 1,000 citations, 2.5 million downloads, and so on. Very much gets a lot of attention. And there again, you see the whole range, broad range of application of salutogenesis. Yesterday I had this honor to meet the human ecology faculty, and there we also saw that really salutogenesis has been applied to architecture, to even prisons, to elderly homes, to any kind of living environment and social ecological questions, and that you all find in the handbook. And that's also Monica Eriksson, one former member of our global working group, who also shows how salutogenesis can be applied in health research. And now the next slide, please. Oh, no, I have it here. Yeah. So that's a society. It's an open society, so everyone can join for free. There are no fees. We have over 3,000 members, about half from the healthcare field, but from also many other different fields, all the way down to political sciences, for example. And here you find a lot of resources, the whole scales which are available to measure salutogenesis, the books of Aaron Antonovsky, the original ones, there's PDFs, a lot of articles, and so on. We regularly run webinars, and the next World Conference on salutogenesis will be in Chile next January. And yeah, with that, I invite you to join here and find out more. Thank you.
Thanks again for your very inspiring lecture. Please give me thanks. From now on, I'd like to hand over moderation to my co-chairperson.
Thank you very much. Actually, Dr. Jis Park and I, we've been co-hosting this for 4 years. Yeah, it's hard to believe time flies. And one of my students saying every time we organize this conference, it's getting bigger and bigger. So it's like a snowball. Thanks to all the students and the staffs who organize this. Give them a round of applause. Yeah, thank you. Okay, so is Dr. Kerry Courneya in? Okay, so I'd like to introduce our next speaker. He's Dr. Kerry Courneya. Those people who are in the field of exercise and oncology, I guess we don't need the introduction. But then anyway, he's a professor at the University of Alberta at the Faculty of Kinesiology, Sports and Recreation. And then he graduated from University of Illinois for his undergrad, and he moved to Western University, London, Ontario. And then he started his career at the University of Calgary, and then moved to University of Alberta. And then he was also one of my professors when I was studying at the University of Alberta. But now he's a world leading. Actually, he pioneered the area of exercise oncology. And then again, early this year, he really published the landmark paper in the New England Journal of Medicine, the challenge trial, after 17 hard years. So that really changed, how we see and how medical society sees exercise. So without further ado, please welcome Dr. Kerry Courneya.
Thank you, Justin. Can you hear me okay and see my slides?
Oh yeah, we see you well.
All right, fantastic. Well, good morning, everyone, and it's a pleasure to be here, and thank you to the organizing committee and to Justin Gion for inviting me to speak with you this morning. I actually attended the very first Yonsei Exercise Oncology Symposium, so it was a pleasure to be part of that symposium and to come back a few years later and share with you the final results of the challenge trial. You'll notice a little different title here, how the challenge trial beat the odds and improved survival. That's because over the last few months after publishing the challenge trial, I've begun to realize just how difficult it is for these lifestyle interventions to show improvements in survival. Many have tried and many have failed. In fact, going through this literature, challenge could very well be the first phase 3 randomized trial to show that a lifestyle intervention like exercise actually improves survival. So I've come to appreciate how remarkable the effects of this intervention were and how it really is that we beat the odds and showed improvements in survival. So I'll share with you the trial today and also a little bit about why I think we were able to beat the odds and improve survival when many of these previous lifestyle trials have not. So colorectal cancer is the third most common cancer and second leading cause of cancer-related deaths worldwide. The management of stage 3 and high-risk stage 2 colon cancer typically is surgery followed by 3 to 6 months of chemotherapy. So those are the treatments these patients get. But unfortunately, 20 to 40% of patients will still relapse. So there's a high risk of relapse in this patient group. And the treatments themselves cause many side effects, including reduced physical functioning and quality of life. So it's definitely a patient group where further improvements in survival and quality of life would be well received. We know there's a lot of observational studies suggesting exercise is associated with improved cancer survival. In fact, when we designed this study back in 2007, 2008, it was based on the new data published by Jeff Meyerhart, really those seminal observational studies showing that higher levels of physical activity are associated with lower risk of recurrence and lower risk of dying from colorectal cancer. But of course, there was no definitive level 1 evidence. All of this evidence was based on observational studies, which suggestive is not compelling. And there's all sorts of reasons why observational data might not demonstrate a causal link. We do have lots of clinical trials of exercise in cancer patients, but they will be focusing on physical fitness and quality of life outcomes. And even there, most of those trials have focused in breast and prostate cancer. The ones that have been done in colon cancer are very small studies with short follow-up. So there really was an absence of good quality evidence on the role of exercise in colon cancer. And Challenge is the first phase 3 randomized trial examining the effects of exercise on cancer-related survival. The primary objective was to examine the effects of a 3-year structured exercise program compared to health education materials on disease-free survival. Lots of different secondary objectives, including overall survival, very important secondary outcome. We have lots of data on patient-reported outcomes, physical fitness, motivation, self-reports of physical activity, biological mechanisms, and health economics. So a lot of those data are being analyzed and are circulating among the co-authors right now. But as of this stage, we've still just published the primary paper on the survival and fitness and physical activity outcomes. So this is a schema for the Challenge trial. In terms of targeting the specific cancer group, these were all patients with stage 3 or high-risk stage 2 colon cancer. They all had the tumors surgically removed, and they had completed their chemotherapy. So we recruited them within 2 to 6 months of completing adjuvant chemotherapy. And so this is really kind of an early survivorship trial after patients had just completed their chemotherapy. And we also had to add a couple eligibility criteria from an exercise perspective. One being that they're not currently meeting the exercise guidelines. We didn't feel like we could let anyone into the study because we weren't confident we could increase physical activity levels in patients who are already meeting the exercise guidelines, so they had to be either sedentary or at least insufficiently active. And they also had to be able to complete 2 stages of a treadmill test, which were 3 minutes each, meaning they had to be able to walk for about 6 minutes at a very slow pace. So this was just to ensure that they were ambulatory and functional, because we knew we wanted to significantly increase the amount of exercise these patients were doing, and they had to be at least functional for us to be able to do that. Did all sorts of baseline testing, including submaximal treadmill test, the seniors fitness test, which includes 6-minute walk test. As I mentioned, lots of quality of life measures, physical activity measures, and so on. And those measures were done repeatedly throughout the 3-year intervention. So baseline, 6 months, 12 months. Some were done every 6 months, and then some were also done at 2 years and 3 years. So we had lots of repeated assessments of these important outcomes. And then we randomized patients to either health education materials or to a 3-year structured exercise program. And I'll describe that in a moment. And once again, the key outcome in this trial is that we focused on survival endpoints, disease-free survival and overall survival. And given the challenges in the slow accrual, we actually ended up with an 8-year median follow-up. So we had long-term follow-up on these patients after the 3-year exercise program. So these were the health education materials that were given out to patients that we considered sort of standard of care at the time. They got the information that they should indeed exercise, and they should follow the exercise guidelines of 2.5 hours of moderate to vigorous intensity aerobic activity per week. And they also got information about strength exercises that they should do a couple days a week. Gave them a few tips on how to be active. And so that's what the health education comparison group received. The structured exercise program was modeled after the diabetes prevention program and the Look Ahead program. And for those of you familiar with this area, you'll know the DPP is probably the most successful lifestyle intervention that's ever been published. They were able to show substantial weight loss among the patients for an extended period of time, and they showed that that weight loss resulted in a dramatic reduction in the incidence of diabetes compared to both usual care as well as a particular drug, metformin. So highly, highly successful. So we looked at the key features that they used and tried to replicate those in the Challenge trial. And so we set clear and challenging exercise goals that I'll show you in a moment. We included some supervised exercise. We didn't feel like we could go to a fully remote intervention, and certainly not back in 2008 when we launched the trial. The other key thing we provided is frequent and ongoing contacts, including face-to-face contacts. So we didn't want to do a short-term intervention and then expect patients to continue on their own. So we wanted to keep the intervention going for the entire 3-year period. and that's how long we felt it was necessary to improve these cancer outcomes. The other really key feature of the challenge trial is that it's based on a validated theoretical model using evidence-based behavior modification techniques. So this is based on the science of behavior change. This is not just telling patients go get some exercise or giving them the FIT principles. This was based on science of behavior change and the things that we know can help patients substantially increase and maintain exercise over an extended period of time. So the exercise behavior change goal, let me just pop my video back on there. I can see it popped off. I'll see if it'll come back on. Okay. So the exercise behavior change goal to increase recreational physical activity by at least 10 MET hours per week from baseline. And one difference with this study is this is a behavior change goal. That means no matter what patients were doing at the beginning of the study, they were asked to increase by 10 MET hours per week. Many trials do an absolute behavioral goal, so they set the goal at 150 minutes per week or 200 minutes per week, and then the change goal is different for each patient depending on where they started. So we really focused on every patient trying to dramatically increase their exercise behavior. We focused on aerobic exercise of at least moderate intensity, which we defined as brisk walking, so 4 to 5 METs is what we were really trying to push for. But patients could choose the type of aerobic exercise they wanted to do, the frequency, duration, and even intensity to achieve the goal. So lots of variety was available to patients to how they wanted to meet that goal. They didn't receive any guidance on strength training, on nutrition, or weight loss. Of course, patients are free to do whatever they want in terms of those things, but there was no guidance from the interventionists who were delivering the intervention. So this was the structured exercise program in terms of the timing. We delivered it every 2 weeks during the first 6 weeks, and those were mandatory face-to-face sessions. So they came in every 2 weeks, they did a supervised exercise session, and then they also did a behavioral counseling session. In the second 6 months, we also asked them to come in every 2 weeks, and they could do the behavioral counseling session either face-to-face or remotely. And if they did come in face-to-face, we also had them do a supervised exercise session. In years 2 and 3, we transitioned to them coming in once a month. So once a month for the last 2 years. Again, they could do it face-to-face or remotely. We strongly encouraged the face-to-face, and if they did come in for a face-to-face session, we also had them do a supervised exercise session. But during all of these sessions, they were delivered these behavior change techniques that we know help patients increase and sustain exercise behavior over an extended period of time. So we followed a theoretical model. This is very, very important. I won't bore you with the details of this particular model, but this is the one we used to guide the intervention. And the exercise specialists were trained on this theory so they could understand what theoretical constructs we were targeting in this intervention. Attitudes towards exercise, subjective norms for exercise, perceptions of control, intentions to exercise. So this is a very important component that these types of interventions are theory-based. And here's the 17 behavior change techniques that we implemented based on that theoretical model. Many of these you will recognize, things like goal setting, time management, making exercise fun, social support, self-monitoring, of course, overcoming barriers to exercise, detailed planning, and so on. So these were a lot of the key evidence-based behavior change techniques that were known to improve exercise levels, and we put them together in a package where they were delivered over these sessions that were delivered over a 3-year period, along with the supervised exercise component. Primary endpoint was disease-free survival, and that was from the time of randomization to the first event of either recurrent colon cancer, new primary colorectal cancer, new second primary malignancy, or death from any cause. We also report overall survival in the primary paper, improvements in cardiorespiratory fitness, and self-reported moderate to vigorous physical activity. So as Justin mentioned, these data were presented at ASCO back in June, and we had the good fortune of a simultaneous publication in the New England Journal of Medicine. And so, as many of you know, it's quite rare for an exercise trial to be published in the New England Journal of Medicine. It's quite a big accomplishment. And I think they were interested in this paper just because of the novelty of the paper, testing exercise as a treatment for cancer compared to drugs or radiation therapy. And I also think they were interested in this paper because of the remarkable findings that I'll share with you in a moment, showing substantial improvements in survival. Probably the first ever lifestyle trial or complementary therapy intervention that's been shown to improve survival. So we ended up randomizing 889 colon cancer patients with equal numbers to each group. We did recruit mostly in Canada and Australia, which was some of the reason for the slower accrual, fairly small countries and not a large geographic base. The median age of the sample was 61 years, half were women. But I think the other key descriptive variable is 90% of these patients were stage 3 colon cancer. So a very targeted patient group, probably one of the most targeted exercise interventions out there as well. And these were patients at high risk of a recurrence. These are the adherence data, and I'll draw your attention to the second line there, the attendance at the mandatory behavioral support sessions. You can see the first 6 months, we had about 80% attendance at those sessions, which were required to be in person. About 70% attendance for the second 6 months could be in person or remote, 70% in the third 6 months as well, and about 60% in each of the final 18 months of the intervention. So certainly a little bit of a drop-off in adherence over time, but still quite good when you keep in mind, keep in perspective that most exercise oncology trials don't do any more than this phase 1, first 6 months. Many are 3-month exercise interventions. They keep patients exercising for 3 months. 6 months would be considered quite a long exercise oncology intervention. So this is the first trial not only to go beyond a year, beyond 2 years, but out to 3 years to try and keep these patients exercising, because that's what we felt was necessary to improve survival. So I think these are fairly good adherence numbers considering the length of the intervention that we attempted. See if that video comes back on there. I'm not sure if you guys are still able to see there or not.
We're seeing the slide fine. You have a problem with the video, but just continue.
Okay. All right. So there's the first data that we reported from the study, which is absolutely critical. And you can see we had a substantial increase in moderate to vigorous physical activity in the exercise group compared to the health education group. So this is where many of these lifestyle trials have failed in the past. It's notoriously difficult to get substantial behavior change in these patients compared to a usual care group, and to sustain that exercise behavior change over a 3-year period. So this was a huge relief, needless to say, that we were able to sort of separate these groups and deliver the exercise intervention. Because this is far more challenging in a lifestyle trial than it is in a drug or radiation therapy trial, and I'll talk about that in a moment. And we also showed substantial improvements in fitness that were maintained over the 3-year period. So these patients exercised more and were fitter over an entire 3-year period. So compare the challenge we have in a lifestyle trial to a cancer trial, a drug trial. So you can see in the top graph A there, in a drug trial, when patients start the trial, none of them are doing the drug at all. All right, so if you're doing a cancer trial of chemotherapy, none of the patients are doing chemotherapy at the start of the trial. None of them are doing immunotherapy at the start of the trial. And when you randomize them to control or placebo group, none of those patients get the drug over the course of the intervention. None of them start immunotherapy on their own. None of them start chemotherapy or radiation therapy on their own. So in these cancer trials, you have an absolutely perfect control group during none of the intervention. So you get to compare your drug to absolutely nothing. Now, they may struggle a little bit with adherence. You can see adherence may not be perfect in the drug trials. Patients have side effects and so on. But overall, you can see how much they're able to separate the groups. Compare that to a lifestyle intervention in graph B, like exercise. Rarely do we recruit patients doing zero exercise or eating zero fruits and vegetables or doing zero amount of the Mediterranean diet. They're all kind of already doing some of it. Some of the drug that we want to test is already being done. And then when they're randomized to the usual care group, many of these patients will increase their exercise, as we saw in the challenge trial. So this is a real challenge for us. You can see what we tested in the challenge trial is really a dose-response trial. We compared a high amount of exercise to a moderate amount of exercise. And this is what makes the findings even more remarkable. This would be like a cancer drug trial comparing 6 cycles of chemo to 3 cycles of chemo rather than to 0 cycles. Or comparing 1,000 milligrams of an immunotherapy drug to 500 milligrams rather than 0. How difficult would it be for these cancer trials to demonstrate a benefit if their comparison group was doing some of the drug or some of the radiation therapy? And so we push these groups higher. If I go back to the previous slide, our solution to the contamination in the usual care group is to try and get the exercise patients to do even more. And that's how we kind of overcome this challenge. The problem is we kind of push these patients further along the dose-response curve. So we're not in the optimal range of showing benefits. What we'd love is to compare completely sedentary patients to patients meeting the guidelines. That's where we think all the action is in terms of showing benefit. What we did in the challenge trials, we compared patients who were kind of starting off doing around 150 minutes on average. And we got the intervention group to do up to about 300 minutes on average, compared to maybe 175 or 200. So this is kind of the range of the dose-response curve that we're working with. So still a possibility of benefit, but not as dramatic if we were able to get truly sedentary group in the trial. Despite those limitations and despite those challenges, we reported remarkable findings. You can see here in terms of disease-free survival events, 93 patients in the exercise group had a DFS event compared to 131 in the health education group. Hazard ratio of 0.72. So patients randomized to exercise had a 28% lower risk of having a disease recurrence or new primary cancer. You can see these curves start to separate at about 12 months. And by 5 years, there's a 6.5% absolute difference. And this difference continues over time, all the way out to 10 years, where it's close to a 10% absolute difference in disease-free survival. We also showed a remarkable improvement in overall survival. 41 deaths in the exercise group compared to 66 deaths in the health education group, hazard ratio of 0.63. Patients randomized to exercise were 37% less likely to die during a 10-year follow-up than patients randomized to the health education materials. You can see here the curves start to separate at about 4 years. So the recurrences and second cancers start to happen at about 12 months, and then the deaths start to kick in at about 4 years, and this is where we start to show the benefit. Out to 8 years, you can see a 7% absolute difference in overall survival. At 8 years, 90% of patients randomized to exercise are alive, compared to 83% of patients randomized to the health education materials. So my colleague Chris Booth, medical oncologist in Kingston, Ontario, put together this slide to put the challenge effect size in context. And this slide really generated a lot of buzz at the ASCO meeting and really got a lot of attention. As you can see here, he puts our intervention adjuvant exercise in colon cancer, which showed a 7% gain in overall survival, absolute gain at 8 years, Compare that to FOLFOX, which is a well-accepted chemotherapy protocol in colon cancer, 5% survival benefit at 10 years. Some of the targeted drugs in non-small cell lung cancer, 8 to 10%. Trastuzumab, well-accepted intervention for HER2-positive breast cancer patients, 5% survival benefit. And many other targeted drugs showing smaller improvements in overall survival. So this slide demonstrates that exercise is as good as, if not better, than many of the current drugs that we give to our patients in terms of its effect. And these drugs cost tens of thousands of dollars and have all sorts of serious side effects that these patients experience. So this really is remarkable finding on how well exercise can improve survival compared to existing treatments. So just going back to this initial theme and title of my talk about beating the odds, there's a few things I think the challenge trial did to beat the odds. So one is beating the odds on recruitment. And many trials fail at this stage, not just lifestyle trials, but many drug trials close to early accrual. So this is a high risk for these types of trials. We were able to recruit 889 patients. Our goal was 962, so we were almost able to achieve our goal. It did take us 15 years. As I mentioned, we recruited mostly from Canada and Australia, and these are two small countries. Canada has the same population as California, and Australia has about the same population as Texas. So this is the equivalent of recruiting in two large U.S. states. So it's a very small geographic base, and I think it was not enough. You know, we needed to expand much more. We did try to add more centers after the trial opened, including in additional countries, but this was very challenging for all sorts of different reasons. These centers had to go out and find their own funding. That's always a lot to ask. Even the centers in Canada and Australia were underfunded. The UK, which joined the trial, lost its funding after 5 years. So these were some real challenges. And then helping different centers find local exercise partners. Not all of these centers were set up beforehand to have these relationships with exercise specialists. And then finally, of course, COVID, which could have been the death knell of the trial. But unfortunately, it was not. So how did we beat the odds on recruitment? I think it was really because the Data Safety and Monitoring Committee was very lenient with our trial. To be honest, if this was a drug trial, it might have closed early for poor accrual. But the funders were very supportive, the patient advocates were very supportive, and even the local medical oncologists. And so I think they cut challenge trial a lot of slack. And even though it was slow accrual, they said, no, we need to finish this trial. So that was really what helped us beat the odds on recruitment in the challenge trial. Beating the odds on adherence. As I mentioned, this is where many lifestyle trials fail. They're unable to separate the groups. They're unable to get a substantial increase in behavior change compared to the health education group. And as you can see, our health education group did pretty well. So this was challenging for us to do far better than the health education group. We had challenges with standardization across centers. We had a high turnover of the exercise specialists, the physical activity consultants at some centers, in part because some of these centers put very few patients on the study. And so, you know, when you're randomizing one patient a year or one patient every 2 years, it's hard to stay engaged or motivated in delivering the intervention. COVID did require a temporary shift to remote only, so that was another challenging for us. But on the positive side, we had very well qualified exercise specialists at the key high accruing centers. So the centers that were recruiting well also were delivering phenomenally good exercise intervention. As I mentioned, we had a strong theoretical basis for the intervention and a really good behavior change program that these exercise specialists were following. We did incorporate some supervised exercise, and I think that's a really important component, and ongoing regular contacts all the way out to 3 years. And lastly, there was close monitoring of the exercise specialists. So they had to submit to me regular updates every couple months on adherence in their patients and the fitness reports as well. So there was accountability to make sure the intervention was being delivered. And I think those things helped us beat the odds on exercise adherence. And then even if you beat the odds on recruitment and beat the odds on adherence, there's no guarantee a lifestyle intervention is going to improve survival. Even at that stage, many of these interventions have failed. They do separate the groups, they do deliver an intervention, but it doesn't actually have any survival benefit. So I think we were able to beat the odds on survival by focusing on a high-risk patient population. As I mentioned, 90% of these patients were stage 3 colon cancer, at risk about a 30% or so of relapse and second cancers. We also had long-term follow-up. So one of the kind of blessings in disguise of slow accrual is that we followed these patients for an extended period of time. We had a median of 8-year follow-up, which helped increase the number of events. It's based on strong observational data of physical activity after treatment for colon cancer, very compelling observational data. Some preclinical data, but limited in the colon cancer cell lines. It's also based on good mechanistic clinical data. So, things like insulin IGF, improvements in immune system, anti-inflammatory markers, these are all thought to play a key role in colon cancer growth and spread. So, there was good mechanistic data there as well. And we also, when we did our substantial increase in exercise and fitness, it was still within the dose-response zone. So even though we weren't comparing these patients to completely sedentary, we were still in that range that the observational studies said was associated with improved cancer outcomes. And lastly, not only were we able to get substantial increase in exercise and fitness, we were able to sustain that for the entire 3 years. And I think this may be critical for improving cancer outcomes. So in conclusion, a 3-year structured exercise program after surgical resection and adjuvant chemotherapy for colon cancer increased moderate to vigorous physical activity and fitness and ultimately improved disease-free and overall survival. As I mentioned, this is one of the first exercise trials to demonstrate a survival benefit in any population: cardiac patients, diabetes patients, older adults, other patient groups, COPD. So it really is a remarkable attainment from that perspective. And as I mentioned, the magnitude of benefits comparable to standard medical therapies. Exercise is as good as, if not better, what we're currently offering patients for many of the drugs and many of the other biomedical interventions. And intervention, like exercise, is empowering and achievable for many patients. And health systems, we're hopeful that we can change clinical practice, that this is a practice-changing trial. But I think health systems need to invest in these behavioral support programs, that just recommending this to patients alone will not be sufficient for sustained exercise behavior change and improving outcomes. I'll just end by acknowledging the Canadian Cancer Trials Group that oversaw this entire trial, all of the centers, investigators, and exercise specialists who delivered and ran the study, and the 889 patients and their families who committed to a 3-year intervention. That's quite a commitment for people who are recovering from colon cancer. And lastly, the funding sources, in particular, the funding we received in Canada from the Canadian Cancer Society. Thank you very much for your time.
Excellent presentation, Kerry. If you stop sharing the screen, and then maybe you can turn the camera on and see what happened. Kerry, do you hear
It
me?
looks like I have stopped sharing. Have I stopped sharing there or not?
Okay, now can you turn the camera on?
Yep.
If you already have it on, maybe turn it off and back it on again.
Yeah, it's not looking like it's working, unfortunately, Justin. I'll keep trying here while you're...
That's okay. So we can still,
Yeah.
okay. So thank you. And then I'd like to invite, floor, anybody who has a question, please identify who you are, and then you can ask question. Okay, until somebody come up with a question, Kerry. Oh, yeah, go ahead. When you have a question, please come to the microphone and then first introduce yourself. We'll start with Sungwoo, and then Nicole.
Hi, Dr. Cuneya. I'm Sung Lee, a PhD student of Yonsei University in Justin's laboratory. I was really interested in your research and I really appreciate your presentation today. I just have one question. From my understanding, this RCT conducted an exercise intervention among colorectal cancer patients after they completed chemotherapy. So in that case, is it correct to compare the exercise group's effect with the with absolute overall survival gain typically observed in groups with just adjuvant FOLFOX? I mean, are you just trying to emphasize that adding exercise after chemotherapy increased the expected overall survival gain from the usual 5% point to 7% point, meaning an additional 2 percentage point improvement?
Yeah, okay, very good question. No, what we're saying, so this is the exercise intervention after chemotherapy. That chemotherapy protocol is associated with about a 5% absolute survival advantage. So the benefits of exercise were beyond the chemotherapy one. So by adding exercise after chemotherapy, this was an additional 7% improvement in overall survival compared to chemotherapy alone. So we're not suggesting that exercise should be done in place of chemotherapy. Patients should still get their chemotherapy, but after chemotherapy, by adding exercise, the magnitude of benefit is as good as or better than the chemotherapy that they just completed.
Thank you.
Nicole?
Hi, Kerry. It's Nicole. Thank you for that awesome overview. Every time I see and read more about Challenge, it just makes me excited about where this can go. So I have 2 questions for you. The first is, and you've already talked about this, I've heard you speak on other pieces, as well as a talk I heard Chris give. But you've got a pretty motivated group coming in, right? Their med hours are hard at baseline, and you make that nice distinction of, when we have to have a drug trial, we're comparing to nothing. So I guess my first question is really, how do you get the people most in need, the sedentary group, to even consider coming in to something that looks like structured exercise?
Yeah, great question, Nicole. So I agree. This trial has a bias similar to other trials coming into it. These patients were likely healthier, a little bit fitter, more motivated. And so these are not your, completely deconditioned or frail older patients. So we do have to keep that in mind when we think about generalizing beyond kind of the patient group that we had. In terms of engaging with those patients, the type of intervention we did in Challenge may not be feasible for some of those patients on the very low end of functioning, but possibly just helping them increase exercise even less than what we achieved in Challenge might be beneficial for them. Mm-hmm. And in terms of motivating them, I think, all these patients that came forward for Challenge had no idea whether or not it was going to improve survival. And now we've got these compelling data, I think, that you could present to those types of patients. And many of those patients who are very sick, very ill, will still start their chemotherapy and still do the chemotherapy, even though that's going to be very hard on them because they view it as providing a survival benefit. So hopefully the Challenge trial results might motivate those patients who might not think of themselves as exercisers or may not think that it's feasible for them to at least be able to do some exercise and potentially gain those benefits.
Awesome. Okay, and then the second question is implications of this, given the dose response you saw, for guidelines. Because you're moving them beyond, the current exercise oncology guidelines, and that's where you're really seeing the benefits. So any thoughts around that? And thanks.
That's a really interesting point, Nicole. I hadn't thought yet about the implications of the guidelines, but you're right. If we put those out and say, what does it take to improve survival? Yeah, you're kind of looking at the 300-minute suggestion rather than the typical 150 minutes. The between group difference, let's say for argument's sake, is 150 minutes. So does that mean, if we had a truly sedentary group that in fact 150 minutes might be enough. So some of the patients in that trial would have been doing nothing at baseline, and we would have been trying to get them to the guidelines. And so I don't know if we can go in and look at some subgroup analysis just to see if it did require, a full 300 minutes, or whether it looked like patients doing less might have been beneficial. But that's a really interesting point, Nicole, how this is going to get interpreted for what guideline we put forward.
Do we have time
All
for
right.
another question?
Yes, we do actually have 4 or 5 more minutes. So,
Thank you.
Dr. Kim.
I'm Sue Kim
Kyung-jin,
from
you
the
have
College of Nursing at Yonsei. I really enjoyed your talk, and it was very comprehensive and challenging. Having done a short-term 3-month exercise program for patients with cancer-related fatigue, I do understand how difficult this might have been and can't imagine how you did it for this long. My question is, you talked about the health system implications, which is really, really underlying in the next step. And I can almost imagine it might take as long as you did this exercise trial to convince providers and the health system to move to support and invest in this. And I recently heard a discussion by a professor in Germany who did a shared decision-making trial, and he used his benefits evidence to convince the health insurance companies by region, and then by hospital, by hospital first, and then he expanded it to the region. And eventually it got covered, and so a lot of the hospitals are implementing this. I just wanted to ask you if you have any concrete plans for the next step of convincing the providers and policymakers.
Yeah, that's a great point. So I think we might be a little bit naive that this will change practice overnight. We're already getting people saying, hopefully it doesn't take the standard 10 to 15 years that other interventions take. So, is exercise going to be different, or are we going to follow that path of kind of a very slow implementation and uptake? Right now in Canada, there's different provinces that are pushing to get this into practice, and we'll see if any of them have success. I know Nicole Culos-Reed and others in Alberta have been approaching the government to try and get some funding for this, but not successful so far. We're attempting it in Ontario and British Columbia as well. And I'm getting emails from all around the world, groups in Belgium and Denmark and stuff, saying we are putting this into practice now. So I think, we might look for some countries to be more successful. I don't know what's going on in South Korea, what the implementation is, and whether a challenge trial might influence implementation there. But I agree. I think if we can get a foot in the door somewhere, some province or state or country to adopt it and show success and deliver it, it might encourage other places to put this program into practice.
Okay, actually, Kyung-jin, Lisa has one, yeah, and then Anna May.
Thank you for presenting. I'm undergrad student in UIC Yonsei College. So my question is also similar with like the previous question for the result and the maintenance for the adherence for the behavior. So given the challenge trial, the demonstrated survival benefits comparable to standard medical therapies, required, I think, expensive behavior support infrastructure. So what do you see as the most realistic path for health system to implement MVPA behavior support program at scales? Like, do you envision a model led by oncology clinics or community partners or like digital platforms? Because I see you mentioned in the conclusion as like health systems needs to invest in MVPA behavior support.
Yeah. I think right now different groups are exploring different options. So, some are saying, do you combine this with cardiac rehab? Can we capitalize on existing cardiac rehab or pulmonary rehab programs and expand those and gain access for cancer patients? Some are suggesting, the cancer center itself, could they hire a certified exercise specialist who would oversee these types of programs and deliver them? Others are looking at community-based models. Chris Booth, the medical oncologist I mentioned, said, what about a model where the money just follows the patient? So we've costed this out to maybe $4,000, and if you're diagnosed with stage 3 high-risk, stage 2 colon cancer, you've got kind of a health spending account of $4,000 to, for exercise support, and you can go out to the community and receive qualified support. So people, I think, are looking at different models and how to deliver this. And of course, we can't forget about the virtual models, the remote models. Those are going to be very important for delivering, in rural areas, smaller towns, across much larger regions. Can we develop virtual online programs that oncologists might be able to refer to?
All right, thank you. We have last question, Anna May.
Yes, thank you. Hi, Kerry. This is Anna May from the Netherlands. Thank you for, again, a great presentation. And I have one question about the length of the intervention. You mentioned in your talk that you decided on 3 years. And
Yes.
Could you share a bit of the discussion you had beforehand, why 3 years is the length and not 2 or 4? So what's your opinion about that?
Yes, so we know that, short-term exercise interventions can improve fitness. 4 to 6 weeks is plenty. 8 to 12 weeks, we can show improvements in fatigue and quality of life and those types of outcomes. But, when you're trying to alter the course of disease, it seemed like we need a longer intervention than the standard 3-month or 6-month intervention. But the key reason in the challenge trial is in that particular clinical setting that we studied, 3-year disease-free survival is a well-accepted surrogate of overall survival. So if you can keep patients disease-free for 3 years, you've got a really good chance of a cure and improving overall survival. So that's why we targeted the 3-year intervention in that particular clinical setting.
Excellent. So, Kerry, maybe can you just try to turn the camera on? Because we like to see your face
there.
before we end the session, if it's possible.
No, it's saying failed to start the video camera,
Okay.
so sorry
That's
about
okay.
that,
No,
Justin.
that's okay. We saw your face earlier. Okay, so my last question, but then you can keep it brief in answering my question. Why did you name this trial Challenge Trial? Because, in the middle of your presentation, you said this was challenging, that was challenging. We were very confusing whether it was you're talking about this challenge trial or whether it was challenging. So can you answer my question?
Well, I think you've answered the question for me, Justin. Yeah, when we designed this trial, we knew there were going to be all sorts of challenges. We came up with the acronym, the Colon Health and Lifelong Exercise Change Trial. So that was kind of the acronym we came up with, but we viewed it as a really good fit, knowing that, demonstrating that exercise can improve survival was going to have a lot of challenges. So we just played off of that kind of thinking on the trial.
All right. It was challenging, but it was very much worth it. So thank you for your tenacity and your excellent work. Thank you so much, Kerry.
Thanks for having me. Take care.
Right. So that concludes the first session of this symposium, and thank you for the participation and chairs and the insightful talk from the presenters. So we're gonna have the 10-minute break. So we believe that we're gonna a little bit late for the second session. So we're gonna start the second session at 10:55. So please have some coffee and take the break. And we're gonna meet in 10 minutes. Thank you for your participation one more time.
Yeah, and also housekeeping here. There's a QR code. If you put the camera on, then you can see the program. Okay, thank you.
여기 앞에 있어요. 그래서 적어보시면서 보셔야 되고 얘가 다음 걸로 넘어가는 거고
We're going to begin in 3 minutes, so please sit down. 네, 알겠습니다. So we're going to start. Good morning, everyone. Welcome back. I hope you enjoyed the coffee break. My name is Kyung-eun Lee, a PhD student at Yonsei University. So now we will begin second session titled Exercise for Survivorship, Recovery, Function, and Quality of Life. It's my pleasure to introduce our session chairs, Dr. Ji-won Lee from Department of Family Medicine at Yonsei University, College of Medicine. and Dr. Kyuwon Lee from the Department of Physical Education at Ewha Women's University. Please join me in welcoming our chairs with a round of applause.
Thank you for your introduction. Good morning, I'm Dr. Jiwon Lee from the Department of Family Medicine at Yonsei University. I'm honored to chair session 2, Exercise for Survivorship, Recovery, Function, and Quality of Life, especially with Dr. Kyuwon. Thank you. In this session, we discuss how exercise interventions promote recovery function outcomes and quality of life in cancer survivors across different age groups and treatment phases. We'll have 3 presentations and followed by a discussion and Q&A session at the end.
Okay, so I'd like to introduce our first speaker today. So first speaker is Dr. Ji-Young Kim from Korea Institute of Sports Science. And the title of the talk will be Development of and Implementation of an Exercise Program for Children with Cancer. Please welcome Dr. Kim.
Thank you for your introduction. Honestly, this is my first time on such a big stage, so I'm really nervous. Please be forgiving if I make any mistakes. Good morning, everyone. My name is Ji-Young Kim from the Korean Institute of Sports Science. Today, I will present on the development of implementation of an exercise program for children with cancer. Contents are as follows. Childhood cancer are the second leading cause of death among children, and their incidence continues to increase. However, fortunately, childhood cancer mortality rates are gradually declining due to advance in medical knowledge and technology. As you can see, while rate vary by cancer type, the 5-year survival rate for cancer patients in Korea has been steadily rising. And furthermore, the 5-year survival rate for childhood cancer in both Korea and the United States has increased. Survivors often face long-term health issues. Studies show survivors experience a higher rate of palliative, physical limitation, and challenges with school or work. They are also more likely to develop severe or even life-threatening conditions later in their life. According to the previous study, childhood cancer not only impacts the patients, but also impact parents and their siblings who face stress, emotional burdens, and lifestyle changes. Overall, survivors often face many physical and emotional challenges. They have many low fitness levels, feel tired easily, and struggle with depression and anxiety. Many also report lower quality of life and difficult with basic physical tasks such as walking, running, or lifting objects. This issue can make it harder for children to feel confident and comfortable in their daily lives. As you know, regular physical activity and exercise can improve these factors. It can improve health, physical function, fitness, and quality of life, while also reducing fatigue, depression, and other symptoms. However, as you know, according to the meta-analysis, both physical activity and fitness were significantly lower in childhood cancer survivors than in non-cancer controls, like this. And this review analyzed 9 randomized controlled trials with a total of 642 childhood cancer survivors, improved muscle strength, increased daily physical activity, better BMI, and reduced fatigue support the benefits of exercise as part of survivorship care. Furthermore, survivors who exercise more vigorous show low depression and low somatization compared with survivors reporting no vigorous activity, exercising 15 to 21 minutes per hour was associated with significantly lower adjusted prevalence ratio for depression and somatization. Exercise offers many benefits for childhood cancer survivors, physical, emotional, and social. This image shows how exercise can support recovery and promote long-term health. However, information on exercise program for childhood cancer survivors was limited in Korea. So we began research to develop an exercise program for childhood cancer survivors. This study, which started in 2016 and lasted until 2018, aimed to develop an exercise program based on 8 specific steps, including a review of the literature, a physical activity survey, a qualitative study, the first experts panel discussion, drafting on the evidence-based exercise program, a secondary panel discussion, revising the exercise program, and conducting a feasibility and file study. It resulted in 4 journal articles in total. I will describe each study in the following slide. This cross-section study surveyed 120 childhood cancer survivors. The modified exercise and quality of life questionnaire, Korean youth risk behavior web-based survey, and Golden Leisure Time questionnaire were used to evaluate their physical activity levels, preference, and barriers to exercise. The 3 most common diagnoses were acute leukemia, brain tumor, and malignant lymphoma. As a result, only 16 participants met the physical activity recommendation for children and adolescents. As you know, physical activity guideline for children and adolescents recommend at least 60 minutes of moderate physical activity every day. And there are differences in physical activity level between males and females. The 5 most common possible barriers to exercise were lack of time, poor health, reluctance to sweat, lack of exercise skills, and not having exercise partners. Among questions to consider when developing an exercise program, the most popular sports included soccer, basketball, resistance exercise, badminton, dance, and taekwondo. And they wanted to exercise with their friend and responded that exercising twice a week for more than 30 minutes per session was appropriate. We also wanted to determine whether there was a real decrease in participation in a physical education class or sports club at school. So we compared 1880 survivors with 440 healthy students. The groups were matched for gender and age at a 1:5 ratio using propensity score matching method. As a result, the survivors engaged in less activity across nearly all categories: vigorous activity, daily movement, strength training, and participation in physical education class and sports team. We interviewed 9 survivors to hear their personal stories. In-depth, one-on-one interviews with open-ended questions were conducted. As you know, during cancer treatment, their physical activity level significantly decreased. After treatment, environmental factors like lack of friends or time, combined with physical issues such as severe decline, fatigue, and disability, made it difficult for them to engage in exercise. As a result, they either only did light exercise for recovery or did not exercise at all. For the feasibility and final study, 10 childhood cancer survivors participated and divided into either an exercise or a control group. Participants in the exercise group took part in the exercise program for 6 weeks. These exercise programs included home-based and supervised sections such as resistance training and sports. A total of 12 supervised exercise sessions took place twice a week, over 6 weeks, with exercise experts as part of a group exercise program. Each session featured a warm-up, line dancing, resistance training, and sports activities such as basketball, badminton, soccer, and racket sports tailored to participants' preference. For home-based exercise, we provided exercise logs and encouraged daily exercise. The log categorized the program into low, medium, and high intensity levels, focusing on movement that participants could perform and setting the number of repetitions. Aerobic exercise, such as walking or indoor cycling, was recommended. Weekly checks was conducted to ensure their motivation. Participation in exercise program was very high, with an average of 93%. After completing the exercise program, the exercise group showed significant increase in muscular endurance and lower body strength compared to the control groups. Additionally, fat mass significantly decreased in the exercise group relative to the control group. This study developed and validated an evidence-based exercise program for childhood cancer survivors. The program was designed by identifying their exercise preference and barriers and consulting experts across related fields. A pilot and feasibility study confirmed its safety and practicality. Overall, this evidence-based exercise program can be a useful resource for exercise specialists and healthcare providers to tailor exercise plans for childhood cancer survivors. Ongoing and long-term management is crucial for maintaining our health conditions after cancer treatment. To develop effective and evidence-based exercise program for children with cancer, large-scale clinical trials are needed across all stages of care, before, during, and after treatment. Additionally, longitudinal cohort studies like the childhood cancer survivor study in the United States is really necessary to track survivorship outcomes and detect light impact over time. Furthermore, post-cancer health management should be supported by a multidisciplinary integrated care model that combined experts in medicine, exercise science, rehabilitation, psychology, and social welfare to address the varied and complex needs of childhood cancer survivors. I would like to thank my supervisor, where's my supervisor, and my colleague, who worked on this study. Their support made this study possible. Thank you for your attention.
Thank you for your insightful presentation. Yeah, we'll have Q&A session at the end. Our next speaker, is Dr. Dongwon Lee. Dr. Dongwon Lee, a professor of plastic and reconstructive surgery at Yonsei University College of Medicine. He completed his medical and doctorate training at Yonsei University and has extensive clinical and research experiences in breast reconstruction and post-operative recovery. Today, he will discuss the effect of early exercise on functional recovery after breast reconstruction in breast cancer patients. Please welcome Dr. Lee.
Thank you for kind introduction. Can you show the slide? Okay. I'm truly delighted to be here at Yonsei's Exercise Oncology Symposium, and it's a great honor for me to be here. Today, I would like to discuss about the effect of early exercise on functional recovery after breast reconstruction in breast cancer patients. In Korea, breast cancer is now the most common cancer in women and continue to increase. About 1/3 of breast cancer patients undergo total mastectomy. All of these patients become candidates for breast reconstruction, since losing a breast can greatly affect daily life. If a total mastectomy is performed, one breast loses almost all volume. With current surgical techniques, most chest muscles, such as pectoralis major, are preserved, and only the breast tissue and some lymphatic tissues are removed. Breast reconstruction fills the defect caused by breast cancer surgery. This can be done with an implant or with the patient's own tissue. Breast reconstruction can be divided into implant-based reconstruction and autologous reconstruction. Autologous reconstruction can use tissues from the abdomen, the thigh, and the buttock. The breast reconstruction has been increasing every year due to the rising incidence of breast cancer and coverage by the national insurance system. More than 600 patients receive breast reconstruction at Severance Hospital each year. Breast reconstruction techniques have advanced remarkably in recent years. These patients received reconstructions with an implant and abdominal tissue. Can you tell which breast side was reconstructed in these patients? The left patient had reconstruction on the left side with the implant, and the next right patient had surgery on the right side with her abdominal tissue. So the appearance is very important in breast reconstruction. But breast reconstruction is not only about restoring the shape. The breast Q, which is most widely used evaluation survey, looks at outcomes from many perspectives. Among them, physical well-being, chest is an important domain, and shoulder and arm function is also one of the key factors in the final outcome. Using Korean National Health Insurance data, we investigated whether a patient who had breast tumor removal later developed shoulder disorders. Our analysis showed that these patients were 1.78 times more likely to undergo shoulder disorders. This study was conducted by the breast surgery team at Severance Hospital and Professor Justin John. They analyzed patients who had breast cancer surgery without reconstruction. The results showed that a significant decrease in shoulder strength and range of motion after surgery, and these functions did not return to normal even within the first month. This recent review article also shows that many studies report a decline in shoulder function during the early postoperative phase. Many plastic surgeons used to restrict shoulder movement after reconstruction, favoring complications. But because we now understand the harm of prolonged restriction, early mobilization is gaining attention and is being adopted to some plastic surgeons. Here is an interesting report. A 2020 survey of United States plastic surgeons showed that 18% never recommend physical therapy to the patient after reconstruction, and 76% provided it to less than half of their patients, usually after 3 weeks. This showed that postoperative exercise is still not widely recognized in the United States. Many plastic surgeons still worry that early postoperative exercise might negatively affect surgical outcomes. Because of this concern, they are often hesitant or less interested in early exercise. Does early exercise after breast reconstruction actually increase complications? We examined whether early mobilization affects postoperative drain output. However, we found that looking in this graph, early exercise did not increase the amount of the drainage after surgery. Now we need to summarize the key problems we face today. First, early exercise does not significantly affect surgical outcomes. Second, there is a few established exercise program after breast reconstruction. Therefore, we need to develop exercise program to help preserve shoulder function after reconstruction. We conducted 2 separate studies. First, we observed that a natural course of shoulder function after breast reconstruction. Second, we performed a randomized controlled trial to evaluate how early exercise affects shoulder recovery following reconstruction. In study 1, observing the natural course of shoulder function after reconstruction, we measure shoulder range of motion, strength, body composition, and physical activity levels in patients who underwent breast cancer surgery and immediate reconstruction. There are 5 follow-up visits within the first 3 months after surgery, and we collected the necessary measurement at each visit. 29 patients were enrolled 21 with implant reconstruction, and 8 patients with autologous reconstruction. There are no significant difference in baseline demographic between the groups. We looked at how many patients reached 95% of their preoperative total sum of flexion, extension, and abduction. The total sum of range of motion was about 18% at 1 month and improved to 43% at 3 months. Strength recovered to 37% at 1 month and 47% at 3 months. This suggests that even after 3 months, less than half of the patients fully recover shoulder function after reconstruction. We compared flexion, extension, and abduction ROM between implant and autologous reconstruction. In all measurements, ROM dropped right after surgery and gradually improved, but there was no significant difference between these two groups. Strength showed the same pattern. It decreased after surgery and slowly improved with no significant difference between implant and autologous reconstruction. We compared ROM in patients who exercised more than 150 minutes per week with those who exercised less. There was no significant difference between the two groups. We also compared strength based on the 150 minutes physical activity level. Even though the difference was not statistically significant, the group exercising more than 150 minutes showed greater strength and faster recovery. In summary, range of motion and strength dropped the most right after surgery, but improved steadily over 3 months. There was no significant difference between reconstruction types. Patients exercising more than 150 minutes per week showed better recovery trends, which suggests that being more physically active may help improve functional recovery. So, based on the result of the study 1, we designed study 2. We divided patients into an exercise intervention group and a control group, with random assignments. We planned to enroll 30 patients in each group. We set shoulder function, including ROM and strength, as the primary outcome. Upper limb disability, body composition, physical activity level, and post-operative complications were used as secondary or ancillary outcomes. The total follow-up period was 6 months, with 6 assessment visits measuring the variables shown here. The exercise intervention had 4 intensity levels. Each level included one-on-one instruction and supervised exercises during the first month, followed by home-based exercise starting in the second month. There was no significant demographic differences between the intervention and control groups. This is the key result slide. Strength and ROM decreased right after surgery in both groups, just as we saw in the natural course in study 1. They then gradually improved over time. However, the exercise group showed faster recovery beginning at 1 month and maintained significantly better strength and ROM than the control group at 6 months. For strength, the intervention group showed significant improvements over the control group in all shoulder movements. For ROM, significant differences were observed in abduction and extension. This showed that the shoulder recovery rate, based on the percentage reaching 90% of the preoperative baseline. At 6 months, over 80% of patients in the exercise group regained normal shoulder strength and ROM. In contrast, fewer than 50% of patients in the control group reached normal recovery at 6 months. For upper limb disability, the exercise group showed an initial decline right after surgery, but returned to near normal baseline level by 6 months with a significant difference compared to the control group. Importantly, there was no significant differences in post-operative surgical complications between the exercise and control groups, addressing the major concern often raised in plastic surgeons. For body composition, the exercise group showed a slight trend toward better outcomes than the control group, but the difference was not statistically significant. Regarding physical activity, the exercise group showed a greater increase than the control group, but this difference was also not statistically significant. In study 2, we found that all exercise after mastectomy and reconstruction improved shoulder function and health-related outcomes. For the primary outcomes, the exercise group showed significantly better shoulder function compared to the control group, and there was no increase in post-operative complications. For the remaining measures, there were no significant differences, but the exercise group consistently showed better trends across most outcomes. This more than 3 year study was possible because the excellent collaboration with Professor Justin John team, and I want to express my sincere gratitude. Thank you. 네. Okay, thank you for your attention. Thank you very much.
Right, thank you so much for the great lecture today, and we'll have a discussion later after our last speaker. So let me introduce our last speaker, Dr. Sammy Kang from Gachon University. She is currently an assistant professor at Gachon University, and she will give us a talk about exercise experiences of cancer survivor. Please welcome Dr. Kang.
Hello everyone, my name is Sammy Kang and I'm a nursing professor at Gachon University and rectal cancer survivor. Today I will share my exercise experience during recovery. Before going to my exercise experience, I'd like to share a short story of diagnosis and treatment. In December 2022, I first noticed blood in stool. In August 2023, colonoscopy confirmed rectal cancer. This cancer was located about 5 centimeters from anus. The CT scan showed lymph node metastasis. So I had open low anterior resection surgery with lymph node dissection, and pathology examination showed adenocarcinoma and with 7 metastatic lymph node and 4 tumor deposits. My cancer has spread to so many lymph nodes and tissues, so doctors suggested chemotherapy and radiotherapy. So I received 8 cycles of Xelox and 3 months of treatment was successful, and but however, there was the side effect, LARS, low anterior resection syndrome. So I felt frequent bowel movement and urgency and pain that I cannot describe, and I cannot sleep well, that caused by these symptoms. At that time, I was desperate, just trying to find anything that could help me manage these symptoms. Then through an online cancer community, I found an exercise program designed for bowel problems after colorectal cancer, and I joined immediately. This program created by team Professor John, and it was very easy to follow at home, and I could adjust the pace depending on my daily symptoms. We also made a small peer group, sharing experience and supporting each other, and we still keep in touch. It became part of my daily routine. After 4 weeks, I noticed clear improvements, less incomplete evacuation, fewer bowel movements, and also I had greater confidence in daily activities. It was a great improvement since I couldn't even go outside before this program. So, still some symptoms remained. I still had persistent discomfort, and I still had residual fecal incontinence, and also symptoms changed depending on my condition or food. Some functions improve quickly, while others simply need more time. In the following months, thanks to this program, my bowel patterns became more stable. Today, I mainly walking and do yoga. It's a good way to stay active, and my bowel health is a lot better because of it. From my experience, exercise programs for survivor need 4 things. First, accessibility. Programs must be easy to start at home, even with low energy or bowel symptoms. Second, flexibility. Intensity and pace should be adjustable according to day-to-day symptom. Third, psychological support. Peer support or survivor groups help reduce fear, normalize symptoms, and improve adherence. Fourth, integration into daily life. Exercise should be simple and short enough to eventually become a sustainable routine. Thank you for listening to my story. Actually, being a cancer patient, it was difficult, but being here today is very meaningful to me, and I hope it helped to improve exercise program for cancer survivors. Thank you.
Thank you, Dr. Gang. Thank you for your precious experience and difficult time. And also, thank you to all presenters. We'll now open the floor for questions and discussion. If you have any question, please raise your hand or approach to the microphone.
All right. While we are waiting, maybe I can ask some questions first. I'd like to ask a question to our first speaker that we already learned from our previous session from challenge trial that it's really challenging to implement exercise programs for cancer survivors. But I noted that your exercise program for child cancer patients, even adherence was really high, even higher than adult cancer patients. And it was surprising because from my experience, it was even really challenging to implement exercise programs for a child. Whenever I try something to our child patients, they just cry sometimes and they don't want to do it. And I was curious, what your strategies to improve your adherence and whether the most important piece of your exercise program.
Thank you for your questions. It's good point. I think compared with the adults with cancer, children with cancers are more likely to want to participate in sports like soccer, basketball, badminton, or dance, and they want to exercise with their friends or peers. And furthermore, they have experience and exclusion of school physical education, so they can hinder their ability to participate in sports as adults, and they hinder their chances to experience them. So I recommend it is the exercise program is fun and should fun, and they want to exercise with their friend, and laughter is very important. Thank you for your question.
Hello, my name is Kristin Campbell from the University of British Columbia in Canada. Wonderful to hear what's happening in South Korea, so thank you for all the talks. My question is for the second speaker, and I think seroma was always the reason that people didn't want to do activity early on in the post-operative time period, so it's good to see that data. The question for you is around implantation. I know that surgical techniques keep improving, but plastic surgeons in the past have been very reluctant for any pectoral strengthening because they were worried that things would move down and out. Is that still something that, based on what you've done here and your general thought process, is that something that you have thought about, or are you still restrict? That's my question.
Thank you for your question. The surgery always evolve. In the past, the standard treatment of the implant reconstruction, we put the expander under the pectoralis major muscle, and I thought that it can affect the exercise function to the of the patient, surely, for sure. But now, especially in Korea, and especially maybe many countries in the world, we put the implants in the prepectoral plane, and pectoralis major must stay in the position, and we don't touch the pectoralis major muscle. So I think the reason of the changing the surgery is it can preserve the function of the muscle, and it would be the helpful to the patient. So many plastic surgeons do put the implant the prepectoral plane. Yes.
Thank you.
Yeah.
Also, my first question for Dr. Lee, because you said in your presentation that you implemented exercise, but then I might missed it. How many times was the exercise implementation? Like how many times did the patient meet with the exercise specialist? Do you remember?
How many times? I thought because the exercise is almost handled by your team.
Okay, I will answer the question.
Yeah, so I know. The exercise operated by the one-on-one intervention, by the man-to-man education, and if the patient can complete one step and go to next step, and we have four step. Yeah. So I don't know exactly the specific protocol, but how many times?
Yeah, so exactly. So 4 times. So what I was trying to say also to the audience is that only 4 exercise intervention, and then within the first 1 month, and we only did follow up at 3 months and 6 months, and that's how much improvement that we saw. So I think that was something that amazing result that we witnessed together. Thank you. Sorry, I asked the question and I answered.
Thank you for your comment. Yeah.
And my second question is to Professor Kang. Okay, same question because how many times you see actually amazing improvement in the first 1 month? How many times actually did you meet with us for exercise session? 몇 번 우리 만났죠?
We met 2 times.
Yes.
Only 2 times.
Yes.
Yes.
And how much improvement you experience is actually amazing, because we only met once actually, and then we gave you the booklet, and then you did a home exercise for 1 month, and then we met to see how much you improved, and then we exercised together, and then all the participants who came, almost everyone, they had a significant improvement with only 1 exercise session with the right booklet. So I think that's something that I like to that people to know. Thank you.
I'd like to ask Justin John, conference host. Yes. Yes. We talk about the supervised exercise program. Yes. While supervised exercise program definitely beneficial to the cancer survivors, but however, maintaining exercise remains very challenging. And so, how strategy is the best strategy to sustain exercise for cancer patient without supervised exercise or supported program and what do you think about that?
Okay, so I think many of our students who did the study could answer better, but maybe I will try to answer in two different ways. First one is to remind our patient how much they have improved since we met last time. And then they see the change in their body or symptom, and then now they understand it was due to the exercise. Once they know what exercise is doing to their symptoms, they don't need more motivation. They exercise themselves. Okay, so I think that's one very important thing. And then one thing like what Dr. Lee mentioned, but that also we had another paper published in JAMA Surgery. We only met 4 times. And then significant improvement in first month and 6 months, like 4 times or 5 times faster recovery in their shoulder function. But we only met 4 times. The reason why we met 4 times is that's when the patient need to see the surgeon. So we meet them right after their meeting with the surgeon. So they have to come to the hospital anyway. And then we show them how much they have improved since their last meeting. And then they, again, of course, it's the work of our graduate student. They were very, very good in motivating them. But also, I think meeting with the surgeon, and also they know that surgeons support this exercise, really help them and trust our exercise program that increase the compliance. Thank you. Thank you for your question.
As Professor John comments, the making motivation to the patient is very important. So whenever I see the patient in my clinic, I always cheer up the patient to exercise exercise is important, and you can overcome the cancer with the exercise. Yeah, like this. Yeah, motivation is very, very important.
Sue Kim from Yonsei University. Dr. Kang is a dear colleague of mine, so it's especially meaningful to hear her story today. My question for you as a survivor is, from a survivor perspective, what would you like to see change in the clinics and in the health system, and also in the health industry that is trying to make money out of patients but not really focusing on the important evidence-based material that we have?
Yes, right. In the clinic, can I talk in Korean? 영어가 짧아서 죄송합니다. 그 클리닉에서는 그러니까 병원에서는 이제 치료가 끝나면 좀 방치되는 느낌입니다. 그래서 이제 정말 그런 생존자를 위한 이런 프로그램들이 정말 필요하다고 생각이 드는데, 이제 이렇게 연대 정 교수님 팀에서 이렇게 연세 의료원이랑 이제 연계해서 이렇게 학교에서 활성화된 프로그램이 있다면 모르겠지만, 이제 대부분의 병원들은 그런 것들이 저는 없는 걸로 알고 있어서, 이제 그런 프로그램들이 정말 필요하지만 이제 지역사회나 아니면 이제 병원, 그러니까 치료가 끝난 이후에 그런 생존자들을 위한 프로그램이 이제 필요하다고 생각하고, 이제 그런 것들이 지금 많이 없어서 좀 어디서 무엇을 찾아야 할지, 이제 생존자 입장에서는 그런 것들이 좀 문제인 것 같습니다.
Yeah, maybe I can just briefly translate to our international faculty. So basically, after the cancer treatment, there's no like a formal follow-up for the patients to exercise. So it's really hard for her to share. I mean, to find the right exercise program. So where to go and where to see the right program. So I think she really believes that we need like a better like a follow-up like exercise programs for those like cancer patients and survivors. And we still have a couple more minutes. If you have any other questions, we can ask our distinguished speaker. Yeah.
Good morning, everyone. I'm from Sports Industry Department, Leisure Business Lab. I have a question for Professor Kang, because it's a very meaningful story for us. So, as a cancer survivor, could you please describe the most meaningful, most memorable exercise experience for us?
처음에 이제 너무 대변 그런 심텀들이 너무 안 좋아가지고 이제 막 여러 가지를 뭘 해야 될까를 일단은 몰랐는데, 이제 그런 것들을 찾던 와중에 이제 저희가 암 환자용으로 이제 네이버 카페가 굉장히 활성화된 곳이 있거든요. 이제 거기서 이제 마침 전영강 교수님 그 프로그램이 있다고 해가지고 이제 가서 이제 해봤는데, 이제 그게 제가 얘기했듯이 좀 집에 가서 쉽게 할 수 있는 것들이 제일 좋았어요. 그게 가장 도움이 됐고, 일단은 지금은 되게 멀쩡하지만 다 이제 많이 리커버리가 돼서 멀쩡하지만 그때는 되게 쇠약하거든요. 막 엄청 피로하고 막 좀 움직이기도 되게 힘든 것인데, 이제 그 전영경 교수님께서 만든 그런 프로그램들이 되게 집에 가서 좀 따라하기 쉽고, 그러니까 거의 뭐 힘든 게 플랭크 정도였던 것 같아요. 제 기억에는. 그래서 좀 그런 되게 쉬운 동작, 집에서 따라하기 쉬운 동작들이 가장 좀 기억에 남고 도움이 되었던 것 같습니다. 네.
Thank you for sharing, because it's really hard to say they're like a drama, like a very hard time. So thank you for sharing.
Yeah, just briefly, the most memorable exercise was something that she can do at home easily. So but also she remembers like plank exercise was the hard part, but also memorable. So, and if you guys don't have any other questions, sorry, yeah, you. Please.
Thank you. This is Seung-Young Lee from Incheon National University, and
probably I will ask. I will ask you any thought from all presenters, maybe. So, as an exercise physiologist, I'm trying to ask you guys for maybe one type of question regarding exercise prescriptions. So, since like first speaker present the 3 different types of cancer, which is acute leukemia, brain tumor, and malignant lymphoma, and the second presenter said breast cancer, and then colon cancer from the third speakers. So what I'm trying to ask is, what is the specific like exercise prescriptions target or strategy for each different types of cancer survivors or cancer patients? So since as an exercise physiologist, when we do the exercise prescription for different disease types like cardiovascular disease or musculoskeletal disease, we have different types of exercise prescription strategies. So what is like common, or so as a researcher or clinicians, what do we consider when we try to do the exercise prescription for these cancer patients?
Okay. In breast cancer, my study is focused on the recovery of the function. Actually, I was wondering that exercise can help overcome the cancer, but it would be need more research. And in my study, I just focused on the muscle function recovery, and I can I think I should prove my result, and it will be the more research will be needed to more help for cancer patients. Okay. Thank you.
So do we do resistance training mostly, and then maybe flexibility or stretching, because you have showing the range of motion as well?
Yes.
Yeah, if I could add just one more thing to your specific question. Yeah, cancer patients have multiple like comorbidities, so we don't really do like a uniform exercise to like all like breast cancer patients, all like colorectal cancer patients. So we basically identify like risk factors and and other comorbidities, and we are targeting specifically what we need to improve. Some patients need like aerobic exercise, and the other maybe need like resistance types. So it's important to identify the risk factor first, and then we target it. So, and the next question.
Thank you for your presentation. My name is Boyeon Kim, and I'm PhD student in Justin's lab. I want one question to Professor Kang. I'm currently conducting an exercise intervention study in patients immediately after rectal cancer surgery, LAR. And from your perspective, what your thoughts on exercise intervention immediately after surgery?
직후는 사실 병원에서 걷기 정도를 권장하긴 하거든요. 근데 이제 제가 아마 이 병원에서 그런 근육 강화 교육들이 이루어졌다면 아마 했을 것 같아요. 근데 그런 것들을 전혀 알려주지 않습니다. 그냥 그러니까 POD 0일날 갑자기 뭐 교육실로 불러내서 거의 진통제에 취해서 자고 있는데 뭐 시기 어떻게 해라 뭐 저잔사 시기에 대해서만 알려주지 뭐 이후에 뭐 생활 습관 이런 거는 사실 제가 찾아서 해야 되는 거거든요. 그래서 아마 앞으로는 이제 병원에서도 이런 엑서사이즈가 이런 근력 운동이 이제 그 배변 양상 완화에 도움을 준다는 이제 근거를 가지고 이제 교육을 해주신다면 이제 뭐 유튜브도 만들고 정영규 교수님처럼 그렇다면 정말 많은 도움이 될 것 같습니다. 네.
maybe I can translate briefly, but yeah, it's hard that it was hard, but if there's something that she could do, I mean, she would have done it, but there's nothing that she could really follow. So there was, I mean, if there's like a YouTube video or something that she may try, but she, basically it was hard for her to find it.
So let me briefly explain what she did, one day of exercise education. Actually, the exercise that she did was a result of 10-year exercise research on colorectal cancer patients about their defecatory function. So it's not just any random exercise. The exercise that was developed for specifically for those with lower anterior resection syndrome. But then the question that she asked is, what if you exercised earlier? So we recently just complete one of the study. Those people who started exercise day after surgery, they don't experience symptoms. So we feel so bad because many people suffer for many years. And then they say to us like, oh, why didn't you tell us earlier? So I think that's our motivation nowadays, that we need to put this into a regular practice so that they don't need to experience unnecessary suffering, which they could actually avoid if they only exercised earlier treatment stage. So.
Hi, I'm Doyop Kim, master student from International University. I have a question about childhood cancer. Yeah. If I'm correct, you mentioned that children who experienced cancer have lower physical activity. Could you tell me the main reason again? And then the second question is there any of following research investigate that this difference persists when they become adult? Yep.
Please translate. Thank you. 일단 치료가 워낙에 많이 힘듭니다. 그래서 치료 중에는 당연히 신체 활동이 떨어질 수밖에 없고, 사실 이건 저도 좀 고민이긴 했는데, 소아암 담당하시는 의사 선생님들한테 왜 체력이 많이 떨어지나요? 그거를 어떻게 생리학적으로 지금 밝혀진 게 딱히 없고, 그냥 그런 치료들의 레이트 이펙트다 정도로만 알고 있어서 사실은 계속 연구가 필요한 부분이라고 생각을 하고, 저는 사실 지금 제가 당장 이 연구를 계속하진 못하지만 계속 이 연구에 마음이 있는 것은, 사실은 소아암 환자들은 다른 일반 암 환자들과 다르게 살아갈 날이 더 많은 사람들입니다. 그래서 연구가 굉장히 필요하다고 생각이 들고요. 또 실제로 이 아이들이 어른이 돼서 운동을 못하는 이유는 실제로 얘기를 들어보면 학교에서 체육 시간에 거의 활동을 못합니다. 그러니까 본인이 이제 치료를 받으면서 약간 본 프랙처, 약간 골절이 일어나기도 하고, 선생님들도 어떠한 암 치료를 받았다고 하면 부상이 일어났을 때 어떠한 책임을 질 수 있는 소지가 있기 때문에 그런 부분에 대해서 좀 많이 차별을 하지 못하고, 그렇게 계속 체력이 떨어진 상태에서 어른이 되면 체력도 떨어지고 운동을 할 수 있는 재미도 못 느낀 적이 없으니 이런 것들이 계속 악순환으로 이어지게 될 것 같습니다.
Okay, I fully understand. Thank you.
Yeah, just briefly, I mean, they become long-term survivors. So they have like long life after the cancer diagnosis. But the problem is they can't really participate into regular PE classes or regular exercise. So that's the problem. But she really wants to do more research on it. But so far, there's no specific answer right now. So that's what she maybe further does the research after. So I think it's time's up. So thank you so much for the great speakers today and sharing all the insightful information. And we learned a lot from you guys. So thank you, and please join me with big applause.
Okay, thank you to our chairs and presenters for your discussion. We'll have lunch from 12 to 1:30 p.m. Enjoy your meal, and we'll see you again at 1:30 p.m. And there will be a poster session at 1 p.m. So if you're interested, please join us.
네, 저희 점심이 따로 제공되지 않아서요. 점심 공간은 여기 학교 에스컬레이터 바로 왼쪽에 있는데요. 그쪽 올라가시면 바로 좌측에 학관 이용하실 수도 있고요. 학관에서 식사 가능하십니다. 이외에도 다른 공간들이 있는데 저희 앞에 접수처에 오셔서 여쭤봐 주시면 상세하게 안내해 드리도록 하겠습니다. 아까 말씀드린 대로 1시에 포스터 세션이 있어서 1시에 관심 있으신 분들은 포스터 공간으로 와주시면 될 것 같습니다. 그러면 이제 다른 포스터 발표자들이 발표를 진행할 예정입니다. 네, 그럼 점심 식사 후 1시 포스터 세션 또는 1시 반에 세션 3에서 뵙겠습니다. 감사합니다.
근데 이거 크게 해야 되는 거야?
아니 그냥 누나가 그냥 말만 하고 그냥 마이크
지금?
그냥 하면 돼. 지금 이 정도.
이 선생님 첫 번째시잖아요, 맞지? 해요? 할까요? We're gonna start post session, so in 3 minutes, yeah. Your name is Enhase? Is it right pronunciation? Hayes.
Yeah, it's 2 A's, not.
Hayes.
Yeah.
Hayes.
Hase.
Or
Yeah.
which one is better?
People probably understand Hase.
Hase,
better.
okay.
So,
Okay.
yeah. It's, I wasn't quite expecting to say something, but.
Yeah, you know. Oh, okay. It's gonna be 3 minutes.
Yeah, I know.
Yeah. You're the second. Yeah. Oh, no, the third. Yeah.
That's fine.
Good luck.
Thank you.
오니까 이제 하니까 이제 뭐 포스터 세션 앞으로 오셔라 뭐 이렇게 얘기하고. 우선은 마이크 안 쓰려.
마이크 드리. 나 이거 좀 어색하긴 한 미국 사람. 교수님 왜 안 오셔? 그래서 오시면서 그런가? 그러면은 제가 시작해서 오셨다. 시작해서 큰일 났다.
Okay, now we are going to have a brief poster session. So each few presenter will make a 3-minute presentation. So if you like, please come to the poster. And also we have a coffee at the back. 우리 커피가 준비되어 있거든요. 그래서 얼마든지 저희 커피 드시면 되니까요. 커피 드시면서 포스터 발표 진행하는데 함께 해주시면 감사하겠습니다.
Okay, we're gonna start post session. Welcome back, everyone. I hope you enjoyed lunch. Thank you for joining the poster session. We will begin the poster mini presentations. Each presenters will have 3 minutes for a brief self-introduction and short overview for their posters. Our first presenter is Rosa Park. Please introduce yourself and present your poster. Thank you.
Hello everyone, my name is Rosa Park from Yonsei University, and today I'll present our study on the effect of early exercise after mastectomy with reconstruction in breast cancer patients. So before I begin, I would like to mention that our study was conducted together with Professor with Professor Dongwon Lee, who has presented earlier about our findings of the study. So I'm going to add a little more detail. So the breast cancer is the most common cancer among Korean women, and the number of patients receiving reconstruction after mastectomy continues to increase. So despite advances in surgical techniques, many patients still experience persistent shoulder dysfunction, such as pain, limited range of motion, and weakness that interferes with daily life. So while exercise is known to support recovery after mastectomy alone, research focusing specifically on reconstruction patients is very limited. So therefore, we aim to evaluate whether an early structured exercise program could safely accelerate shoulder function recovery in this population. So we conducted a randomized clinical trial with 60 breast cancer patients assigned to either exercise or control group. As shown in Figure 1, assessments were conducted from baseline to 6 months after surgery. The exercise group began a structured program on postoperative day 5, consisting of stretching and gradual resistance training for 4 weeks, followed by home-based exercises. And Figure 2 and 3 illustrates the development of exercise protocol and the exercise diary used to guide daily intensity levels. The control group received standard postoperative care. So our primary outcomes were shoulder function, range of motion and strength, and our secondary outcomes included DASH scores, which assess shoulder discomfort and pain, physical activity, body composition, and postoperative complications. So as you can see in Figure 4, this is our result that you have seen in the earlier session. The exercise group showed much faster and more complete recovery in shoulder function compared with the control group throughout the follow-up period. So for shoulder strength, the 70% of the exercise group returned to baseline levels by 3 months and 86% by 6 months, whereas the control group reached only about 46% at 6 months. And for shoulder range of motion, by 6 months, 83% of the exercise group recovered to baseline ROM, compared with only about 41% in the control group. So the exercise group also showed better improvement in DASH scores, indicating less functional discomfort. And importantly, postoperative complications did not differ between groups, confirming that early exercise is safe even for reconstruction patients. And although not statistically significant, the exercise group showed a tendency toward increased physical activity and a return toward baseline body composition, especially when compared with the control group. So in conclusion, early structured exercise significantly accelerated recovery of shoulder function without increasing surgical complications, and these findings support integrating early tailored exercise into postoperative care for breast cancer patients undergoing mastectomy with reconstruction. Thank you for your attention.
Thank you for the excellent presentation. And next will be the Wien. Please begin when you're ready.
Hello everyone, my name is Yuan. I study physical epidemiologist and from Professor Dongwon Lee. I think this valuable opportunity to share my personal researches on how different exercise types affect on blood pressures in adults with pre-habitation and habitation stage 1, stage 2 using the network meta-analysis. So our studies will fill gap, so the different exercise types on blood pressure and to explore the epithelial exercise prosections for these populations. We systematically research these related studies from PubMed, Web of Science, MBase, and the Cochrane Centers. We included the 146 RCT study designs to data analysis. So in our research, in our studies, the exercise intervention divided the interventions into 10 exercise types. For example, the aerobic exercise, resistance training, water-based exercise, and so on. On our research results, we found that all exercise significantly can reduce the blood pressures in adults with hypertension and habitations patients. So, especially we found that the epithelial exercise is water-based exercise can the epithelial to reduce the blood pressure in our results. So we also found that the lowest exercise type is higher intensity interval training in our results. Okay, this is all my introduction stuff. In the future, we will plan to explore the dose response between the exercise types and blood pressure reductions in these pressures. And from my supposition properly. Okay, this is all my introduction for my post. Thank you.
Okay, thank you for your presentation. And next, our presenter will be Anne Hayes, right?
Kia ora. Ko Anne Hayes, tako ingoa. I'm an associate professor in health promotion and health psychology from Victoria University of Wellington in New Zealand. So I've flown quite a ways today. But my presentation is looking at the use of behavior change techniques and mechanisms of action in physical activity and nutrition interventions for colorectal cancer patients. Physical activity and nutrition interventions after colorectal cancer treatment aim to increase the quality of life and duration of survivorship, all through improved nutrition, improved physical fitness, and greater well-being. Patients do try to make these changes, but invariably it's very difficult for them. And these changes require considerable effort through program support, as we've seen with the challenge trial, for instance. But this additional support is through multiple strategies or behavior change techniques. More recently, trials are addressing concerns about transparency of interventions. Some apply theory, describe and include sufficient behavior change techniques when designing and implementing their interventions. However, there's a lack of understanding of how these behavior change techniques actually work. What is the mechanism or the reason that they have an effect on the population of interest? So we conducted a scoping review to first identify recent physical activity nutrition interventions, and then we coded the behavior change techniques and the mechanisms of action, applying Kerry and colleagues' approach and using the calorie taxonomy. With this, what we've found, our results are here. If you want to come a bit closer, you can see them. I'm sorry, they're not quite big enough. We found 11 studies had used BCTs in their interventions in some shape or fashion. And 19 BCTs were identified using the calorie taxonomy. However, what we did find was there was an average of 6.6 BCTs used across interventions. There is discussion and conflicting evidence on whether or not higher numbers of BCTs, for instance, in the challenge trial, which used 17, whether or not that number makes a difference, or is it the quality or the clustering of behavior change techniques that actually has an impact. Only 5 of the 11 studies explicitly mentioned theory and these techniques, and the behavior change techniques of prompts and cues, as here, was listed most frequently. And then 9 studies also include instructions on how to perform a behavior and descriptions on demonstrations on how to perform behaviors. We also found that there was synergistic usage, I think I mentioned it down here, synergistic usage to initiate behavior change. However, there wasn't much evidence that we could see around maintaining the behavior change. To conclude, we suggest there are 5 main behavior change techniques and mechanisms of action combinations that have an effect in physical activity and nutrition interventions. Firstly, it's prompts and cues, which is the most frequent, and that links to memory and decision making. Instructions on how to perform behavior, which links to knowledge and skills as the mechanism. Demonstrating how to perform behavior, which links to beliefs and capabilities of the skills around physical activity and healthy eating. Goal setting, which links to behavioral regulation, and social support, which links to social influence and effects. So future interventions, then, to sum up, in terms of development, reporting, and evaluation, would benefit from more linkage of the behavior change techniques to the actual mechanisms of action, or the process through which the behavior change techniques have their effects. And then that leads to more pragmatic type of interventions and applications. So thank you for your time, and any questions, I guess, come and see me later. Thanks.
Yeah. Thank you for your excellent presentation. Yeah. And our last presenter will be Fukushima Takuya. Yeah.
Okay, thank you for the opportunity to present this oral session. And I'm Takuya Fukushima from Kansai Medical University, Japan, and collaborate with Dr. Q and Dr. Eisuke. Yeah, thank you so much. The theme of this systematic review and meta-analysis is effect of exercise on physical function, symptoms, and quality of life in patients with bone metastasis. Right? This is the introduction, and the patient with bone metastasis often experience physical decline. Various symptoms, including fatigue, pain, nausea, or like this, and reduce the quality of life. And exercise has a potential to address these issues, but existing studies have not been comprehensively synthesized. So this systematic review and meta-analysis of randomized control trials aim to examine the effect of exercise on physical function, symptoms, and cure in patients with bone metastasis. Move to the methods. This SR and MA using the 4 databases from inception to December 2024. We include the RCTs published in the English and evaluate the effects of exercise in all patients with bone metastasis. This is characteristics of this review. We limited the inclusion. I mean that all patients have bone metastasis. Using physical function, symptoms, and psychological distress and cure as outcomes. This is a result. Finally, we get the 8 studies to synthesize each studies. And first, muscle strength and physical function cure didn't improve significantly, but fatigue and psychological distress significantly improvement after the exercise. So this is a conclusion. Exercise significantly improves fatigue and psychological distress in patients with bone metastasis. So exercise could be a useful supportive therapy for patients with bone metastasis. However, improvements in physical function, pain, and cure have not been achieved. So developing treatment strategies and building evidence remains key challenges for the future. Thank you for listening.
This concludes our poster session. Thank you for your attention. Thank you.
Now we start section 3. Please take your seat. Good afternoon, everyone. Welcome back. I'm Sujin Young from Professor Justin John's lab at Yonsei University. Before we begin, Professor Justin John, the chair of the organizing committee, will give brief welcome remarks. Please give him a round of applause.
I forgot that I was supposed to say a greeting word. So thank you again for coming. But then, do we have a slide ready for the organizer? Okay, can you please turn the... Yeah. Okay, as he prepared. So this session, or this symposium, is not just me who organized it. There's actually about 8 or 9 of us. We meet on a regular basis. What we're gonna have our theme on, and then who we're gonna invite. So I'd like to introduce the organizing committee members. So can you, yeah. Okay, so Dr. Jis Park, who was the head of the Cancer Prevention Center at the Severance Hospital. She was the organizing committee member, and she chaired the first session. And also Dr. Dong-Hoon Lee, where are you? Yeah, Dr. Dong-Hoon Lee. And then Dr. Ji-Yup Choi, she's not here today, but she's going to be here tomorrow as a speaker. And Kywan Lee. Yeah, Kywan. Also, he chaired one of the earlier session today. He's from Ewha University. And then Dong-Woo Kang. Dong-Woo? Oh, 없어? Okay, he's a professor from Fred Hutch now. And then he's also a committee member. And then Dr. Ji Hee-min. Yeah, okay. And then also Dr. Eun-Ju Yang. She's a professor at the Seoul National University, a physiatrist. She's a physiatrist. And also Dr. Hyo-Yeol Moon. Oh, yeah. Yeah, so these are the organizing committee member at this symposium, and I was hoping that maybe next year more people. This is not a close, exclusive committee, but then if anybody wants to put an input, you can let me know. Then we can include you as an organizing committee member for the next session, and maybe next year we're going to invite international advisor for our session. So thank you.
Thank you, Professor Justin John. We now begin section 3, Bridging Evidence and Practice, Implementing Exercise Oncology. Our chairs are Dr. Yeon-Soo Kim from the Department of Physical Education at Seoul National University and Dr. Hae-Dong Lee from the Department of Physical Education at Yonsei University. Please welcome them.
Good afternoon, everyone. It's an honor for me to participate in the Yonsei Exercise Oncology Symposium. I congratulate on the first symposium, and I'm truly impressed by its remarkable progress each year. Yeah, and I would like to express my appreciation to all of you for your participation today. Yeah. Now we'll begin the session titled Bridging Evidence and Practice, Implementing Exercise Oncology, and we will proceed Q&A session after 3 presentations. Yeah, let me introduce our first speaker. Yeah. It's my great honor to introduce Professor Nicole Culos-Reed from the University of Calgary. She is a world-leading expert in exercise oncology, exploring how physical activity can support the health and quality of life of people living with and beyond cancer. Also, she is a professor in the Faculty of Kinesiology, adjunct professor in oncology, and director of the Health and Wellness Lab and the Thrive Center at the University of Calgary. Her research has led to practical, community-based exercise programs such as ACE and EXCEL, which have transformed cancer survivorship care across Canada and internationally. Today, she will share her talk titled Evidence-Based Implementation in Exercise Oncology, Beyond ACE and EXCEL. Please welcome Professor Nicole Culos-Reed.
감사합니다. That's all I have for you. It's a pleasure to be here. Thank you to Justin and the organizing committee for having me. I'd like to take the next 35-40 minutes to speak about the work that we're doing and really about moving beyond. So what Dr. Cuernier started off with, what you've heard from others around the programs and resources that are available, to really how do we make that available for each and every individual diagnosed with cancer. Before I begin, I just want to highlight my bias that I believe exercise is medicine and that I am the co-founder of Thrive Health Services, so you'll hear more about that with our training. And I'm also a consultant with a prostate cancer center in Calgary, and you're going to hear a little bit about the program that actually runs there. While I'm the one up here doing the presenting, none of this would have happened without a whole host of colleagues, trainees, and sources of funding, community partners. It's taken a team effort. I've been at this for 25 plus years. We're still not at the point where it is a sustainable, available to every individual living with and beyond cancer, but we're getting closer. We've developed a lot of different programs. This is just some of our names of programs. I'm going to highlight a couple of them today, but everything from children and adolescents with cancer to young adults to individuals living with more advanced cancers and their support persons. So that teamwork has really resulted in a number of studies, and some of those have translated into programs with the help of those community partners and funding. So I'm briefly going to go over how do we move from these really rigorous trials, which we need, but I would argue we have a lot of the evidence, and start to move that to practice, right? To really take that next step. And then beyond that practice, these are still trials. ACE and EXCEL, I'm going to highlight and talk about a few others. They are still trials. So once they end, potentially the end. So how do we move beyond that and make sure we've got resources available in the clinic, in the communities? And then I'm going to talk a little bit more about our model and what we've done, what we've called Exercise and Educate for years, and the case for really not just offering generic, here's a resource or here's guidelines, moving beyond that. So I'm not going to go into a lot of the evidence. I think lots of people in the room work in this field and know this. We've often talked about in our lab this idea of a tug-of-war. Everything that cancer negatively affects, physical activity or exercise potentially has a beneficial effect. And so it's really this constant, you're going to ask people who feel sick to move more. When I first started out, it took me a year to recruit 10 people into a yoga trial, primarily because the oncologists were looking at me as a young new researcher and going, not a chance, you don't know what you're talking about. And fast forward to today, we put through almost 500 people every 12 weeks into our programs and resources. So a lot of shift has happened, and it's been built on the evidence. So everything that we do is evidence-based. That evidence has resulted in guidelines. So I'm most familiar with the American College of Sports Medicine guidelines. Kristin Campbell, who's in the room or was in the room, has been part of that group that led the development of those. There's Australian guidelines. There's nutrition and physical activity guidelines from the American Cancer Society. So lots and lots of evidence has been collated. If you look at the exercise oncology work, 6 new publications every day, over 10,000 studies, over 2,500 RCTs. Is there anybody in the room who doesn't think exercise is good for individuals living with and beyond cancer? Okay, so we're all on the same page. So how do we start to move beyond that? And I did a cursory look at some of the recent reviews that have come out, and this one was looking at oncology guidelines. So these are more like the practice guidelines. In Canada, our different provinces have different cancer care systems. Out of the provinces across Canada, really only Ontario's cancer guidelines have a recommendation for exercise within them. So this is really, one of our opportunities to move to practice is to go in and start to embed exercise recommendations, not just rehab, but exercise specifically into different practice guidelines. But that's, I think, still largely lacking even as the next step. We tend to sometimes, get into our silo of exercise and we talk to other people who do exercise for cancer and forget that we have to start to build this out. And using something like was introduced in the first talk today around that social ecological model, moving beyond just our target to the system around them. Because right now we kind of do a bad job of that. And as a result, most people living with and beyond cancer are not physically active. Right? You see nice numbers of change when we give them a trial, but in general, people avoid being physically active. Or it's still the old mentality of they're sick, they'll wait till later to start being active, even if we have enhanced recovery after surgery protocols that are supportive of more mobility and movement. So my argument is we need to move towards these pragmatic trials. So still good research. Okay, and this is still research and building evidence, but it's moving from what works in an ideal condition. If I build the best program and I've got the best trained professionals in our center, at the university or at the cancer center, to what actually happens in the real world. What happens when we relinquish a little bit of the control that we typically exert over our trials and say, let's put this out there and see what the effect is. And that's where some of these pragmatic trials can really start to bridge that gap from efficacy to effectiveness. And really start to go, well, the real world in cancer starts in the clinical setting, but then for most individuals, it moves to the community. I've yet to meet somebody who has been diagnosed with cancer who wants to really come back to our cancer center for wellness after they have finished treatment. They want to go to their local fitness facility, their community center, do Tai Chi in the park. They want to do all of those things and not necessarily come back to where they were treated for cancer. And so the pragmatic trials really help us kind of do that next step before we maybe build then something that people continue to want and we build the resources to develop it. There's different frameworks for doing this. The PRECISE tool, pragmatic, explanatory, continuum indicator summary is I think a good starting point. I've just taken some screenshots of the tables in that, but it really talks about this continuum again of how much control we exert, right? Do we let all comers come in? Do we keep it to one tumor group, right? How much control we have over the different interventions and the expertise to deliver it. How we're measuring things, and importantly, how we're tracking compliance and adherence. It's always this continuum. And more as we build to, okay, is this gonna really work in the real world? It's about taking, again, some of that rigor necessarily around the control, but still collecting solid data and building the right evidence. And so I wanna talk about a couple of the ways that we have done this, some of our guiding principles. And the first is this social ecological model, right? Typically, when we think about people and exercise behavior change, we target the individual. We say, okay, I'm gonna give you a prescription and you, and here's the class, and it's gonna be all up to you, right? We've set this program up, but you've got to change your behavior. And ultimately, yes, people have to change their own behavior, but people don't exist in a vacuum. They exist with influences around them, whether it's their family and friends, and if they're active or not, or they support being physically active. In the cancer care setting, they sit in the cancer care center. And so the last few talks, that's come up over and over. One of the physicians mentioned, I reinforce each time somebody comes in that they should start exercising, right? And so if we could make that standard of care, that every oncologist, nurse, physical therapist, occupational therapist, if they all recommended cancer, that would be great. But we know if they recommend it, but people don't know where to go, probably still isn't going to change behavior. So it's about building environments for them, with them, and around them that will support more wholly them being able to engage in exercise. So for us, it's about keeping this in mind as we continue to build resources, that we're not building them just for the individual, we're building them to change the environment that they have access to, and that they're supported to go into. One of the ways that we have done this, and this has been happening since the very start of my first program, is we build participant advisory boards. So we build it with the individuals, not just for them. So my very first study when I came to the University of Calgary in 2001 was a breast cancer trial called Beauty, and it was breast cancer survivors engaging in activity while undergoing treatment. And we built our first advisory board. So we ran one round of this. We recruited a few of them who'd participated to tell us how to make it better, and it continued to evolve. And I don't know what this says about me, if it's good or not, but I've essentially been doing the same 12-week program since 2001, and just tweaking it as we go to meet the unique needs of the different individuals. So the two big programs that I'm going to share with you just briefly about are ACE and Excel, and these have both been built with participants, drawn from the very beginning when we wrote the grants to what are the important outcomes they want to know about. How can we deliver them their results in a more timely manner versus them, oh, wait, they're never going to read our published trials, right? But how do we give them back their data to motivate them to keep going, right? And so our Excel is an example. The members include patient advisors that have been in our prostate program, our head and neck program, our neuro-oncology program, et cetera, et cetera. We've got participants in Excel, you'll hear about that more in a minute, but from different provinces, and we've got research team, right? So it's not just we put all the onus on our participants, it's a very collaborative co-creation process so that we're listening to what they need, we are bringing in different expertise for different questions, and then building, hopefully, what is going to be the best programming that's available for them through the studies. They're engaged throughout the process. So this isn't a sign on the line and just tell us that you did this. We have meetings with them. Some of our programs we meet every couple of months, some it's every quarter. Really depends on the needs in the program and where we're at. The basic of the program. So I've literally been doing almost the same program for a long time. It's 12 weeks, and that was really came down to a very pragmatic issue, is that most of our fitness facility partners in the community ran 12-week schedules. And so that is really how we built it. We started with an 8-week program. We had some that were a bit longer. And then as we moved into community, they all said, well, our fall session's 12 weeks, our winter session's 12 weeks. And so we built it to fit into that timeline. We do a multimodal program. So we don't just target one type unless we've got a specific study going, but typically they get all types of fitness at it. And it's really about tailoring. So all of our programs are group-based with an asterisk. Certain studies have some single elements, but they're all meeting people where they're at based on their screening and intake, so their needs. And then it's about what Dr. Cureña talked about, that relative change versus an absolute where they have to get to. 60-minute classes, really important on this one. We found this on early on, and participants kept saying to us, we want to engage more, we want to engage more. It's the instructor is paid for an hour and a half. So they are there 15 minutes early and stay 15 minutes longer, and that's all about building community, which is really central to our program. And that is online or in person, and you'll see we do both. And then our classes are kept quite small, and really dictated by the room size, but also the need to be able to tailor to meet individuals' needs. So we don't run like a Peloton online class with hundreds of people, right? We have in our maintenance programming some bigger classes, 20 to 30, but very different than a baseline class where we cap it typically about 15. So on to the trials. So I'm going to share two of our bigger studies. These are both effectiveness implementation trials. ACE was our first one. So this started in 2017. It's led by Dr. Margie McNeely at the University of Alberta and myself at the University of Calgary. This was an Alberta-wide initiative. So how many people in the room have been to Canada and or Alberta? Few of you, some of you from there. Okay, so I just looked this up. Alberta is 7 times the geographical size of South Korea, just to give you an idea. A fraction of the population, very, very small population compared to even Seoul. But it gives you an idea of the scope. So we built ACE to be across the whole province. Alberta has 2 main cancer centers, one in Calgary and one in Edmonton, and then it's got a couple of smaller cancer centers, regional ones, at some of the major urban, and you might laugh when I say urban, but urban with populations maybe close to 100,000 plus, right? And then Calgary's over 1 million people, Edmonton's a little close to 1 million, maybe. I'm looking at my team, maybe close. So small relative to here. Okay, so it was built for everybody. It's all comers. So that's one of the hallmarks of a pragmatic trial. We weren't saying you had to be prostate or colorectal or. Anybody could come in up to 3 years from diagnosis. So pre-treatment, on treatment, up to 3 years post, even post 3 years if they had a medical referral to come in. So really wide open, trying to build this for people to access. The whole goal of ACE is to build it so it would become part of cancer care. And so we did partner with Alberta Health Services right from the beginning, who said, yes, with success, we will help you embed this. Spoiler alert, that hasn't happened. COVID happened, politics happened, and it didn't become embedded, but I'll tell you where we're at. So Margie's leading the data analysis along with the clinical trials unit at the University of Alberta. There's the number. So ACE was going and then COVID hit, which put a huge disruption. We switched to online delivery within 2 weeks of COVID hitting. So we have an ACE data set that is people that did the in-person programs at urban centers across Alberta. And then we did an online that started with COVID. We still run both. We run both in person and online. So you can see the population here, lots of breast cancer, most half on treatment. We had some people pre-treatment, a lot of people completed. Important to note, a third of them were more advanced cancers or metastatic disease. So this was all comers, really built as a program that was going to be implemented in the community setting. And I think that's an important piece. You can see we have high completion of the program across the attendance rate. Attendance was really impacted by if they were on treatment or not. So we see above 94% attendance when they are completed treatment and a little bit less, but still pretty good for when they are actively undergoing treatment. You can see some basics here. So I should say Margie's just in the process of finalizing some of our initial effectiveness data. And so hopefully our publications will start to really roll out over this next 6 months. But one thing I do want to highlight was that if people were undergoing chemotherapy treatment, we didn't see those significant changes. And I think that's really important to note. When people are undergoing treatment, they feel sick. It's really hard to exercise at levels that we might see improvements on, but what you do see is maintenance, right? So instead of these significant downward impacts of having the treatment, we see a slighter decrease or them staying at this level, which allows us to help support them to recover more after. So the success of ACE led us to build a team grant. It's called a Cancer Survivorship Team Grant funded by our CIHR and our Canadian Cancer Society to basically start to address one of the biggest gaps in the research. And that was all of our exercise oncology trials serve people from urban centers. That's where the access points really are. And so we built Excel to reach rural remote individuals across Canada. So if you know how big Canada is, coast to coast to coast, this was a pretty ambitious team. It included a great team from across the country to see how we could start to deliver this. We wrote and got the grant in 2019. COVID hit in 2020. Luckily, we were delivering a lot of this online. So it hurt initial recruitment, but it allowed us to keep delivering the program. And the program model is really built on this hub and spoke model, taking our urban expertise and then making connections to our rural remote communities, and very importantly, developing qualified exercise professionals, QEPs, outside of our urban centers to help us deliver the actual programming, whether it be online or in small areas. We did have some in-person programming. So the key piece here to connect with the cancer centers was our clinical exercise physiologists, and I'm going to come back to their important role. We have published our protocol, an interim analysis, and then very recently, Dr. Jonathan Lowe has led our baseline characteristics, and that just was recently accepted for publication. And we are currently, as we speak, working on the effectiveness data, so looking at our full data set pre to post 12-week intervention, so that will be coming out soon this year. Right, Jonathan? Yeah, okay. Excel numbers to date. So this is rural remote across Canada. So pretty big numbers in terms of reaching a really typically underserved population across the country. You can see where our hubs were. So Kristin Campbell here leads the hub in Vancouver. Myself and Margie cover Alberta. Ontario, we have Danielle Santamina and Linda Trin. Quebec, so we are a bilingual nation. We've translated everything into French as well as English. So Isabelle Doré leads out of Quebec. And Melanie Keats leads all of the maritime provinces from Halifax, Nova Scotia. So core teams, primarily at academic institutions, and then leading the outreach, the recruitment of potential participants from across provinces and territories. Now here's where we get to, does this matter beyond the trial? And so both ACE and Excel have gone from being an effectiveness implementation study or trial to how do we make this a program that continues to exist. So in spring, just like we've done with ACE, and I'm going to come back to ACE in a second, but in spring we took our Excel measures, we keep the screening, we keep the intake, because that's what allows us to safely see what people need, but we've narrowed down our patient-reported outcomes, which can take a lot of time. And so we have a smaller data set capturing the core measures that we need, and we've moved into program implementation. So over the next year, we will test those measures, we'll be able to compare them to the full data set and really see, can we do this? Gathering information that we give back to participants, that's the key. Yes, it'll be nice data, we will publish on it, but it is, what does a person need to know to motivate them to want to continue? To see where their changes have been, and really importantly, to see where they have room for improvement. So as we start to do this and think beyond even these very pragmatic trials, moving to programming, these are really the three guiding pieces that we continue to use: screening and referral, community integration, and the importance of that professional role. So I'm going to briefly talk about these. So, screening, how do we get this to happen? We've published a couple variations of this. The first one was with Daniel Santamina. This latest one was with Loren Capozzi, a very good colleague of mine who's now in BC Cancer Care with Kristin and teams. But it's really about how do we move people from the point they're diagnosed, right? We have this a teachable moment where people hear they have cancer and maybe are ready to make some behavior change. We also have them in a setting where we can access them, that clinical setting. If we don't reach out to them, touch them at that point in time, it can be really hard when they're back in the community to recruit them into programs or studies. And so for us, this is really a screening piece that we've developed. We're actually at the top point looking at this new tool that Loren and I developed while she was doing her kind of a residential postdoc. She's an MD PhD. So we've got this new screening tool that we're implementing. But really what I want to highlight is down here. And this role, again, you've heard me say it once, the clinical exercise physiologist. In Canada right now, we do not have CEPs embedded into cancer care. Okay, we do in cardiac rehab, I work in transplant medicine, we've got lots of CEPs there. Cancer, which is our largest chronic disease, does not have a CEP embedded in the system, fully paid for by the system. They have my CEPs through grant funding. That ends as soon as a grant potentially ends, right? And so we do not have that fully embedded, and that is for us the key piece so that we can support the clinical team if someone, all people, get referred to exercise and then get access to resources. So that CEP comes with the need to train them. Okay, a CEP training doesn't necessarily understand or have background in exercise oncology. There's been a couple of calls to action to really say, in cancer care, this is what we're missing. We have to start to train these individuals. As I mentioned at the beginning, my conflict of interest, we developed a training years ago to start to address the need that we just saw in our own programs, to have a workforce that could work safely and effectively with this population. So go back to that social ecological model, right? This isn't about intervention for the participants. This is building the environment around them that can deliver those interventions safely and effectively. So for us, the clinical exercise physiologist or the registered kinesiologist is really the critical piece. In Canada, and I know this is similar in the US, the educational requirements are that kinesiology background, and then they have the scope of practice to screen, assess, and prescribe exercise to medically unstable populations. Okay, different than a qualified exercise professional teaching in the community who could be a group fitness instructor. They might have come with an aerobics background, a swimming, aqua size background, all sorts of different things. Both of these roles are important. For us, the CEP is the link in the clinical setting from the care team to then the exercise programming. Depending on the needs of the participants, the exercise programming can be delivered by a trained, qualified exercise professional. They don't have to be a CEP unless they're working with the high-risk population. So in our programming, anybody high risk, advanced disease, metastatic disease, bone metastases, they all work under or receive a program from the CEP versus a qualified exercise professional. So our training is very comprehensive that we offer to our team. It includes this background information, doing our online modules, and then they attend project-specific training. So ACE training, Excel training. We did a ACE Neuro program. We have a new ACE dose study starting. They will all receive this very specific training pathway before they start to moderate. So they shadow a more seasoned professional, and then they start delivering a program, and then we do fidelity checks to make sure they are delivering the program in the way that we've developed it to be delivered, which is really kind of this last piece of moving evidence to practice. And I love this quote from our participant, and I swear I will not fully retire until I see this happen, where I don't hear from people who say, oh, I wish I'd known about this. Right? There's no reason we should have people in our cancer care system who don't find out about the value of exercise. There's no reason, but it happens still all the time. So what are we doing beyond the trials? So ACE funding ended years ago now. We've kept it running in Calgary. So after our very first ACE group of 12 participants, they said at about week 8, they're like, you can't stop us at 12. We love this. What can we do to keep going? So we developed our maintenance programming that very first year in 2017, and we've run it continuously since then as a fee-based program. That's the only way we can make it sustainable. Right? We don't have funding at that level to keep everybody going through. We see in Calgary area classes about a 70% uptake from our baseline program into maintenance. So pretty good numbers. We track everybody in ACE out to a year, and we see very good physical activity levels in general. So some people do their own thing, which is fantastic. We never were meant to actually make them dependent on us. Our goal is to make them as someone who sees themselves as an exerciser, independent. And if they just happen to love the community that they found in ACE, then that's fantastic. So you can see right now what we delivered as of fall was 55 plus classes around the Calgary area. Baseline are people brand new to the program, so they have no fees. We have been very generously supported by Cereris, which is an oil and gas company in Calgary, for the next few years. So that allows us to run the baseline class, and then the maintenance class is fully sustainable. It covers the cost of our instructors, it helps to subsidize our CEPs who do all the intake and screening, and allows us to deliver it with our community partners, which is absolutely key. Without our community partners allowing us to train their fitness professionals to deliver it, we wouldn't be able to have the scope of impact that we have so far. How they deliver it is the key for me, and it's exercise and educate. So it's about moving towards maintenance and this idea of, can we keep them going? Hit the 3 years that challenge trial saw, right? And keep people engaged. And so we really train our qualified exercise professionals to reinforce a positive motivational climate and support the behavior change of the individuals through these tenets of health coaching and motivational counseling or motivational interviewing. Exercise and educate is the way we look at the class. So for me, the actual program isn't about the exercise. No offense to all my exercise physiologists, friends, and colleagues. It's really a moving support group. It's about building this community where individuals gather. They're not talking about their cancer. They're talking about their grandkids or the trip they want to go on or things they found that helped them. But it's really not about the cancer. It's about living well. It's about the talk you heard this morning, the Salutogenesis, that idea of focusing on wellness. It's about empowering them to make this choice to then live as well as possible and giving them the resources. So it's easy to say I can make a choice, but unless you're supported and have the resources to reinforce that choice, it can be really hard on top of everything else. So we have very strong component of our training that focus on what goes on up here, not how to teach a squat. We take people that are already fitness professionals, we're teaching them how do they build that environment to really support people. So when we saw, and there's a post over there on behavior change techniques, over the years, this is the core of what we deliver, not as extra education, embedded in the class through how the instructor teaches it. So additional resources for sure. We've got tip sheets and handouts and all sorts of things they can access, but it's about talking to it. You know, weeks 1 and 2 in our class, we're talking about the principles of exercise, and then we get into goal setting. And then we talk about barrier management, because it's not going to be easy the whole way through. And then we talk about motivation and how do they build their confidence and trying new activities and the way that we encourage and engage with them to do these activities. We've got some really neat studies that will be coming out around the BCT engagement, the fidelity, the enactment of it, and people do they recognize that they're receiving it, right? So there's a lot of different components to it. The other thing I will say around this is that this is the central core, but depending on the population, we may add in other elements, and that comes from those participant advisory boards. So fatigue, nutrition, lymphedema with our breast group, these are all been topics they've asked for more information on, so we'll develop the resources. And so this really is what it's about. This helps to build the community, that supports their engagement, and that builds them towards maintenance. The positive motivational climate really is about all of these elements. So if you know health coaching at all or motivational counseling, there's a lot around that, but this is really how we approach the classes. About supporting participants to see themselves as movers, first and foremost, before they might see themselves, if they ever do, as exercisers, right? So taking away sometimes some of the language that might be a barrier to them, right? If I've just been diagnosed with cancer and I've been sedentary for years, do I see myself as an exerciser? Probably not, right? And so it's really about working with them to build this connectedness and this positive, supportive environment. The tenets of health coaching is really that relationship. So all of our programs are group-based, other than we've had a few that have got some individual sessions, but they're group-based to harness the power of social support, but to build those relationships with that instructor lead that they feel and can build their confidence and feel empowered. And then that big part is the education. So we've developed a whole host of resources. These are all available for free. You can take them, you can add your own logos to them, you can use them, improve on them, share them back with us. We've had these translated into many different languages around the world by teams that are using them. We've got a wellness manual. We've got, I don't know, probably 50 infographics, tons and tons of resources that participants have asked for that we've developed and co-created with them to really reinforce and support their exercise behavior change. One of the ones that we use a lot, and we really probably should publish this more, but we use our red light, yellow light, green light system. One of the things we heard early on was people said, well, if I can't do it, then I won't do it at all, right? And we're like, yeah, the beauty of exercise is we can tailor any single day to you and meet you where you're at. And so when we give them a program, this is an example of what they actually get, we give them their red light, yellow light, green light based on their intake. So we say for them, on your worst day, your red light day, you know, here's some options. You don't have to do nothing. You might do a little light stretching. You might do some toe taps. You might do one sit to stand, whatever it might be. On a mediocre day, average day, here's your yellow program. And then on a great day, here's what you can do more, right? So they're taught this at baseline. So they're empowered to make their own choices as they go through and adjust based on their fatigue and energy levels. And then as they move into maintenance, they've got this whole resource with the pictures, there's videos, there's YouTube channels, there's all sorts of things. There's our YouTube channel, lots and lots of videos on here, our 12-week programs on here, our 12-week yoga programs on here, our South Asian Punjabi programs on here, our Cantonese program, and individual exercises as well. So they've got all these resources once they start to continue to reinforce their behavior change. Still not sustainable. I'm not gonna share it's all rosy and this is perfect and we've got it all figured out. I think the key piece as we move towards implementation, when cancer care keeps telling us, sorry, we know exercise is great, but we're not gonna fund it, is we're working with community partners. So just to wrap up, I think I've got like 3 minutes or so left. I wanna highlight some key community partners that are allowing us to deliver this sustainably in the community. It's not my grant funding that's doing it. They're paying for the programs. The first one is Wellspring, Alberta. This is an amazing organization, and I was fortunate to help them develop their Exercise and Educate program. And so that is a program that runs, they pay their facilitators, the instructors, to deliver the classes, and they run 9 to 11 classes a week for anybody diagnosed with cancer or support persons. So it's a small reach. There's 2 physical locations in Calgary, then online, but slowly growing over time. The second one I'll highlight is our peer program. So this is our pediatric program. And we started this a number of years ago with Dr. Carolina Chamorro-Vina, who was a postdoc with myself. And we started it, and it was literally Carolina and I and 2 children showed up at the first session that was at our Alberta Children's Hospital in Calgary. Fast forward, PEER is now run, fully funded by Calgary Flames Foundation and Kids Cancer Care. That's the support organization for pediatric cancer in southern Alberta. And they run, you can see there, 3 different programs now. They have hundreds of children who come through the program every year and engage in all sorts of things from our PEER program to, the camp activities they have and all sorts of others. So we still are running a current study looking at on-treatment and online delivery, but PEER is a fully sustainable resource with Kids Cancer Care that's based on our research and collaboration. We still do all the training, so every volunteer, every new person that comes in to lead PEER is trained by our group, and then their team does the implementation. And then the last one I just want to briefly highlight is the new prehabilitation program at our prostate cancer center. So I was fortunate, I've worked with prostate, it was my very first big grant since 2002. And that team has always had this education pathway. So every male diagnosed with prostate cancer comes into an education series. And they started to notice this gap was there was nothing really for them pre-surgery. And so we developed this prehab pathway, which you can see here includes a very comprehensive opportunity to support men as they start to go through the treatment trajectory. So not waiting for our exercise program, ACE or Excel, after their treatment, but starting them in sooner. So there's mental health supports, the group exercise class, a way for them to access this portal to self-care, a yoga for their pelvic floor health, caregiving resources, and then counseling. So they have this whole suite of opportunities. They're all screened. They all come into the exercise class. From there, they access the other pieces as they feel needed. So nothing's mandated other than come in and do the exercise, but then it's then up to them to attend and come to the classes. But this is a great example where it's not research funding. It is fully supported. It is part of their clinical care pathway. Important to note, the Prostate Cancer Center sits outside of cancer care in Alberta, which is probably how it got to happen, and they agreed to do it. When we were starting this, they envisioned it being a nurse who did the intake and screening. And so I convinced them to, hey, how about we pilot this idea of a CEP as well? So it's a really dual intake with a nurse clinician in prostate cancer and the clinical exercise physiologist. So they're all screened at intake for their physical activity levels and then right into the exercise pathway. And then this feeds nicely into ACE or Excel, depending where men are, for their long-term access to exercise resources. So I don't know if this little video is going to work, if you can turn it on back there, but I thought we'd share a voice from a patient. This recently came from our work in Excel with a patient that was in Halifax. I don't know if I can play it, or if at the back you can play it. Oh. It might not work. That's my technology. I try to embed the video in that. It's just, I'll give you the brief synopsis because I know I'm right out of time, but this was a very interesting interview. They were profiling the Excel program out in Halifax, where really there's not a lot of exercise oncology resources. And this was a woman diagnosed with advanced ovarian cancer. She was offered MAID before she was offered exercise resources. And that's what she brought up. So when she came into the program, she was offered medical assistance in dying program. She was like, I'm not ready to die, even if I have advanced cancer. Found out, saw an ad for Excel, contacted our Calgary group. We put her in touch with the hub out there. She went from being wheelchair bound to a year later, she's working out in the gym and living with her cancer and living well. So her voice tells it a little bit more eloquently than I did, but that just shows the impact of making these resources available. And so with that, I'm going to end it. I'm happy to join back later with the panel and answer any questions. Thank you.
Thanks, Nicole, the wonderful talk. So I have one suggestion before we bring in the next speaker. So that is before we taking care of a cancer patient,
why don't we take 1 minute to take care of yourself? So because you are sitting all day, so why don't we stand up and stretch your back, and I will bring in the second speakers. Yeah. 예, 김수 교수님. 예. Okay, are you okay? Yeah. Okay. So let's move on to the second talk. So our next speaker is Professor Soo Kim from the College of Nursing at Yonsei University in Seoul, where she's a professor of nursing with the program of research focused on cancer survivors, survivorship, cancer-related fatigue and exercise adherence, return to work and family adjustment, and hereditary breast and ovarian cancer communication. So today, she will talk about applying sallutogenesis to hereditary cancer. Please give welcome Professor Soo Kim.
Thank you very much for the kind introduction. This is actually a session on bridging evidence to practice and implementing exercise oncology. But then you look at the title and you go, how does this fit? I had initially intended to start the presentation by talking about how exercise can help patients with hereditary cancer, meaning I have already had cancer. That's how I discovered I have this gene mutation, but then also to share it with my family members. How can exercise help? That was my intention. However, when I looked at the literature, there was basically nothing. And then I realized, even today, I shout out to all of you, like Nicole, the excellent work that you've done. If you can look at your population again, your participants, to see what percentage of them have hereditary cancer. And is exercise making a difference in their lives? And also, how does that impact their family relationships? I think that would be an awesome next step for challenge as well for Dr. Cuernia. Anyhow, so I decided to pivot to the topic close to my heart nowadays, which is hereditary cancer. So you may be aware of Angelina Jolie and the BRCA, the BRCA1 and 2 gene mutations. This particular picture is about where, particularly in the chromosome, those mutations tend to happen. But hereditary cancer is not just about breast and ovarian cancer, like Angelina Jolie. It also has to do with Lynch syndrome, which is a percentage of colorectal patients as well. And because it's an autosomal dominant, which means you can pass it on. I got it from my parents, 50 to 50% chance. And then now I'm going to pass it on to my children, and my siblings will also probably have been affected with a 50 to 50% chance. So today my talk will mainly focus on HBOC, but also it will, some of the studies I mentioned will include Lynch syndrome. Just to give you a brief about why this topic is important and relating to exercise and the power of harnessing that energy, is that it's easy to identify. It's number 13 or number 17, there's a known risk, 50 to 50%, male or female, to blood relatives. The key point is it's actionable. It can be useful information. So if you know you have the gene, you start to go for cancer monitoring, surveillance earlier than usual. And then they offer risk-reducing surgeries, which can be very drastic and life-changing, but it does, in effect, prevent cancer from arising. Because basically, as you see down here, you have a very, very high risk compared to like 1 out of 8 women will get breast cancer. If you have the gene, the risks go up exponentially. Even for male breast cancer, 0.1% in the general population. However, if you have the gene, it's so many more, such a high risk for prostate and pancreas. So actually for HBOC, there's a movement or a consensus that we should change the name to HBOP because now we know that it's related to prostate and pancreatic cancer as well. So it's not just women. There's a public health implication. So there's so many cancers that are related. If you have this gene, you're apt to get not only the same cancer in the opposite side or related side, but you are also susceptible to all of these other types of cancers as well. And another public health message is, if you are found to have the gene, at least 10 members of your family will also be related or under the umbrella of needing this kind of information. So that's a big public health message. If you can prevent cancer at such a level, tenfold, not only personal cost, but also public health and country level cost issues. So HBOC and Lynch syndrome are important. Again, I told you that if you have the pathogenic variant, and most people find they have this gene after they get cancer, if they meet certain criteria, you're offered the test. If you're found to have the gene, your first-degree relatives, half and half chance, but then your second degree, which is like your aunts, your nephews, nieces, 25% chance. Even third-degree relatives like your cousins, they still have a chance of being exposed and having the gene, but we don't know unless you get tested, right? What do you do if a pathogenic variant is found? Like I've been telling you, we can have close follow-up. There's risk-reducing surgery and lifestyle changes and certain medications that can help. Among the lifestyle changes, many patients are interested in exercise and diet and sleep and stress management. However, we have very limited evidence on what that does for hereditary cancer. The risk management will start early at 25 years old or 10 years from the earliest a cancer that they got at that age. And your family members, if they don't have the pathogenic variant, you can exclude them. They can just go for cancer surveillance at the usual general population age. And then finally, it can really ensure adequate coordination of the care that people need. But the reality is people struggle to navigate the path and paths. So I thought I was walking just my cancer journey, but then all of a sudden I feel like I have this divide in the road where I'm supposed to walk both paths at the same time. I have to juggle my cancer treatment decisions on the left side, but then I also have to talk with my family about this gene, what it means to me, go for follow-up, try to follow up with people who are avoiding my information, my family members trying to persuade them. So it's a double journey. Many of them talk about negative emotions at first, confused, uncertain, very burdened, fearful. Sometimes we do see people who say, we had a lot of cancer in my family, so I kind of suspected something was going on. It's kind of a relief, and now I know where to go. So they have some clarity, but it's not the majority of cases. And to go to acceptance, it's really taking a long time. But if you look at family disclosure, how do patients share this information, or do they share the information? Most of the laws all across the world say that healthcare providers are not the ones to break the news. It's up to that index case, or the proband, as we say. If you got the news, you found out you have the variant, you are the one who are supposed to tell your family. If you look at the studies that are out so far, a lot of it is still skewed. People do tell their first-degree relatives, their parents or siblings or children, but it's skewed to women. Also, it's limited to first-degree relatives, so very few other out of that family contact will get to know that information. And this is for HBOC and Lynch. What about in Korea? An old study done in 2011 found that many of them do talk about it, but again, you can see that very limited sharing, less than 1/3 to other family members aside from your close, immediate nuclear family. A more recent study done with ovarian cancer patients show a slightly different picture, but still discouraging rates beyond first degree. So again, it's mostly first degree relatives who are told, and there are huge gaps in informing other blood relatives who still need the information. So then what can we do? We know that there are many barriers at the individual level, relational level, and structural level. And they're multifaceted. But then we get to think, my team and I, we're trying to create a digital health intervention to help these patients on all three levels of the barriers. However, how are we reframing the family disclosure in cascade genetic testing? Cascade genetic testing meaning if you're found to have the variant, you were hoping for a cascade, an overflowing effect where a family member will be tested. If my brother gets tested, he has the variant, his children should be tested, right? So it's like an ongoing flow. However, I realize that, and a lot of clinicians also say this, it mostly seems to be a risk-based approach, which is enacted as a threat-based approach. So in essence, what we're doing here, one of the slides is missing, it's okay. Think about like cigarettes, and you'll see these advertisements where they show these horrible pictures about, cancer in your larynx or throat. And they're a threat-based approach. They try to scare people into doing things. So if you don't do this, you might get cancer with this high risk. But thinking about today's morning presentation too, how about a salutogenic orientation? Is that possible in hereditary cancer? Is it a potential way to reframe our approach? So we did a search of the literature, and initially I had told Justin that I would try to do a scoping review. Lo and behold, we only found 3 studies, and they're very, very old studies, as you can imagine. And I think it's because we're not looking into hereditary cancer enough. But the most recent one was in Denmark in 2013. The other one is in Norway, 2007, and in Israel, 2004. The sense of incoherence and self-concept in Lynch syndrome was the most recent study that was done. So you can see here that sense of coherence increased with age. They compared the general population with people who had Lynch syndrome. And in both groups, as they aged, the sense of coherence was better. However, the effects were more pronounced in the carriers, in the older carriers. They looked at it with self-concept, and you can see that that the Lynch syndrome subset had a slightly higher score compared to the general Danish population, and different cutoffs as well. So there was a similarity in this sense of coherence of scores at large overall. With self-concept, and it correlated well, moderate Pearson correlation coefficients. So stigma and vulnerability seem to show a similar pattern within the self-concept. And they suggested that this could reflect different effects from knowledge about hereditary cancer. If you look at the actual bowel anxiety, bowel symptoms, this was a little bit weaker correlation, but still statistically powerful. The second study was with genetic counseling and how does cancer-related distress change. So the basic hypothesis was a buffering effect, that sense of coherence would mediate or moderate cancer-related distress, but also perhaps have direct implications for negative emotions. Looking at the possible score range, you can see that most people had a generally more than moderate effective sense of coherence baseline. Cancer-related distress was not that great. Hospital anxiety and depression scores were not that particularly high either in this sample. However, more of them experienced anxiety compared to depression, and a significant interaction was found between sense of coherence and distress in relation to depression only. Looking at it again, you can see that especially meaningfulness under one of the subcomponents of SOC was meaningful in anxiety, depression, and the overall score as well. But the study said they could not conclude that SOC is a moderating factor of these negative emotions. However, the interaction was significant for depression, and they suggested it could be helpful in identifying individuals with hereditary cancer who may be vulnerable to anxiety or depression. And then they suggested, and it was mentioned this morning, that positive measures of health could probably be, should be included. They were only focused on the negative emotional aspects. And then the final study, they just briefly tuck in a sense of coherence and give the results for carriers, for their family probands, and then also people who have had cancer. So I don't want to make a whole lot about this particular study in detail. But if you look at these 3 studies, although they are old, you can see that it's related to self-concept, especially depression. And in Lynch syndrome, at least, it seems to be higher. SOC is higher in older adults. And if we assess it carefully, it could help us identify people who may need to be followed up and maybe have more promotion or implementation for interventions for SOC. But you can see that the numbers of studies are very, very small, lack of ethnic variation, and they really don't reflect the lifelong nature of the clinical management that requires genetic care, and it requires engagement from all of us. So I really enjoyed Nicole's talk about the motivational counseling and then the health coaching, which is a big part of how we keep people engaged and moving, right? So then it moves me on to the next remaining questions. And here, this presentation is more about me voicing out loud my thoughts about, is it still usable? Or how can we make it usable? Why hasn't anybody done studies after 2013? What can we do? Why did so few studies continue to utilize SOC? Is this an indication of the need for further conceptual development or clarification, particularly of how to use the subdomains, especially about meaningfulness that was important in one particular study, but how can we capitalize and also clarify this concept for use in clinical intervention? Or are we simply measuring the sense of coherence by instruments without using or having an appreciation for the salutogenic orientation that actually should underlie it? What are the practical or pragmatic use of sense of coherence? It's not being used to encourage, it's not encouraged to be used for screening purposes. There seem to be some interventions out there to strengthen SOC, especially in cancer patients, but I think we need more evidence for that. Other remaining questions. In this population, it's basically two axes. One is, are you communicating your genetic test results to family members, giving them a chance for action? And the second is, are you following up with risk-reducing measures with your clinician? And I think considering that salutogenic orientation makes much more sense than trying to scare people and make them motivated to continue coming up for follow-ups. How can we use it on the left side from the provider messaging it and how to frame the message for patients, not just as bad news, but then it can be useful news for themselves and their family, but also for patients to relatives. A lot of relatives, they avoid the topic, they ignore, or they get angry because there's a lot of cultural stigma, especially here in Korea, about something in the gene running through your family. It just makes it a bad situation for the family in total. So there's a lot of cultural things that we find from our comparative work with Switzerland and Israel. But how do patients relate that information to relatives? How can they take on a salutogenic approach? And is it just like an attitude, having an upbeat attitude, or yes, I'm thinking about the health of my family, but no, if you look underneath, they're really more worried about other things. Family saving face, how they think it's an individual choice for family members, which is true, but then how can we use a salutogenic model for that purpose? On the right side, does the salutogenic orientation align with making these decisions about risk-reducing surgeries? Or do they actually collide with it because it's such a dramatic or drastic measure? Another thing that was mentioned this morning too was the shared decision-making model. And I think this is another case where people use the word a lot, but they don't really understand the important tenets and the basic assumptions that are needed for SDM. So you can think that you're doing shared decision-making, but you're not really following all of the important steps and covering all of the ground. How fully is that going to be SDM? And I think the same thing with especially risk-reducing measures. We can think about an attitudinal or an orientational salutogenic model, but do we really understand it clearly enough and communicate it with clinicians and among researchers to have this make an impact and be researchable? So that was just me musing about everything. So before, I think the emphasis was on cancer, which is a threat-based approach. You're going to get cancer if you don't do this or that. However, I think if you apply it, it's the here and the can that should be more emphasized, but not in an abstract manner, as I'm just saying, but really to be spelled out and clarified through further research and discussion. Thank you.
Thanks to Professor Kim. Another stretching before the next speaker is preparing for awesome talk. Yeah. So. Need more time? Yeah. So I attended another conference, and sitting long day, all day, influences your blood flow. So it's very bad for you. Yeah. So especially this kind of conference, you all sitting all day. Sometimes you understand, sometimes you don't understand. It's sleepy, so you need to move a little bit. Okay, our final speaker of this session is Jonathan Lowe, postdoctoral fellow at University of Calgary's School of Medicine and Faculty of Kinesiology, specializing in exercise oncology and cancer immunotherapy. He earned his PhD in kinesiology from UBC, focusing on exercise metabolism in type 2 diabetes, with extensive publication on digital health and wearable. Please welcome Dr. Jonathan Lowe.
Thank you very much. That's very kind of you. And I'm not going to speak anything related to my PhD today. And a little bit about the postdoc work that I'm doing, but more along the lines of this idea of implementation in exercise oncology. So really quickly, by a show of hands, how many have used the idea of self-report physical activity in your clinic or your research? Okay. And on the flip side, how many have used some sort of fitness wearable or wearable technology in the clinic or in your research? Okay, so some familiarity with what I'm going to talk about today. And it really is based on that question of thinking about when we are looking to try and get to this root of exercise oncology and implementing this in whatever setting, how do we measure physical activity, and how do we know that what we're getting in a measurement is the right thing? So similar to what Dr. Culos-Reed talked about, I don't think I need to spend much time convincing those in the room the importance of exercise oncology and the importance of exercise for helping those living with and beyond cancer. But there is this statistic that is really startling that suggests that 75% of individuals decrease their physical activity levels after a diagnosis. And so that's cause for concern, right? And so maybe those of you who have tuned out and are tuning back in, realize that this is something that we need to talk about, and I think a shared aim between all of us that we are aiming to try and improve the levels of physical activity and exercise. Now that's not the focus of my talk, but the focus of my talk is how can we measure this to know if we really are increasing the physical activity levels or the amount of exercise that somebody is getting. But the challenge that we see, and maybe those of you in the clinic or researchers, is that getting this 24-hour picture is really challenging because maybe somebody might have an active job, or maybe they might actively commute to work. Maybe in their brain that's not necessarily physical activity if they're filling out a questionnaire. Maybe they might take their dog for a walk or go out with friends and go for a walk. Maybe they might do gardening after work or play with their family before bedtime. So there's a lot that goes on in a 24-hour period for individuals, right? And capturing that whole picture can really be a challenge for those of us in the research space, but also for clinicians. So there's two ways that I'm going to highlight today, and for those of you who raised your hands, you're probably familiar with them, that we can try and capture that picture. Now, wearable technology has been increasing exponentially in the past 20 years with the advent of pedometers and accelerometers that are now quite low cost. You can put them into basically anything, into a t-shirt, into your shoe, but most commonly into a watch or a ring or a necklace to be able able to measure movement, right? And various companies have different algorithms that process that information differently. But at the end of the day, wearable technology is an avenue that we could use in exercise oncology, or can use or are using, to be able to try and capture that picture of the 24 hours, maybe in a longer period. Now, you might be thinking, okay, that's all great, Jonathan, but what if people don't wear it, right? And we're going to get to that, so just hold on. But on the flip side, when we think about self-report physical activity, obviously this is a really important consideration when it comes to time and cost. If I'm going to buy watches for a cohort of 2,700 people in the ACE cohort, that's probably not going to fly for a CIHR grant, right? So a time and cost-efficient method is self-report physical activity. Similarly, in the challenge cohort, in what we do for Excel, these are large cohorts, and to be able to implement these wearables can be a challenge. So self-report really helps to fill that, among others. So we have this technology, and so there's certainly pros and cons to both. I've alluded to a few of them, and I'm sure that a lot of you could raise your hands and tell me some good and some bad about each method that you've used. But when we think about self-report, for example, we have that idea of recall bias, right? So if an individual can't quite recall, or maybe they think, well, I walked my dog, but that's not really, on what I would want to capture. Though for example, the Godin, which is a method of self-report, it's a questionnaire, is quite specific in what it asks individuals. However, there could be things that could be missed, right? And maybe am I influenced by what the researchers are expecting from me? But then on the flip side, obviously with wearable technology, will I remember to wear it? First of all, wear time is a huge thing. If you've read any literature in terms of accelerometry and wearable technology, if you've ever sent a paper for review that includes that, wear time is a huge consideration. But then also, influencing wear time, if I don't like the style of the band of my watch that they give me, I'm not going to wear it. As part of my PhD, we used accelerometers, and the accelerometers we used were Genia Actives, and they basically look like a house arrest bracelet. They're not style, they're not fashionable, they're not stylish. So getting people to wear them is a consideration and is difficult. Though if you can, there's a lot that you can capture in terms of heart rate, steps, maybe a little bit better picture of sedentary behavior. Now, when we consider this in the context of the entirety of our society, but specifically in the clinical setting, in the research setting, here's a little picture that tries to get at what that could look like, right? So in a clinic setting, we can look at different types of sleep and maybe posture. You can look at vital signs. Similarly, in the research setting, it gives us the ability to look at what is going on if we think about wearable technology. Now, when we think about this measurement of it, you can see here that similar to some of the stuff that we do in Canada with our large geographical location, we've got a lot of remote work, a lot of people that live in remote locations. So using things like wearable technology allows us to be connected with them and to monitor. Similarly, with a self-report, being able to send out a questionnaire via an online link also gives us that ability, right? So we're making progress and hopefully getting better at measuring. So what I wanted to do with this kind of foundation is dive into two studies that we have done, or that have been done in Dr. Culos-Reed's lab, and be able to compare. So there were two studies that administered the self-report questionnaire, the Godin, as well as had individuals wear a wearable technology, a watch. And so I went in and tried to compare those two to see what the agreement was, to see if there was one that was better than the other, or how they did agree. So this first one, I think Nicole alluded to it in her study, or her talk earlier, but this was a study in individuals living with and beyond head and neck cancer. And this was measurement points before and after operation. And they wore the Garmin VivoFit 4, that's a type of Garmin, which is a fitness wearable that captures heart rate and steps, again, according to the algorithm of that company, and that's a big caveat. But then comparing that to the gel tech is what I call it, but it's the Godin. The leisure score index is what I pulled from that. And we had 8 individuals. There was a larger study. They had around 60, but there was 8 individuals that had complete data across that enabled me to look into it. And so you can see here, bear with me and I'll help you kind of digest these plots, but this is where on the y-axis I've got the objective, so Garmin steps, and down here you can see I classified low physical activity, and this is just for the purposes of comparing, 0 to 5,000 steps. Medium is 5,000 to 7,500, and then high is greater than 7,500. And with the Godin LSI, these are pretty standard, but low was 0 to 14, medium 14 to 24, and high was greater than 24. And so you can see the agreements here pre-op was around 63% between the objective and the subjective, or the self-report. Now again, this isn't necessarily one or the other is gold standard, right? But just for interest's sake to look into, see if you do decide to use one or the other, what could you be missing? And then post-op, again, we had about 25% agreements between the two. And so, again, if you're still thinking, what the heck do you have going on in these plots? You can see that this is where the agreements is. So if it's low and low, that was considered agreements. And then similarly with the high and the high, and then the medium and medium, if there was agreements, would be there. So that was an interesting finding. Again, considering the decrease from pre to post-op, what could be going on there, a lot to be looked into more about what could explain that difference. And then in this study, so this was building, as Dr. Culos-Reed alluded to earlier, on a study that we did off of ACE, which was called ACE Neuro, and these are individuals living with and beyond neurological cancers. And this was before and after a 12-week exercise intervention, which you are now fully educated on. And similarly, there was Garmins that the participants wore. We had 37 that had complete data for Garmin, but then also for the Godin. And we saw similar classification, but then again, some similar areas of agreement. So this is pre-exercise intervention, around 50%, and then post-exercise intervention, 41%. And this is an interesting thing to consider, again, a little bit more that I need to dive into, but we know with mental fog and cognition, which is usually a lot of people living with and beyond neurological cancers also live with that, recall bias is an important consideration. So this was an interesting thing to look at, but again, really trying to pull out those differences. So you can see that there's good agreements on the low, classified in the low, but then when we get into the higher, it is a little bit more varied. And again, that's based on the classifications that I set here in the bottom left corner. So in summary, there's a lot to consider when we're thinking about measuring physical activity, but there's a lot that we need to maybe be unified on and be able to push as we continue to try and measure physical activity. And the difficult thing when we think about wearables, for example, is that the field is evolving so rapidly. So maybe I might say that one type of device is great today, in a couple weeks or a couple months, that's going to be old and antiquated. So it makes it a little bit difficult, right? If you're going to buy and spend a lot of money on a certain device that you know in 2 years or 3 years is going to be out, how to find that balance and still make it the most useful that you can. And so when considering the way that we're going to measure these physical, especially if we're going to be deriving insights and they're going to be main outcomes, really considering, okay, what is the best way to measure? What suits me best? Do I have a little bit of budget to buy some wearable technology, or is self-report the way that we know and we have the R code to run it and it fits for us? But in this data that I presented, obviously taking from a Garmin perspective, which again, that's their own proprietary algorithm that was processed through, comparing that to the Godin, there is limited agreement between the two. And so we do need to consider and continue considering as a field, what are great ways and better ways to be able to measure physical activity in those living with and beyond cancer to make our assumptions better. So thank you so much for your time, and I think it's the panel time now.
Thanks, Jonathan. Yeah. So these are all the presentations we have in this session, and we will move on to the Q&A session. So I'd like to invite all three speakers on the podium again. Yeah. And while doing so, you can stretch again. So why don't we give a big hand once more for the good presentation in this session. So now floor is open to question, comments, or any productive discussion issues. So please be shy, don't be shy. And there's 2 microphones in the middle, so please come to the mic and tell us who you are and ask questions.
Hi, I'm again Annemai from the Netherlands. And Nicole, I have one question. I really liked your program, and I was wondering one thing. You decided to pay your trainers for 1.5 hours instead of the hour of training. And I can get that point, but since we all need to keep costs low, did you also try to have this get-together that the patients alone have a get-together before and after the training?
Yeah, that's a great question. And yeah, budgetary constraints are a huge piece. What we found was, so I'll just justify kind of why we're doing it. It's not just to build community, but they were putting in all this extra time, and the fitness industry is competitive. So to keep really good professionals, really it was a decision our team made to say, okay, if we want to keep them, let's make sure we're justly giving them the money for their time. So that's one. Number 2, huge community develops with these groups. Most of the in-person ones go off for tea and muffins after the class, depending which setting they're in, but they very much connect with each other, and so they do socially do some of those pieces. I think the peer mentoring piece is really untapped across a lot of exercise psychology, and so we're starting to do a little bit more about how we can integrate. So some of our work at Wellspring in particular is starting to develop these peer mentors, so we can match them up when a new person comes into the class, and really give them that additional support, but also that potential to then lead pieces afterward and engage in kind of support groups. On that note, though, so my very first study I did in breast cancer, we did exercise and they had the 20 minutes after to do the behavior change, and no one wanted that. They wanted to exercise and either get back to their day or just socialize. They didn't want to sit and listen. So that's really why we took that embedded exercise and educate approach. So it's all done there. And so really that pre-post, a lot of it came from COVID and online where they don't get to interact as much. So having that open time pre-post became kind of central, and then we were finding the in-person, same thing too. So it was really a mix of all of those factors, but yeah, I think that it's untapped, and we could be using people that have come through our program even more to develop that community and continue that engagement.
Maybe question for Dr. Kim. Yeah. So I think hereditary cancer, when somebody finds out that they have for example, BRCA2 gene mutation, and suddenly they have a lot of fear whether they're gonna develop it or not. Then, from a salutogenic point of view, about comprehensibility, and then maybe manageability, maybe not about meaningfulness at this moment. So, what would be the right approach? Because I know that many nurses nowadays they actually learn about and counseling these people with a hereditary cancer. So, what is your thought on that?
So today's morning talk was especially helpful for that, because there are strategies for manageability and at lunchtime, Georg was really stressing that the precondition for SOC is social support and having a supportive environment and supportive networks. So for manageability, I think number one, it has to be with your clinician and getting clear guidance, evidence-based, guideline-based suggestions for your daily life, but also for your family to be on board with you and understand where you are. But then the challenge for that is they don't know about your hereditary part. How can they support that part? So that's still a very tricky place, I think. But yes, for manageability, I think that's it. Comprehensibility also, their genetic awareness, their genetic literacy, their health literacy in general, I think creates the platform of are they understanding or are they just being delivered the information? So I think there's so many more challenges, and it was just me really just musing in front of all of you and hoping to get your input about all of this. But thank you for the question.
Yeah, but then, you yourself, as a cancer survivor, and also, you ran a study looking at the effect of exercise on breast cancer patient, and you didn't just do any exercise, you did a on-purpose group exercise. So can you maybe share your experience now, like looking back, now that you understand the salutogenesis and why you did it, and then what kind of effect you saw?
Right, thank you. We at that time did a social capital-based program also. We tried to embed it, as Nicole was just saying, but our breast cancer patients, they really appreciated the opportunity to bond with each other. And yes, a lot of them continued to meet afterwards. I think from that experience, I think that we were working in similar concept levels. So the idea of social sense of coherence, but also using support systems and your social capital, your existing networks, and trying to mobilize that, I think was in the same direction. But I think we may be using different terms and concepts to capture the experience or to promote it at a wider level. So for this salutogenesis model, I think it's more appealing in a way because it's kind of like old knowledge but being shared anew at with different populations, especially for cancer. So don't know if that answered your question, but yes, we try to do in the same line of work, and we found it was powerful.
Excellent, thank you. So one question for Nicole. So, you mentioned, and then you actually address and emphasize quite a lot about CEP. But in Korea, we have this system, but it's not working well in the health setting because it's the certification by Ministry of Sports rather than Ministry of Health and Welfare. Do you know what I'm saying? Mm-hmm. Yeah. So we're struggling because we don't have that, and then I don't know, like for a country like us, about expert in implementation. So what is your suggestion for implementation about the certification and who teaches exercise?
That's a great question. And I hesitate to say what your country should do, not knowing the full setup. But I firmly believe, I think fitness professionals are the right group. I don't think we have to reinvent the wheel and build fitness professionals. They exist. It's about giving them then that oncology specific training, like our general training. We use the BME hub as more and more resources are built around the world, tapping into those and providing them to the workforce that you do have available, whether they come from a sport background or a fitness testing background. I think it is about delivering kind of whatever model you're implementing here, providing them training on that, especially when you are embedding research into that, right? So you need that fidelity piece. You have to make sure they're collecting the right data if there's, fitness testing or adherence, even attendance data, right? So I think it is that kind of on-site training based on what you need. And, the approach we've taken for that training is really that exercise and educate, where we're training them as much as what's going on up here as it is the actual protocol for the 12-week classes. Does that make sense? Yeah.
Thank you for your wonderful presentations. I'm An-Suk Jung from Chicago. I teach psychology in DePaul University, and I do research on this topic. And my question is going to be to all types of different wearables and community implementation and hereditary cancer as well. The thing is, when I saw this social ecological model, it's fantastic. I wonder if you have noticed or witnessed or you're afraid of anticipating to see some systematic barriers in implementing all these different types of wonderful exercise programs in different communities. Because communities, maybe local communities, maybe ethnic communities, maybe developmental age-appropriate approaches. Have you seen any systematic barriers to make it successful or more widespread? I want to hear your insights. Thank you.
It's a very big question, I think. I'll try to answer it first is better. In hereditary cancer, I think the systematic barriers are, they may be a little bit relatively lower compared to other countries because we have national health insurance. A lot of it is covered if you're found to have cancer. But as far as the awareness at large, I think we have a lot of work to do. There's a general stigma about cancer in itself, and then the hereditary part is not being comprehended correctly. So there's more of a stigma that something through you is going out to kind of ruin your family line. Systemic-wise, I think we should have more policy, more campaigns and public health awareness things, but not a threat-based approach, again, but to make it more relatable on a daily level, that there's things you can do here and now, there's things you can do and enjoy now, but then if you take that extra step for your family, valuing your family health is also important. I think that would be very powerful. We see a lot of celebs and how the celebrities influence all of our thinkings and job decisions, right? If I look at my kids, but so maybe some of that might need to be done in a different way, different model.
Yeah, that's a great question and a big picture question. From my perspective, it really does come back to the systematic barrier where it's just exercise, right? And the cancer care system, we have a very good system in Canada, and socialized medicine and really good care, but there's not a culture of wellness within that cancer care. And so until we really break that down and they value exercise as medicine as part of cancer care, it's going to be really hard to have that full-on integration and availability across the board. And so I think at that highest level is really the biggest barrier. And then it comes down to maybe all of the other levels that are closer to the individual. So culture, language, what is considered appropriate, right? So there's lots of other factors down to their demographics. But I think it's really that if we want to build stuff in the community, we need the clinic to community model and that link.
I think from a measurement of physical activity perspective, I touched on this in my presentation, but I think a lot of it is driven by a systemic barrier, is the fact that it's a lot of, not necessarily corporate America, but corporate the world. So there's these big companies that maybe at the heart don't fully care about the actual person as much as they care about what they're going to spend or give them their money. And so I think from a research perspective, I can speak to that barrier being the black box that is the devices and not being able to have full access of what is going on and what they're recording or how they're recording it, I think is a big thing. And I think also a lot of people sometimes are adverse to the idea of wearing something, like who's tracking me, where's that data going to go, how's it going to be hosted, is also a barrier that I think is quite common in the area.
It's time to end. Thank you everyone for being with us today. We've heard inspiring and ideas and evidence that show how exercise and science can truly make a difference in cancer care. Yeah. Thank you for distinguished three speakers. Yeah.
Thank you for presentation and discussion. We will now have a 10 minutes coffee break, and then we will resume at 3:10 p.m. Thank you.
I want to welcome everybody back for our fourth session. If you don't mind taking your seats, we're about to start. For the fourth session, I will be on the microphone. My name is Lex here at Yonsei University. We're going to begin with a few speakers in session 4 with the biological pathways underpinning salutogenic effects on exercise and cancer. It's my pleasure to introduce our two chairs, Dr. In-Dok Kong from Yonsei University Wonju College of Medicine, and Dr. Ji-hee Min from the National Cancer Survivorship Center and the National Cancer Control Institution. So please welcome our two chairs, and right now I'll turn the mic over to you.
Good afternoon, everyone. Welcome to session 4, entitled Biological Pathways Underpinning the Salutogenic Effects of Exercise in Cancer. My name is In-Dok Kong from Yonsei University, Wonju College of Medicine. And
Hello, I'm Jimin from National Cancer Center in Korea. We are pleased to introduce today's sessions featuring 3 outstanding speakers who will discuss how exercise influences cancer biology and immune pathway. Our first speaker is Dr. Hyo Moon, Associate Professor at Seoul National University. Dr. Moon is a researcher specializing in exercise-induced molecular signaling, including exosome and tumor-related pathways. He will present exercise-induced circulating exosomal microRNAs, a novel axis in the regulation of cancer progressions. Please welcome Dr. Moon.
Thank you very much for your kind introduction. And thank you, Professor John, for inviting me here. And I thank you all the committee members for having me here. And this is the main title of presentation, but I will, in this presentation, I will divide into 2 themes. First, I will deliver some research findings from our laboratory about the neutrophil immune cells, which is the key trend in the exercise and cancer research. And then I will move on to the second topic about the microRNA, which is the novel mediator exercise effect in cancer progression. So this is the historical overview of research on cancer and exercise. In 1944, there was a first clinical study showing that exercise inhibits the tumor growth. And then 2003, there was a first exercise guideline for cancer patients from American Cancer Society. And 2009, there was a first study showing that the relationship between exercise and cancer outcome might differ as a function of a tumor's molecular profiles. And 1916, Peterson group from Copenhagen University, they first study that show that exercise-induced inhibition of tumor progression is made by NK cells. And recently, several groups found that the exercise recruit CD8 positive T cells to anti-tumor immunity in lung cancer and other kind of cancers via epinephrine. As you might notice, there was a paradigm shift in cancer research. And in the past, there was most of cancer research focused on the oncogenic factors within the cancer cells, which increase the metastasis and recurrence caused by anti-cancer drug resistance. And now we know that controlling the surrounding cells, including immune cells, in the tumor microenvironment is important in controlling the overall cancer malignancy. This conceptual change also affect the cancer drug field. Second generation target drugs like Gleevec or Herceptin, they just targeting the cancer cells, and they have a limit of therapeutic effect, or there is an emergence of drug resistance. So people move to the third generation of immuno-oncology drugs like PD-1 inhibitors or PD-L1 inhibitors such as Keytruda or Opdivo, and which modulating the interaction between cancer cells and immune cells. This immune checkpoint inhibitor market expanded more than 50 times compared to the 10 years ago. So among those neutrophils, immune cells. Neutrophils are a first responder that react to the rapidly react to the patient's condition. The number of neutrophils sometimes are suppressed during and after anti-cancer treatments such as chemotherapy and surgery. But recent findings shows that not only the number of neutrophils that matters. Cytokines such as TGF-beta or interferon gamma can reprogram the neutrophils, polarizing them into N1, anti-tumorigenic, or N2, pro-tumorigenic status. Conventionally, we all know that the exercise can inhibit the tumor growth through the oxygen delivery and increase the catecholamine level and decrease the tumor hypoxia, and chronic exercise actually decrease some growth factors like insulin-like growth factor, and also decrease the pro-inflammatory cytokines such as interleukin-6 or CLP. And recent studies, many researchers report that the NK cells and regulatory T cells are modulated by exercise, which affect the tumor progression. However, the role of exercise induced neutrophil in tumor microenvironment has not been fully explored. So one of our former master's student, Song Woo, who is working at the Alabama University as a researcher, she designed this experiment. What she did first was she inoculated 41 breast cancer cell line into the mammary peptide of BARBC mice, and then let them run in the voluntary wheel cage for 40 days. And 40 days of learning actually reduced the tumor volume and weight. And interestingly, we found that their tumor volume, tumor weight was negatively correlated with the learning distance. And we further confirmed that the lung metastasis was significantly reduced in exercise mice. To assess the immune change, we did single cell profiling in the bone and blood and bone marrow cells, bone marrow. What we found was that there was a reduction of neutrophil numbers in the exercise group in both blood and bone marrow. So we hypothesized that maybe the reduction of neutrophil may mimic the exercise-like effect. So we we inject the neutralizing antibody during the exercise, and found that there was an unexpected result that exercise effect of exercise anti-cancer effect was diminished in LY6G neutralizing antibody treat group. And also we found that the proliferation markers were returned to the baseline after LY6G neutralizing antibody group. So we were curious whether a neutrophil itself can directly inhibit the cell growth in the in vitro. So we isolate the neutrophil from the exercise group, and then co-treat those neutrophils with 41 breast cancer cell line. And as you can see here, we found that the neutrophils from the exercise mice actually suppress the viability of the 41 cells. And we were curious whether this was because of the phenotypical change of neutrophils. So we collect the cancer cells and did the RNA sequencing to see whether those phenotypical markers were changed. So what we found was there was a N1, which is an anti-cancer anti-tumorigenic markers were like CXCL and FAS was increased, and the N2 markers were decreased. And these results demonstrate that exercise can polarizing those neutrophils toward the N1-like phenotype. We further did the immunohistochemistry and to see that the upper cytokine levels and 40 days of exercise actually decreased the TGF-beta positive cells in the tumor. And to validate those effects, we deplete the TGF-beta level, TGF-beta expression in the 41 cells. And when we co-treated with those cells with differentiated neutrophil, we found that there is a significant reduction of cancer cells. In summary, we found that there was like other studies, we found that exercise can reduce the tumor growth and metastasis. And in tumor-bearing mice, exercise decreased the neutrophil numbers. But when we treat the neutrophil depletion antibodies, we didn't find we found that the exercise effect was diminished. And we found that exercise shifted neutrophil phenotype toward the N1 anti-tumorigenic profile. And exercise-induced neutrophil itself can mediate the tumor suppression and potentially via TGF-beta dependent manner. And our findings demonstrate that, like especially immune cells, like neutrophils, can involved in exercise-induced anti-cancer-like phenotype. But still, nevertheless, there are lots of precise mechanism underlying how exercise effect on the reduce the cancer growth is not still ambiguous. So we move our focus to the EVs. Those extracellular vesicle EVs are small and membrane-bound particles which contains the proteins, microRNAs, DNAs, and lipid for the communication between cell-to-cell communication between cells. And some recent reports shows that the exercise-induced EVs can inhibit the tumor growth and metastasis. They found that they isolate the EVs from the high-intensity interval training subject, and then they treat the EVs into the colon cancer cell line and found that those effects. So actually, at the time, we also plan to do the similar experiment, and we also isolate the EVs from the exercise mice and treat them into the colon cancer cell line. But as you can see in this figure, we didn't see any significant difference between those sedentary-derived EVs and exercise-derived EVs. So we thought that maybe that given the potential difference in EV contents, we directed our attention to the microRNA cargos. Yeah, microRNAs are master post-transcriptional regulators. They have CD sequence or short motif, typically 2 to 8 nucleotide from microRNA 5', and which drives the target recognition. And microRNA, when microRNA bind to the complementary side of the mRNA 3' UTR, it can prevent the liposomal translation. by recruiting the risk complex. And 60% of mammalian mRNAs are regulated by microRNAs, and exercise have been reported to release various kind of microRNAs and EV microRNAs and linking tissues and tumors. And these are the list of microRNAs which are reported to be released in after exercise. And substantial number of those microRNAs are related to the cancer progression. So in the physiological perspective, it is a very inefficient way to achieve the same purpose after exercise. So one of our master students raised the question whether they have the common common sequence among those microRNAs. So he collected all the microRNA database and then found some conserved common sequence. To investigate the role of those common sequence, we designed the oligomers. At first, we tried to test whether this seed sequence can transfect into the cells. So we add the seed sequence with the fluorescence sequence, FAM, and found that the 27 hours of transfection actually there has the fluorescence expression was efficiently transfected into the cells. And to test the function of this seed sequence, we needed to increase the stability of the seed sequence. So we add the 5 phosphate at the 5 prime of the seed sequence, and then we also add the phosphorothioate linkage at 19 to 20 nucleotide of the seed sequence. And then when we transfected those seed sequence into the cells, and after 72 hours, we found that the cell viability of those tumor cells were significantly reduced in CT26 colon cancer cell line and 41 breast cancer cell line. We were curious about the underlying mechanism, how these exercise-induced seed sequence affect the cancer cell proliferation. So we did RNA sequencing and found that the seed sequence transfection increased like 400 genes and downregulated 350 genes. And these are the 10 top downregulated genes, top 10 downregulated genes induced by seed sequence transfection. As you can see here, some genes are already known to link to the cancer progression. We further did the gene set enrichment analysis and found that the transfection of exercise-induced seed sequence can increase the hallmarkers of apoptotic genes, and also found that the epithelial mesenchymal transition-related genes were downregulated. And also, we also found that the P53 pathway-related genes were enriched in exercise-induced transfected genes. So in summary, we found that exercise modulates the blood-borne profile of multiple exosomal microRNAs, and we identified a common seed sequence among exercise-induced microRNAs. And exercise-induced seed sequence transfected into the cancer cell influenced cell growth, and this is mediated by regulating specific cancer-related genes. And now we are, the in vivo experiment is still going on, and yes, this is the end of my presentation. And these are the students who work for this work, and then these are the collaborator for this progress this work. And this work was supported by NRF funding. And thank you very much for your attention.
Thank you, Dr. Moon. Because time limit, the Q&A will be take place after all presentations.
Now I'm happy to introduce the next speaker, Dr. Dong-woo Kang, is assistant professor at the Fred Hutch Cancer Center. He is an internationally active scientist working on exercise oncology, immunology, and clinical trials, with experience at Harvard Medical School and Dana-Farber Cancer Centers. Today's talk is titled Immune Adaptation to Varying Exercise Intensity in Oncologic Context, Clinical Evidence and Implications. Please welcome to Dr. Kang.
Thank you, Dr. Kong, for the kind introduction. I think it'd be appropriate to start with we can't get enough from exercise, right? So why don't we get up and again, and this time let's do some squats, like 5 squats, everybody get up. I'll do it together. So at your capacity, you can do easily, you can do pistol squats. Ready? 5 squats. Let's go. 1, 2, 3, 4, more, 5. Okay, we go pause. Great. I think it's very appropriate that we're going to talk about exercise intensity and how it helps with your immune system. So the topic I'm going to talk about is the immune adaptation to different exercise intensity in cancer context. So we'll be looking at some mechanistic theories, but not too much mechanistic theories, but more clinical side, and also latest clinical evidence and its practical implications. Now, we know that regular exercise is associated with cancer, lowering cancer risks and mortality and recurrences. And then various preclinical research is you just saw some of the research that's just presented, and there are many underlying mechanisms that have been suggested, but we'll be focusing on one key mechanism, which is the immune inflammation axis. Now, for those who are less familiar, I'll be briefly show a high-level conceptual framework about this link. So this diagram here is showing the transition from the sedentary life or sedentary state to the exercise-trained state. So really briefly, if you are sedentary, this prolonged exposure to physical inactivity is associated with elevated circulating levels of numerous growth factors, including hormones such as IGF-1, and then these are creating pro-tumorigenic milieu, as you can see in the blue box here. Now, when a patient performs an acute exercise on the right side, as you know, it triggers very immediate physiological stresses like increasing cardiac output, muscle contraction, and then releasing catecholamines. And these changes transiently shift these systemic changes in our body, improving tumor perfusion and mobilizing immune cells. Now, if we are repeating these acute exercises, and these acute exercises accumulate, and then this will kind of reset or calibrate your body's physiological set point, which will lead to lowering chronic inflammation and the metabolic risk factors. Now, there are many mechanisms that are presented, again, we'll be just focusing on immune regulation. So does intensity matter and how? The short answer is theoretically yes, because different intensities trigger different physiological signals, obviously, and there are two call to arms mechanisms. What it means is that first on the left, you can see we have shear stress where inside our blood, when you have a higher intensity, there are millions of immune cells are stuck in your blood vessels, in spleens and other organs. So we call it marginal pool. So we have available immune cells around your body. And as exercise intensity increases and then your heart rate rises, your blood flow increases, it becomes more turbulent in your blood flow. And these physical forces actually scrapes these cells into your bloodstream so that those immune cells are more available. Now, second, there is on the right side on the panel here is adrenergic signaling, or we call it chemical orders. So some stressful exercise or higher intensity exercise kind of trigger the release of these epinephrines and catecholamines, like in these hormones. And these hormones have connections with these immune cells. For example, more particularly, some of those presented immune cells like NK cells and T cells, regulatory T cells, they have most common these beta-2 adrenergic receptors. They're most present, and very importantly, these cells have a highest density. So where there's epinephrine more available, there'll be more binding in these immune cells that are mobilizing into the blood flow and kills the cancer cells. So those are the two main intensity-related mechanisms. Now so put this in this perspective where we are doing exercise and after exercise, these are the levels of immune cell changes in a single exercise. So what we actually see here is a rapid surge of these increase in these immune cells or lymphocytes. And then after this, we see the lymphopenia, which is decrease in these lymphocytes. So how do we interpret it and how does it really work? Now, so when what's going on here, when you're exercising, we call it demarginalization, as we just discussed, and there's existing high-functioning immune cells stuck in your body, and they'll be more available. And then after exercise, almost within 24 hours, it goes down, and the number of cancer cells or immune cells are decreasing available in the bloodstream. But what's actually happening is it's not immunosuppression. Again, it's not an immunosuppression that you don't have many immune cells in your body, but it's potentially infiltrated into different tissues, maybe improving immunosurveillance in your whole body. So they are elsewhere surveilling your body to attack cancer cells or other functions. And also, exercise is acting as a systemic reboot, we call it, and then it preferentially mobilizes those senescent T cells. We call it more mature cells, which is, I think they're old cells, let's say. They are programmed over the time, but they are old, they are not functional. But when you do exercise, after exercise, these cells are dying. They're apoptotic, apoptic T cells become, and then more naive cells, which is more new, fresh cells are available. They have room to get in and fight with cancer cells. So this is another mechanisms that are happening after exercise. Now, what happens then when you do this exercise repeatedly? So each workout triggers these immune mobilization, immune surveillance. This is one mechanism that can help with these making these cold tumors to hot tumor, where immune cells are getting into the tumor cells and fighting with them. And then another mechanism is that again, like immunosurveillance, keeping this constant pressure on any potential tumor cells and lowering systemic inflammation. And then lastly, again, these functional cells are more available. Again, the number of cells, these cells don't look like they're more available, but their functions seem to be higher than before. This is what we have found in more preclinical studies so far. So, based on these preclinical or mechanistic evidences, one of my colleagues of Dr. Emily Lavoie from University of Houston and I were thinking, we kind of want to know if its mechanisms that actually translate into human or clinical settings. So we have conducted a scoping review recently, and I want to show you the result, what we found. Particularly, we established some very strict criteria for this review. We excluded single session exercises, more chronic exercise intervention and long-term training and adaptation. And then we are requiring non-exercising control group to see how they are different from non-exercising people. And then we are really focusing on those trials that are providing immune cell parameters, not just cytokines. And lastly, the intervention should be intervened only or just isolated exercise intervention, not combining with other interventions. So we found 21 articles in total. And as we reviewed these studies, there are a few patterns in the landscape. And we have found breast cancer as most common studied population. And then patients' treatment status are mostly during treatment, including chemotherapy mostly, and then also hormonal treatment. And in terms of exercise programs, there are combined aerobic and resistance exercises and aerobic exercise only, resistance exercise, but most studies used combined exercises. And then intensity is actually most complicated in these studies, where many studies are not particularly reporting or using a specific intensity. They're rather more straddled different intensity categories. So we kind of recategorize as light to moderate, moderate to vigorous, and vigorous. And then we didn't see any single study that are only using light intensity exercise. And then period of intervention is also broad, from 3 to 22 weeks in our included studies, but mostly using 3 to 4 months of intervention. And then one of the first difficulties we found, again, like this is about the intensity categorization, which is very complicated. Particularly, as I mentioned, that most 2/3 of these studies are using aerobic and resistance exercises. Particularly, resistance exercise prescriptions are largely based on patients' RPE or exertion levels instead of 1RM or objective measures. So it was difficult, but we excluded those studies that are using subjective measures. So we only included those studies that are using subjective measures, as you can see, light intensity and moderate intensity, vigorous intensity, based on this ACSM prescription and guidelines. This is a very brief summary of what we found. So this is a little bit complicated, but I'll walk through what it really means. So on the vertical axis, there's exercise intensity, light, moderate, moderate to vigorous, and vigorous. And on the x-axis, there's a favorable control, which is not good. On the right side, exercise is better in terms of changing immunity. So these more yellow dots, you can see they are cellular numbers or phenotypes, so the number of killed immune cells. And then this more of orange dot is showing the lymphocyte function, which is a cytotoxicity or their ability or power to function. And then this blue dot represents the neutrophil function. So you can see as from stepping back and look at this figure as a whole, these yellow dots looking in the middle, it's null or no differences between the exercise and control group across different intensities. But as you see, there are more exercise intensities that are favoring exercise here, particularly including the number of cancer cells, immune cells, and the function of these immune cells that are mostly NK cell or NK cell toxicity or T cells. So I want to show you some example studies. So one of each these intensities. So one studies from Sakura Romeo studies. It was done in breast cancer survivors who are receiving chemotherapy. They recruited 22 patients. They implemented aerobic plus resistance exercises. They didn't really see any changes in their leukocyte levels, and then also lymphocytes. However, there's something interesting they found is CA15.3 is one of the cancer tumor markers they found from the tumor cells. Then the control group didn't really change in this marker, but exercise actually had a negative effect, which they don't quite understand. So this is something that they found, but we're trying to connect the immune changes with the clinical outcomes, but we found something unexpected as well. And this is a moderate intensity exercise. And then one study from Rogers from 2025, they recruited 22 patients who are esophageal cancer. And then they also did aerobic and resistance exercise. So they found the CD8 cells and T cells in tumor. They actually biopsied the tumors and stroma, and then they found the increase or higher infiltrations of these immune cells in these tumor and stroma cells. But they didn't really see any clinical associations between the immune changes and then clinical outcomes. And particularly, they might be relevant to the effect size. And then one vigorous exercise is done in this population, multiple myeloma patients, and also aerobic and resistance exercise. And then they found particular increase in the CD27 T cell in their bone marrow, which will be transient in their bloodstream, and it might help with fighting with the cancer cells. But also, they also found minimal residual disease, which is the effects of their treatment. So they're also seeing that those who are doing exercise having a higher treatment effect, and then that there might be an association where there's a more higher immune cell adaptation that might be relevant to their treatment efficacy. So as you can see, these are some of those studies we found. And then as you also notice that the intervention and patient populations are extremely heterogeneous. So it's quite challenging to interpret in one or conclude in one sentence. But overall, exercise does look like generally show the beneficial effects on immune cells responses regardless of specific exercise regimen. However, there's a potential effect of intensity where vigorous intensity exercise, particularly more than 76% of heart rate max or 70% of 1RM, consistently elicited beneficial immunomodulation. So this effect was particularly observed in NK cells and T cells. In vigorous exercise, maybe we say a potent stimulus for immune cell trafficking and adaptation. On the other hand, lower intensity exercise often resulted in no immunological changes or null changes, especially among patients undergoing treatment. However, I really want to emphasize that the studies we included doesn't explain everything. So there are also other studies that are showing that moderate intensity or lower intensity might be more beneficial in immune adaptations. This is one of my friends who conducted this study in animal models. They actually found that moderate intensity is actually increasing immune function better than higher intensity. So we do not really know the underlying mechanisms, what the discrepancies are between our findings. But one thing they noted is that the forced high-intensity exercise in the rodents does look like they're triggering systemic stress that might be relevant to counteract anti-tumor benefits. And so stress threshold is important concept here. So this discrepancy may be stemmed from species-specific stress threshold, and this high-intensity protocol might induce those state of chronic stress or overtraining. Or acute and chronic might be also different. These human studies have benefits from the acute increase in epinephrine, but mice suffer from chronic catecholamine elevation leading to immune suppression. And I was looking at this article and comparing my studies, but what I was thinking, one of the classes I was taking from Dr. Justin John, and I recall that one of his studies in the past, and he saw more mice is dying when they are forced to exercise, and I remember this might also be relevant also in the immunity side as well. And I want to put another perspective about maybe many of you are familiar with J-shaped curve where high intensity is actually increasing the risk of infection. How many of you have heard about this before? So now, this is, we call sometimes, we shouldn't do exercise because it may reduce or suppress your immune function, but this is a very specific type of curve that are representing a specific situation where their outcome is URTI, which is upper respiratory tract infection, where those people are getting this infection from their breathing or their after their exercise. So this is not specific or particularly to your whole body immune function or systemic immune function. It's very specific. And also specific to high intensity prolonged exercise like marathon. So this is not like 20 minutes or 10 minutes of high intensity interval training. That might be different setting. And then lastly, this is specific to acute responses. So when you do or repeat those high intensity exercises, maybe the overall immune function might be responding differently. This is a more like acute response right after the marathon running. So you may have a different understanding about this J-curve right now. So the limitation obviously is a high heterogeneity. This is something that we need to address to do many different studies. And we really need to have some comparison studies actually comparing moderate, low, and high intensity trainings in one clinical design. And then there are so many intervention details about regimen. We just talked about intensities, but there's a dose, right? There's the frequencies. There's aerobic and resistance exercise. They're also not dichotomous. Aerobic and then resistance exercise can be spectrum. So there are so many things to unveil here. And then there's oncologic outcome gaps, right? So there are many studies that are done. However, we want to know how it'll translate into clinical understanding. So patients are increasing their immune function. Does it really change the oncologic outcomes or clinical benefits? So we want to know if it'll eventually improve their survivals or recurrences or lowering metastasis. So to conclude, with the result, we found just that vigorous intensity exercise may bolster a greater anti-tumor immunity. However, it should be interpreted with caution. And some considerations, as I mentioned, that prescription and reporting should be standardized and guideline considerations. Now, I think it's very important too, as we know, physical activity guidelines for cancer patients are 150 minutes per minute of vigorous to moderate to vigorous exercise, or vigorous 75 minutes per week of vigorous physical activity. So we are kind of combining those intensities together in the guidelines. But if we are focusing on, based on the outcomes, if you are focusing on improving immune outcomes, moderate physical activity and then vigorous physical activity might be different, but we are not just matching the dose. And then also we need adequately powered immune parameters, because most of these studies are maybe data mining, because there are so many immune parameters that are just happen to be significant. And clinical endpoint should be included in the long-term studies. And finally, we want to embed other correlative and mechanistic outcomes to understand better in this relationship. And then there's more emerging outcomes, including microbiome access, which is very critical right now. And then we want to have a novel understanding on that. So thank you so much for listening, and take any questions if you have.
Thank you, Dr. Gang. Our final speaker is Ms. Hee-jae Lee from the University of Calgary. She is cancer biology trainee working on exercise to enhance immune cell-based therapy, especially T-cell based on approach in leukemia. She will present exercise to enhance immune cell-based therapy for acute myeloid leukemia. Please welcome Mrs. Lee. Oh, sorry, Mr. B.
Thank you for the introduction, and thank you for the opportunity to speak here today. I'd like to introduce a new concept, inspiring novel applications of exercise as a model system to develop more effective cancer therapy. Immunotherapy leverages our body's natural defense system to recognize and eliminate cancer. And adoptive cellular therapy, including CAR T-cell therapy, is its leading form. In this approach, immune cells called T cells are taken from the patient, genetically modified in the lab with this targeted machinery against cancer called CAR, grown to millions of cells and reinfused into patients where the CAR T cells now bind to cancer cells and kill them. This treatment has had a transformative impact in treating hematological malignancies. However, the highly tailored nature of this process is associated with high costs and complex manufacturing, limiting patient accessibility. Whereas conventional approaches rely on the patient's own immune cells, double negative T-cell DNT therapy, pioneered by Dr. Jeong-bok Lee at the University of Calgary, is an innovative form of adoptive cellular therapy that uses immune cells derived from healthy donors called DNTs. And this treatment is used to treat acute myeloid leukemia, AML, a blood cancer with limited treatment options and poor long-term survival. DNTs are highly effective in killing AML cells without causing harmful side effects. And because these are derived from healthy donors, DNTs can be pre-manufactured in large batches and cryopreserved until later use, addressing the accessibility barrier by providing a readily available therapeutic product that can be administered to patients in an off-the-shelf manner. And this phase 1 clinical trial using DNT therapy for AML patients who had relapsed after allogeneic hematopoietic stem cell transplantation. All 10 patients received their DNT doses without experiencing adverse effects. 5 out of these patients achieved complete remission. And compared to patients undergoing conventional therapy at the same institution during the same time period shown in red, DNT therapy showed signs of improved survival. While these results were not statistically significant, the patients enrolled in this trial were high risk with poor prognoses, leading us to conclude DNT therapy as a safe, accessible, and potentially effective treatment option for AML patients. This warrants continued investigation to further enhance the effectiveness of DNT therapy by identifying who is the optimal DNT donor, what is different about the DNTs coming from these optimal donors, and how can we leverage these insights to develop better therapeutic products so that we can bring better treatments to AML patients who currently have limited treatment options. And to answer these questions, I want to use exercise as a model system. In addition to the benefits of exercise in improving quality of life in individuals living with and beyond cancer, exercise provides protective effects in decreasing cancer risk and recurrence while improving survival. However, the mechanisms underlying these benefits remain to be fully revealed. Exercise has been shown to mobilize anti-cancerous immune cells, and in mouse models, this leads to improved survival. Furthermore, myokines and exerkines, which are soluble factors released during exercise, have been shown to modulate the biology of both immune cells and cancer cells. So uncovering the exercise immune system axis has the potential to be harnessed to develop better cancer therapies, including DNT therapy, while also providing mechanistic insights into the protective effects of exercise against cancer. One challenge remains, though. Implementing exercise in conventional adoptive cellular therapy is challenging because, as I mentioned, it relies on the patient's own immune cells. And these are high-risk patients, and implementing structured exercise regimens in high-risk cancer patients is not without challenges. With donor-derived DNT therapy, a unique opportunity is created by exercising the healthy donors and assessing whether it can be used to develop a more effective treatment. Therefore, to assess the impact of exercise on the effectiveness of DNT therapy, we conducted a single bout of high-intensity interval training session, HIIT, on a stationary bike with blood collected at rest and immediately post-exercise. The HIIT session included a 2-minute warm-up, followed by 4 minutes of high-intensity cycling and then 3 minutes of low-intensity cycling. From here, the DNTs and the soluble factors were isolated and tested against AML. Figure A is a representative heart rate response during the HIIT session, showing the intensity of the exercise performed by the healthy donors. In Figure B, exercise consistently increased the number of circulating immune cells from rest, shown in blue, to post-exercise, shown in red, across participants, including DNTs, which increased by about 3-fold. Now, the DNTs collected at rest and post-exercise were expanded, and the therapeutic product was tested against AML to compare their effectiveness. Here, on the y-axis, what you see is percent-specific killing mediated by the DNTs. And between rest, shown in blue, and post-exercise, shown in red, the results were comparable. However, I noticed a wide variability in DNT performance, leading me to ask what might be driving the variability. I stratified the donors based on aerobic fitness, measured through VO2 max, where the trained donors had a VO2 max of around 60 milliliters per kilogram per minute, and untrained donors having a mean of around 30 milliliters per kilogram per minute. I found a clearer separation, where the DNTs from the trained donors demonstrate a superior killing, shown in blue, compared to untrained donors, shown in red. While these results need further validation, aerobic fitness could be a potential strategy to identify optimal donors. This led me to a follow-up question then. What enables the DNTs from these trained donors to perform better? And since no notable differences were found within a single bout of exercise, I reasoned that repeated exercise might be necessary to imprint changes in DNT function, and this might be mediated through myokine, exerkine soluble factors that act as signaling molecules. So to test this, DNTs from unrelated donors were treated overnight in plasma collected at rest and post-exercise from one of the trained donors. After the treatment, the DNTs were put against AML cells to compare their effectiveness. In figure B, what you see is live AML cell counts, with lower being better. When AML cells were incubated with DNTs that had previously been treated with plasma collected post-exercise, I found a lower number of live AML cells in that condition, suggesting that post-exercise plasma has something in there that enhances the anti-cancer performance of DNTs. Plasma collected from healthy donors post-exercise also exerts direct cytotoxic effects against AML. This time, AML cells alone without DNTs were cultured with plasma collected at rest and plasma collected post-exercise. In these microscope images, what you see are healthy, abundant AML cells in the untreated and PBS control groups. However, less cells and more debris are observed in the post-exercise treated condition. In figure C, what you see is again live AML cell counts with lower being better across the 6 donors tested, with blue bars indicating plasma collected at rest and red bars indicating plasma collected post-exercise. Normalizing these 2 groups to the PBS control group in figure D shows that post-exercise plasma effectively kills AML cells. Now, a limitation of this finding is that it does not accurately reflect the exercise response in individuals living with and beyond cancer. However, I think it still has value because it first serves as a foundation for future studies in individuals living with and beyond cancer. But exercise provides a model system to identify novel molecules and pathways that increase the susceptibility of AML cells to death, inspiring new ways to develop more effective treatments. So to identify those molecules and pathways, we're leveraging omics technologies. And this is really driven by Dr. Jonathan Lowe, who's a postdoctoral fellow in Dr. Culos-Reed's and Dr. Lee's labs, in collaboration with Calgary Metabolomics Research Facility. What you see here is each dot, or X, is a sample from a donor. The blue dot indicates plasma collected at rest, and orange X indicates plasma collected post-exercise. Samples with similar metabolomic profiles will cluster together. What is shown here is then exercise induces a distinct metabolic shift compared to rest. And in this volcano plot on the right, each metabolite that is significantly altered are shown in red, all of which could play a potential role in the immune boosting effects of exercise. So in summary, the immune system is highly responsive to exercise, and this has the potential to be harnessed to enhance immune cell-based therapies. And leveraging the natural physiological effects of exercise offers a unique model system to identify novel molecules and pathways essential for effective cancer treatment. So in addition to the well-established physical and psychosocial benefits of exercise across the cancer care continuum, these discoveries will further position exercise as an evidence-based tool that can be used to make a positive impact in the lives of individuals living with and beyond cancer. So with that, I'd like to thank my supervisors, Dr. Nicole Culos-Reed and Dr. Jeong-Bak Lee, who make this transdisciplinary project possible, and Dr. Jonathan Lowe, Dr. Enoch Tin, and Dr. Brittany Edgett, who contribute their expertise to bring this vision to life. Lastly, I'd like to acknowledge our collaborators, CHGI, CMRF, and the GSC, as well as our funding organization, CIHR and Alberta Cancer Foundation. Thank you very much for the symposium organizers. Thank you, Dr. John, for the invitation. And with that, I'm happy to join the panel and answer any questions that you might have.
Thank you, Dr. Lee. Thank you to all our speakers for their insightful presentations. We will now open the session for Q&A. Will be 3 speakers. But we around 9 minutes left, so we just quicker. Any question or comments from the floor? Please feel free to raise your hand or standing on the mic. Yes, Dr. Lee.
Yeah, first of all, thank you so much for the great lecture today, and I learned a lot from all of you guys, and it was really impressive. And I'm not an exercise immunologist or I'm not really doing any like immunology work here, but typically, we are really living in the era of immunotherapies. Like there are multiple successful immunotherapies such as the CAR-T or Opdivo, like Keytruda, or there are many things. But the main function of immunotherapy is basically to improve the immune function. But then also the things that I've learned today is basically exercise also enhance the immune function here. But so my question, I guess, is if our clinical patients, they're doing exercise and plus and getting like immunotherapies. I mean, do we have enough evidence or some level of evidence to say that you're like safe to do exercise while doing like receiving CAR-T or other other types of immunotherapies? I mean, maybe I think I think all of you can answer, but maybe Dr. Kang, because you reviewed the scoping, you did the scoping review, maybe.
Yes, I can answer. First, I think there are probably several preclinical research that are done in different tumor models in lung cancer and breast cancer, where they're providing particularly anti-PD-1 and PD-L1 treatment and an exercise was effective, but we didn't really see a clear trend that exercise has any additive or synergistic effect so far. We just need some more research, and theoretically it works, but we didn't really see in the research setting yet.
Thank you very much for your question, and that's the reason why we choose the neutrophil as one of our candidate mediator of exercise effect on cancer progression. So as far as I know, there is a doctors here, but as far as I know, the neutrophil level is one of the markers for the cancer therapy, cancer treatment. For the chemotherapy, the neutrophil numbers should be some in the range of the normal range. So maybe neutrophil, but we don't have any specific evidence or guideline for the numbers of, as far as I know, we don't have any guideline for the immune cell range for the successful or exercise prescriptions. Yeah.
Maybe I'll just add that exercise immunology is a field that's been there for a while, but I think its application in the context of cancer is growing. And as Dr. Kang mentioned, it's been a lot of focus in upper respiratory tract infections. So I think it's an exciting field with a lot of potential. And more research, as both of our panelists mentioned, more research is definitely needed. I think one thing that I might add is that immune cell function is not at its best in many of these individuals living with under treatment because of chemotherapy that can damage the immune cells. So I think another area of investigation is, can exercise rejuvenate the function of immune cells after these patients have undergone treatment, so that as they go into survivorship, which is a theme of this conference, can we use it to support their long-term immunity, not only to decrease recurrence, but to provide immune protection over many other daily things such as a simple cold. So these things impact their life, and I wonder if exercise has the power to impact those things as well.
Got it. All right, thank you.
Hello, Kristin Campbell, University of British Columbia. This is a question to the panel, and I'll try and keep it focused. Humans have extremely complex systems biology. One thing goes up, there's 400 mechanisms that are changing to dampen that down. So my question for you is, how do we deal with that complexity? We always want to look for one biomarker, and in the old days it was like insulin or C-reactive protein. You can see technology has moved on. So I guess my question is, how do we handle the system biology and the fact that in plasma from someone with a VO2 of 63 versus 29 is going to be full of lots of things? So is technology going to allow us to zero in on one thing, or what do we do with that?
I can address the question first. Thank you very much for that question. And the technology is evolving very fast. And the umbrella term for it is omics technology, but there are different versions. There's proteomics, looking at the proteins, metabolomics, looking at the metabolites, and there's transcriptomics, which look at the gene expression, as Dr. Moon showed as well. So what we can do, for example, in our project, we are taking the plasma for metabolomics and proteomics analysis, and we can see, as a fishnet method, what are the things that are altered. And then from our hits, we can test those in the lab one by one to see which one is having an impact. And if we see an impact, we use neutralizing antibodies, or we remove it to see what happens when it's removed. So these processes, leveraging omics technologies, followed by validation techniques in the lab, allow us to pinpoint molecules. But of course, we always need to remember that mouse doesn't translate into humans, and even if we see results with one thing, the system's biology, as you mentioned, and every individual is different.
I can just add to that. Thanks for a great question. Maybe I can add some more complexity, right? Just as it's one body, but the intervention can be 100, 200 different types of interventions, and then treatment status can be, there's so many, more than 100 different types of cancer treatments. And as you see in the scoping review, not a single or studies are the same to another, which makes it really difficult to kind of conclude. As they see also the sample sizes are very small. As we do some of those preclinical research, we have to see the repetitions and similar outcomes, but we just don't have those repetitions in different. So we hopefully do more research in a similar, very similar settings, and then we may hopefully see the similar outcomes, and we can say, oh, this might have some trend, but it's very complex.
Very good question and very good answers. Now I want to add just one more sentence that, there are so many factors we have to consider for the cancer patient conditions, but as I brought EVs, extracellular vesicles, which contains lots of proteins and microRNAs and DNAs and lipids, which can reflect the human physiology. So I think that's one of the candidates that we can focus on, keep studying that. Thank you.
Hello, I have just one question to the second speaker, Dr. Kang. Hi, I'm Sung Lee, a PhD student of Professor Justin. In the final slide of your presentation, it was suggested that the current guidelines equating 150 minutes of moderate intensity activity with 75 minutes of vigorous intensity activity might need revision. However, those guidelines refer specifically to aerobic exercise, but in your scoping review, didn't you classify not only aerobic activities but also resistance training as vigorous intensity? So what was the rationale for categorizing resistance exercise as vigorous intensity in your intensity framework? That's my question.
I think Kristin can also jump in if you, so because the guideline is a lot based on the aerobic exercise studies because we don't have a lot of resistance-only exercise trials in the past and draw some particular regimen or intensities to specify the benefits of exercise as far as I can understand. But the aerobic part, I think we are just more focused on these intensities are, as you see, most of the studies having aerobic part with the resistance exercise, but there's only a few studies that are only doing resistance exercise. It's really hard to kind of dissect the benefits. So in our review, when we are categorizing those aerobic and plus resistance exercise, we are focusing on aerobic intensity rather than resistance. So they're relatively more categorized and studied and more rigorous in terms of measuring subjectively. So I don't have a clear answer to your question, but I think it'd be more, beneficial if there are more resistance exercise studies that are having clear intensities when they are prescribing exercise and then what they see in terms of the immune outcomes.
Okay. Thank you again to our three speakers and everyone here for a productive discussion. I hope not today, but tomorrow. Thank you.
We're going to take our final break to ensure that we finish on time. We'll start promptly at 4:30. going to start in 1 minute. 1 minute.
네, 안녕하세요. 오케이.
Welcome back, everyone. We're going to ask you to take your seats as we start session 5, our exercise oncology talk, global perspectives in exercise oncology. This session is co-hosted by the Korean Society of Exercise Physiology. Our session chairs are here, Dr. Yoon Jong-jang from the National Cancer Survivorship Center, and Dr. Sang-hoon So from here at Yonsei University. Please welcome our chairs and chairs. The floor is yours.
Honored to be here. My name is Sang-hoon So from Yonsei University. The professor sitting next to me Actually, famous singer in Korea, Dr. Jang Yun-jung from National Cancer Center, will be chairing the session titled Exercise Oncology, Global Perspectives in Exercise Oncology. In this session, we have one presentation followed by discussions where we have 5 outstanding discussants to talk about the issue of exercise oncology. Now, just letting you know that discussion session is conducted in Korean, and all the issues being discussed here will be displayed on the monitor. The speaker we have, Dr. Oh Shi from Hosei University in Japan. The topic that he's going to present is from guideline to practice, so exercise for cancer survivors in Japan. Please join me in welcoming Dr. Oh Shi.
Thank you so much, kind introduction for me. So I'm very happy to have a presentation for the last presenter. So I don't want to ask you to do the squat, break, anything. Just go ahead to my presentation for that. So I'm from Tokyo, Japan. I belong to the Hosei University. And also I have appointment at Kansai Medical University from this year. So I'd like to talk about this point from guidance to practice exercise for cancer survivors in Japan, the current situation for that. This is my presentation topic that I'd like to talk about global exercise oncology consensus and guideline at first. Then I'd like to move to the Japanese guideline and the current practice in Japan, which I would like to introduce my intervention or activity for it. Here, it's kind of a busy slide, but there are a lot of guidance and consensus here. So the Kristin is here, Anna is here. So I'd like to briefly introduce the global guideline for that. Here, so maybe you must know, but I would like to introduce you that in the global consensus is saying that exercise safe. Here, exercise generally safe for the cancer survivors. Cancer survivors should avoid the physical inactivity. And also, aerobic resistance exercise during cancer treatment improve these kind of side effect or something like that. The important point is the discussion in this guideline is saying that the important first step is making the exercise a standard part of cancer care. This is important, and also I would like to emphasize that multidisciplinary effort across many professional care for the patient with cancer is more important for that, including the exercise scientist. Here, I put some recent topic that oncologists should assess advice for the exercise, and also it should be published this month or last month. Exercise is one of the most powerful cancer therapy, but unlike a pill, it requires a behavioral support, specialized professionals, acceleration standard, and adolescence is become standard care for that. That's a point. So this is the situation, the global standard, and I would like to move to the Japanese situation, which I was involved, some guideline involved in this kind of project here. So here's the Japanese situation that the number of the cancer survivors, the same as the world situation, in Japan has steadily increased. The survival rate is going up. Yep. And also, clinical practice in Japan has traditionally relied following the international guideline of exercise and rehabilitation. However, there's a limitation that robust Japanese specific evidence need to it's kind of limited for that right now. So here, I would like to show 3 guidelines today, and then also, in addition to these kind of guidelines, we are working on this project for that. So here's a cancer rehabilitation. This is Japanese, but the guideline for cancer rehabilitation is a third version. We are working on that. I'm working on the assistant committee member for that. So this is following the ACS and the ACSM guideline and adapted to Japanese oncology practice. That is having the cancer site and the phase-specific chapters, and including the post-operative rehabilitation, something like that here. The point is, again, the research or evidence is still limited for that, but we are updating every 3 or 4 years. Now we are working on the, we are working on the third version right now. Next, then we are working on the, Fukushima is coming for today. He published a paper that the clinical situation is not easy because a national survey designed by a cancer hospital is showing that outpatient rehabilitation is private in the less than 40%. About 80% they judged as insufficient. We need to improve the data service for that. There's some barrier here. The number of the specialized therapists, including maybe exercise scientists in the future, and also weak link to the community program. This is the point that we having trouble. So therefore, we have also been working on exercise oncology and rehabilitation outside of traditional rehabilitation framework. This is a new concept that the patient is coming in the hospital, not diagnosis. Before the diagnosis, we are asking to start exercise. Before the treatment, before the diagnosis. This is what we call the START project with the Kansai Medical University here. We just published a paper that the feasibility study this year that is home-based pre-treatment exercise for advanced lung cancer START trial that only 4 weeks home-based program of slow movement training and aerobic exercise this is a good compliance rate because it's over 150% are there. And also they are doing the exercise so much and then keeping the lower limb strength. I would say this program is good for the further study, the RCT or the next step for that. And also, the second one is Japanese cancer survivors guideline for the exercise and physical activity. This is from the National Cancer Center, Japan. I was involved one member in this project that it takes maybe 5 years. And then finally, last year, we published the paper and published a guideline in Japanese. Here, so the background, I would like to introduce that because the Korean guideline will start soon, I guess. So this is a background when we started the guideline project that this new guideline provides Japanese specific evidence-based recommendation because we are following the international guideline before this project, right? We have the SSM, ACS guideline, but we need to think about our own guideline for that. So this guideline primarily written for the healthcare providers, healthcare professional, especially adult, not young YA, but right now, at this moment, we are working on the adult and elderly people for that. So this is a limitation, but we are focusing on the patient completed the primary treatment was stable. We can't. This guideline does not cover the people in the active cancer therapy or during treatment for that. Next step, we need to include, or we need to set the different concept for that. The clinical question is here that should exercise be recommended to non-exercise habitual survivors aged 18 to 65? And also, we have decided to divide over 65 or under 65 for that, because the situation is not the same. So after we finished the meta-analysis and modified Delphi, we have reached to the answer in here. Sorry again. So exercise should be suggested for the age 18 to 65 years old, non-habitual exercise. And also over 55 years old elderly people also should be suggested. That was our conclusion at this moment, but I would like to a bit additional comment on this recommendation. So we reached that exercise during the after cancer treatment can be performed safely and improve this function here. Overall, benefit of exercise for survivors, especially these symptoms, were judged to overweight the harm. It's good balance. We have reached to recommend exercise, the balance for the side effect for some other adverse event for that. However, there are few trials data for the adult aged over 65 years old, and then Japanese randomized RCT trial are still limited like that. So we need to add evidence from Japan for that. That's our conclusion for that. And also we couldn't reach to set a fit BP or other specific exercise for the specific cancer site or stage for that. Just we reach suggestion for the exercise at this moment. And also we are working on the evidence from working on the evidence gap to the practice. Japanese mask, Japanese Association of Supportive Care in Cancer. 3 years ago, we have established the exercise oncology working group. I'm working on the vice chair there. We said that Japanese definition of the exercise oncology here. So here, this is the exercise oncology in Japanese. You want to take a photo? I can wait for that. Some newspaper came here to expand our concept that's new, right? And then this is all Japanese, but I put in the deep learning for that. So I don't know if it's correct or not. But we are starting with exercise oncology just 3 years ago. So this is a membership. I would say that this working group has a lot of background professors here. So here, physician, oncologist, or rehabilitation doctor, physical therapist, OT, exercise physiologist, exercise science too. In this working group, we are working on the promotion or awareness program for exercise oncology for the elderly people. As you know, Japan has a lot of elderly people, so we need to encourage the older people with cancer. So that's why we are setting the exercise prescription guideline or some sample making for the elderly people and making for the professionals. So we have this divided three groups and working on the this category is good for the exercise or something like that. We finally finished this stage, the boredom. And we are working on set a training session coming 6 months. And then we will make some e-learning material or the mobile app for the medical professionals and exercise scientists. This is some sample for that. This is algorithm. I'm so sorry, it's a kind of Japanese word. And then here is some specific menu for the exercise. The last one is Japanese Breast Cancer Society Clinical Practice Guideline. Those three guidelines are only exercise oncology works at this moment in Japan. So here, the Breast Cancer Society Clinical Practice Guideline is saying that is maintaining high level of physical activity recommended for the patient with breast cancer. Recommendation is strongly recommend. The recommendation is kind of higher, and evidence is moderate. Agreement was pretty high. So in that line, the breast cancer survivors in Japan need to exercise. However, this is our project, that national survey. The results showing that that's not perfect situation in the implementation, because they are having the barrier such as they don't have a time. They don't know how to do that. And also they need to improve social support, self-efficacy. Finally, we published this year, but we need to solve this kind of point. So we have completed this project. That was project with the National Cancer Center, Dr. Matsuoka and Dr. Tsuji. We made a home-based HIIT training with mobile app and wearable device with Fitbit. So we have reached to some data that in this paper though. So you know well that the VO2 before treatment minus after treatment minus before treatment is showing that going up this exercise group, and also control group is going down in the average. The leg press also going up, and trend is showing that the fatigue is going down for that. So which means home-based mobile app, the wearable device, could cause some increase in the VO2 peak and the muscle strength, and also decrease in the fatigue like that. So this is my favor for you. This episode is available in the English in the NHK. So if we got a higher chance the NHK coming back to the number of the checking, seeing a lot. So if you have time, please check it, including cancer rehabilitation. Okay, so this is the final slide that Japan has developed evidence-based exercise rehabilitation guideline for cancer survivors. That is aligned with the global standard. However, we have some limitation, such as the evidence from Japan, and then the difficult situation in Japanese specific point, such as aging society or something like that. However, we need to try to update and working on this guideline project for that. 감사합니다. Thank you so much.
Thank you for your wonderful talk. I wish I could understand Japanese. So, Dr. Ochi's presentation is open for discussion. So let me ask you two simple questions. Where is your university located in Japan?
Oh, that's an easy question. I should say the first slide, but I came from Tokyo, Japan.
Tokyo.
Yep.
I see. The second question is, what would be the main differences in exercise guidelines for cancer survivors between ACSM and Japan?
Oh, it's kind of same, but they didn't. We didn't say anything about the specific time. For example, 150 minutes per week, or we couldn't recommend to combine with the resistance training and aerobic exercise for that. Yeah.
Okay, thank you. Dr. John?
암하고 전쟁이라고 생각하는데 지금 이겨가고 있다고 생각해요. 오늘 좀 파이팅 하면 좋겠습니다. 감사합니다. 네, 기타들 운동이 암을 원프로!
저도 암 하는데 이렇게 완주하고 나니까 너무 좋습니다. 저도 늘 하루에 한 10km 걷거든요. 근데 되게 도움이 많이 되는 것 같아요.
근데 그때 뛸 때는 진짜 주변을 둘러볼 겨루도 없이 딱 이러면서 했는데 막상 끝나고 나니까 막 뭔가 개운함, 뿌듯함 막 그런 느낌이 오더라고요. 너무 좋았어요.
마라톤을 위한 마라톤이 아니라 의미가 많잖아요. 일단은 기부런이고 그리고 또 함께 준비했다 오는 거고 그다음에 그 코스도 너무 좋아서 올해 단풍도 처음 보고 그래서 아주 다 좋아요. 하나도 안 힘들었어요.
사실은 많은 분들이 운동하면 암 예방이 되기도 하고 또는 암 재발이 예방이 되기도 하는 잘 모르세요. 그래서 많은 분들이 좀 알았으면 좋겠다 해서 그런 취지로 준비를 했고 이게 가능했던 이유는 주변에 많은 분들이 도와주셨어요. 그래서 그분들이 없었다면 행사가 도저히 이루어질 수 없었는데 그분들에게 진짜 감사드린다는 생각이 들어요.
네. 안녕하세요. 쭉 들어가시면 됩니다. 네. 저희가 온콜로지 톡을 하기 전에 저희가 좀 이 무거운 분위기를 좀 이렇게 어울리기 위해서 이렇게 온코론 톡이라는 거를 급하게 만들었어요. 네. 이게 뭐냐면 지금 제가 한국말로 얘기하고 있는데 실시간으로 영어로 번역되는 것을 저희가 테스트를 한번 해보고 있는데 잘 되면 내년 심포지엄 때 영어로 발표하는 것을 한국어로 또 할 수 있게끔 해보도록 해보겠습니다. 네, 먼저 저희가 이 분위기를 좀 올리기 위해서 영상에서 봤던 운동이 암을 하면 어떻게 했죠?
이긴다.
네, 그 다음에 온코론.
화이팅.
네, 이거를 저희 지금 직접 온코론을 참여해주신 두 분을 저희가 모셨거든요. 이 두 분께서 운동이 암을 하시면 여러분들이 이긴다를 해주셔야 되고. 그다음에 온코론 하면 화이팅 해주셔야 돼요. 근데 이게 서로가 이렇게 열심히 해주셔야 이렇게 또 흥이 나니까 여러분들 한번 암을 연구하시는 분들인지 아닌지를 저희가 한번 보도록 하겠습니다. 자, 마이크.
운동이 암을
이긴다.
온코론 화이팅!
예, 좋습니다. 네, 이렇게 이제 저희가 네, 해주시면 되고 그 운동이 암을 이긴다라는 내용을 잘 기억하시고 또 유튜브에 운동이 이긴다를 검색하면 오늘 심포지엄 이 내용이 다 유튜브에 저장이 되니까 시간이 지나도 볼 수 있다는 점 또 광고해 드립니다. 그리고 저희가 이제부터 이 두 분을 모신 이유를 좀 얘기를 해볼 건데요. 이 두 분은 지금 현재 암 치료를 받고 계신 두 분이신데 이제 온코론을 참여해 주신 분들이세요. 그래서 현재 어떤 암이시고 또 어떤 치료를 받고 계신지를 한번 소개해 주시면 좋을 것 같습니다.
저는요 유방암이고요. 호르몬 수용체 양성이라서 타모xifen 5년간 복용을 하는데 지금 4년째 복용을 하고 있습니다. 근데 타모xifen을 먹고 나서부터는 굉장히 힘들더라고요. 근데 그 얘기를 계속 해도 될까요? 근데 저는 수술이 끝이 아니고 수술을 한 그 다음부터가 이제 정말 시작이더라고요. 그때부터 이제 막 그 감정 기복도 엄청나고요. 막 여자들이 말하는 그런 갱년기가 막 오기 시작하는데 그게 걷잡을 수가 없더라고요. 근데 저는 그걸로 운동으로 극복한다는 생각은 안 하고 저는 집에서 나오지 않았거든요. 근데 제가 온코론에 참여하게 되면서 그때부터 쉬지 않고 운동을 하는데 그게 얼마나 좋은지를 지금 느끼고 있습니다. 네.
안녕하세요. 저는 연세 암병원에서 계속 항암하고 있는 위암 4기 김별림이라고 합니다. 저는 작년 6월에 진단을 받고 위 전절제 수술을 했어요. 그리고 보조 항암 8차를 진행을 했습니다. 그래서 끝나는 줄 알았는데 갑자기 전이가 생겨가지고 지금은 복벽전이로 인해서 고식적 항암을 거의 이제 지금 현재까지도 계속 이어오고 있는 중입니다. 그리고
어떤 부분이 제일 불편하셨어요? 치료 받으시면서?
치료받으면서 제일 불편했던 점은 일단은 위를 전절제를 하면서 식사하는 것 자체가 적응하는 데까지가 굉장히 조금 그때는 초반엔 좀 불편했고 또 이제 항암을 하면서 항암으로 인한 그런 부작용이 굉장히 힘들었었습니다. 그때 젤록스라는 젤로다와 옥살리 플라틴 조합으로 항암을 했을 때는 구토하고 오심하고 그리고 이제 아무래도 체중이 감소가 되고 손발이 감각이 막 둔해지고 그리고 저의 의지와 상관없이 자꾸 집중력이 떨어지면서 좀 우울감도 찾아왔던 것 같아요.
그러면 이제 운동을 좀 이렇게 해보시면서 또 그런 지금 불편하셨던 부분 중에서 좀 좋아지셨던 부분이 있나요?
네, 많이 좋아졌죠. 일단은 그 동안의 부작용들이 계속 부작용이 항암이 쌓이면서 부작용이 이렇게 올라갔었는데 달리기를 조금씩 하고 나서부터는 이 부작용이 더 이상 더 큰 부작용으로 가지 않고 안정적으로 좀 유지되고 있으면서도 체력이 또 좋아지니까 확실히 많이 좋아지고 있다라는 거를 느꼈고 제일 큰 변화는 마음의 변화인 것 같습니다. 뭐랄까 살짝 달리기를 하다 보면 다리가 뛰고 또 심장이 뛰는 걸로 막 쿵쾅쿵쾅 느껴지지 않습니까? 그러면은 느껴지는 이 순간을 내가 지금 살아있구나 하는 그런 감사함으로도 받아들이게 되고 또 가족 관계들도 많이 좋아지고 또 수면도 질이 좋아지고 굉장히 삶의 질이 많이 좋아졌다고 볼 수 있는 것 같습니다. 네.
네, 좋습니다. 우리 김현정님도 저기 마이크 잡으시고 네, 좀 치료 받으시면서 불편했는데 혹시 운동을 통해서 좋아졌다라고 느낀 점이 있으면 좀 얘기해 주시면.
저는 변비도 있었고요. 무릎도 아팠고요. 타목시펜 먹기 전엔 그런 일이 없었거든요. 근데 그 약을 복용하고 나서부터는 모든 게 안 좋아졌어요. 그런데 전용환 교수님께서 그냥 달리라고 했으면 저는 못했을 텐데 슬로우 러닝은 약간 점프하듯이 이렇게만 하면 된다고 옆에 사람 걷는 것처럼 맞춰서 뛰면 된다고 그렇게 했더니 4km를 제가 뛸 수 있는 거예요. 그래서 저는 슬로우 러닝이 최고라고 생각합니다.
네, 그러면 지금 운동 온코런을 지금 참여하시고 나서 그러니까 하시기 전에 이 온코런을 참여하기 위해서 운동을 좀 꾸준히 해오셨잖아요. 그렇죠?
네. 저는 숨만 쉬었죠.
숨 마셨죠.
네.
예, 전에는 숨 마셨는데 이제 운동 온코런이 끝나고 나서도 지금 잘 이어지고 계신가요?
그럼요. 뛰면은 좋다는 걸 아니까 지금은 이제 뛰었는데도 무릎이 안 아파요. 네, 무릎이 아프지 않고 그리고 여자들이 좋아하는 그 다이어트. 네, 4kg가 빠졌어요.
4kg를
네.
쪘는데 4kg가.
네.
네, 좋습니다. 네, 혹시 또 우리 김변님은 지금 온코런 하시고 나서 다시 계속
지금까지 운동을 계속 조금씩 하고 있고요. 그리고 저도 슬로우 조깅으로 하고 있는데 한 주에는 10km를 그러니까 2km 한번 뛰고 뭐 2.5km 뛰고 뭐 3km 뛰고 2km 뛰고 이런 식으로 해서 10km를 늘 채웠었어요. 근데 온코런 하고 나서 자신감이 막 상승된 거예요. 이거 완주 메달 받았잖아요.
와, 완주 메달.
그러니까 나 뭐든지 할 수 있겠다 이런 자신감에 조금 오버했던 것 같아요. 저는 그 수위를 좀 조절을 좀 못하고 한 주에 20km 원래 했던 기록보다 좀 2배를 했더니 조금 항암하고 그 몸이 회복이 조금 더뎠다. 그래서 좀 수위 조절이 좀 필요할 것 같아요. 이제 앞으로는 좀 맞춰 가려고 합니다. 네.
네, 좋습니다. 그러면 혹시 여기 암 환자들을 위해서 운동을 연구하는 분들이 있는데 혹시 하고 싶은 말 있으시면 간단하게라도 있으면. 네.
제가 이 온코런에 참여를 해서 운동이라는 걸 하게 됐고 이게 좋다는 걸 체험을 했기 때문에 물론 이게 2회에 참여하신 분이 또 하고 나서 난 별로야 하고 안 하실 수도 있는데요. 또 저처럼 계속 운동을 해서 좋아질 수도 있으니까 저는 2회, 3회 이런 체험할 수 있는 이런 게 많이 생겼으면 좋겠다. 네. 이게 암 환자들은 혼자서 나와서 운동 못 하거든요. 절대로. 네. 그러니까 옆에서 이런 행사에 참여할 수 있도록 많이 이끌어 주셨으면 감사하겠습니다.
너무 좋은 말씀이세요. 저도 온코런 대회 하기 전에 사전 클래스를 신청을 했어요. 그리고 2번을 참여를 했거든요. 그러면서 이렇게 재밌고 쉽게 배울 수 있는 운동이 이번 기회가 아니라 조금 생활 속에 좀 스며들면 좋겠다라는 생각을 좀 했었어요. 그래서 그때 암 한우들도 있었고 암 한우 또 보호자들도 같이 운동을 했었을 때 혼자 한 것보다 훨씬 재밌었었거든요. 그래가지고 예전에 제가 4년 전에 임신 등록을 하러 보건소에 갔을 때 임산부를 위한 필라테스 운동교실이 잘 되어 있더라고요. 그래서 그런 것처럼 좀 지자체에서도 좀 암 한우를 위한 그런 프로그램을 해주면 돈도 조금 저희는 절감하면서 좀 접근성도 좋고 또 쉽게 좀 재미를 느끼면서 또 계속 할 수 있지 않을까 하는 좀 생각을 해봤어요. 근데 그런 게 될 날이 언젠간 오겠죠. 네, 그런 날이 오기를 바라면서. 네.
강원도 인제에서 오셨어요. 그래서 저희가 5km 달리기 전에 3주 동안 매주 러닝 클래스를 할 때 인제에서부터 오셔가지고 클래스에 참가하시고 그리고 처음으로 5km 완주하시고 지난번에 인스타 보니까 또 6km도 뛰시고 근데 오버페이스를 좀 하셨네. 네, 그래서 저희가 올해 처음으로 이렇게 온코론을 한 거는 정말 우리 아까 아침에 수업에서도 우리 강의에서도 들었듯이 운동하면 재발이 거의 아까 막 30% 줄고 생존율이 막 37% 올라가고 그런 얘기를 우리가 말로만 하고 그냥 연구로만 끝나는 게 아니라 정말 우리나라 앞으로 정책이 바뀌고 지금 방금 말씀하신 대로 정말 이런 운동 프로그램들이 각각 지자체에서 우리 암 생존자들 위한 운동 프로그램들이 나오고 더 나아가서 우리나라 운동 가이드라인 같은 것들이 나와서 누구나 우리 암 생존자들이 원하면 운동을 할 수 있는 그런 이 대한민국이 되면 좋겠다라는 소망으로 이런 세션을 준비했습니다. 네, 감사합니다.
네. 그래서 저희 마지막으로 한 번 더 외칠 건데요. 네, 제가 운동이 암을 하면은 이긴다 해주시고 온코런 화이팅 해주시면 감사하겠습니다. 네, 운동이 암을 이긴다. 온코런 화이팅. 감사합니다.
갑자기 훅 들어오셔가지고 10분밖에 안 남았습니다. 디스커션 그 패널 멤버들 다 앞으로 좀 나와주시면 감사하겠습니다. 제가 간단하게 그 패널 멤버 교수님들 소개해 드리겠습니다. 첫 번째 여러분들 왼쪽부터 이승용 인천대학교 교수님이십니다. 김연수 서울대학교 교수님이십니다. 제가 장난기가 좀 발동해서 죄송합니다. 전용관 연세대학교 교수님이십니다. 여러분 전용관은 신촌에 가면 많이 있죠, 그죠? 전용관. 우리 정희철 강남 세브란스 교수님이십니다. 박세정 한국스포츠과학원 스포츠과학실장님 오셨습니다. 제가 좌장 직권으로 정희철 교수님한테 먼저 한 질문 던지면서 들어가겠습니다. 일반인들과는 달리 암 생존자들은 운동 가이드라인을 좀 생각을 하고 만들 때 고려해야 될 사항이 굉장히 많은 것 같은데요. 그런 부분에 대해서 한번 정리 좀 해주시면 고맙겠습니다.
예, 암 생존자라는 말을 요즘은 이제 암 생존자보다 암 경험자라는 말을 더 쓰는 걸로 되어 있습니다. 사실 우리나라가 전 세계적으로 암의 어떤 치료 성적은 상당히 높은 편에 속하고요. 사실 지금 현재 암의 생존자라고 우리가 분류를 했을 때 전체 우리나라에서 보면 한 150만 명 정도가 있는 것으로 되어 있고요. 암의 유병 지금 앞에 계셨던 분처럼 이제 암의 유병률이라고 따지면 한 260만 명 정도가 있는 걸로 되어 있습니다. 그래서 사실은 이제 암의 어떤 서바이벌 서바이버라는 이제 그런 표현을 우리가 쓰다고 하면 암 서바이버에 대해서 우리가 운동을 처방을 하는 거에 대해서는 뭐 사실은 아까 보셨겠지만 여러 가이드라인에서 얘기를 분명히 하고 있는 거는 맞고요. 일단은 저는 온콜로지스트고, 그리고 온콜로지스트는 사실은 모든 학문 중에서 에비던스를 가장 중요하게 생각하는 그런 이제 직군입니다. 그래서 현재까지 이제 아까 얘기를 좀 제가 좀 들어보면은 사실은 하지만 온콜로지스트들이 아직까지도 캔서의 치료에 대해서 운동이 굉장히 중요한 거는 굉장히 알고 있는 사실이고, 또 이게 있지만 아직까지 이거를 우리가 정확하게 그 리얼월드에서 트리트먼트의 어떤 가이드라인으로는 우리가 아직은 좀 어렵다라고 생각하는 이유가 현재로서는 조금 에비던스가 부족한 측면이 있기 때문에 이 에비던스를 어떤 식으로 극복을 해나가느냐가 이제 굉장히 중요한 사실일 것 같고요. 아까 이제 암 서바이버 얘기했을 때 제가 아까 일본에서도 발표를 하셨지만은 이 암 서바이버의 대부분은 브레스트 캔서랑 프로스테이트 캔서입니다. 그리고 그 분들이 50%를 차지하고요. 그리고 이제 또 50% 정도가 거의 65세 이상의 그런 환자 그런 사람들입니다. 그러니까 일단은 이 운동을 처방을 하고 운동에 대해서 얘기를 할 때 아까도 이제 그 일본에서도 분명히 65세까지로 끊고 그 65세 이후를 또 가지고 두 가지 가이드라인을 만드는 것처럼 그렇게 생각했는데, 그게 사실은 그렇게밖에 할 수 없는 이유가 암 서바이버가 가지고 있는 그런 어떤 나이적인 측면이 분명히 다르기 때문에 그럴 거고, 또 그게 현재까지 브레스트 캔서나 프로스테이트 캔서에서 나온 데이터들이 굉장히 많아서 이걸 가지고 이제 모든 암 환자들한테 적용을 할 수가 있겠느냐라는 것에 대해서도 사실은 조금 디베이트가 있는 것이 사실입니다. 그래서 현재까지 나와 있는 가이드라인을 보면은 보통 이 암 서바이버의 아까 말한 대로 인구 구성이 좀 다르기 때문에 브레스트 캔서, 그다음에 프로스테이트 캔서, 그다음에 또 이제 그 나머지는 콜론, 그러니까 대장암이 되겠죠. 그다음에 그 나머지는 조금 이제 다른 잡스러운 그런 암들이 있기는 하겠지만은 이제 제일 그 암 환자들이 가지고 있는 그런 암의 특성에 따라 좀 다릅니다. 그래서 브레스트 캔서인 경우는 많은 경우 서바이버들이 수술을 했고 방사선 치료나 항암 치료를 받고 있고, 아까 보신 분처럼 호르몬 세라피를 거의 10년까지 받으시면서 서바이벌을 하고 있는 분이고, 그리고 방사선 치료를 받으면서 손이나 어깨 등이 굉장히 림페데마라 그러죠. 그런 부종 같은 게 상당히 심하기 때문에 그런 신체적인 특성이 분명히 있고, 그리고 정서적으로도 이 오랜 기간 동안 치료를 해야 되기 때문에 그 정서적인 지지를 굉장히 필요로 하는 그런 분들이라고 생각하시면 되고요. 그다음에 프로스테이트 캔서는 남자들한테서 주로 생기지만은 굉장히 올드에이지입니다. 올드에이지가 65세 이상이 거의 대부분을 차지하고 있고, 또 많은 경우는 처음에 뼈로 전이되는 경우가 많기 때문에 뼈의 통증이나 뼈가 약해지는 경우가 상당히 많아요. 그래서 그런 또 특성이 있고, 콜론 캔서는 또 좀 비만인 사람들이 좀 많고요. 그 다음에 그 이제 장루나 이런 거를 차고 있는 영구적인 장루를 갖고 있는 분들도 많기 때문에 이제 그런 분들한테 억지로 복부 운동을 시켰다가는 또 문제가 생기는 이유가 있겠죠. 또 이제 아까 나오신 분 중에 이제 위암 환자가 있었는데, 사실은 위암은 굉장히 sarcopenia나 그런 팻 로스가 굉장히 심한 그런 상태입니다. 그리고 약도 상대적으로 상당히 세고, 그리고 환자가 못 먹기 때문에 그런 전체적인 바디 헤비투스가 그렇게 썩 좋지는 않은 그런 거죠. 그렇기 때문에 이 암이 가지고 있는 성질에 따라서 환자가 가지고 있는 그런 컴포지션이 전부 다 좀 다르기 때문에 이걸 일률적으로 이제 가이드라인을 만드는 것에 대해서는 조금 여러 가지를 생각할 면이 좀 분명히 있는 건 사실인데, 환자 측면에서 말씀을 드렸습니다.
네.
오늘 이제 마지막 토크가 되는 것 같습니다. 사실 오전부터 이제 내일까지 엑서사이즈 온콜로지와 관련된 이제 많은 것들이 논의가 될 거고요. 저희가 전윤광 교수님께서 이 프로그램을 이제 시작하시면서 처음 잡으셨던 개념이 이게 살루토제닉이라는 그 개념이 정말 저에게는 중요하다라고 생각이 됐던 게 저희가 이제 영양학회나 이런 부분을 가도 영양소에 이제 집착하시는 경우들이 많거든요. 근데 사실 이제 저희가 임상에서 보거나 현장에 있는 분들은 영양소가 중요한 게 아니라 어떻게 하면 잘 먹을까에 더 관심을 갖게 되는 거거든요. 그래서 사실 엑서사이즈 온콜로지 관점에서 그런 운동의 효과 이런 것에 대한 과학적 근거도 굉장히 중요하지만 운동이라는 것은 삶의 연속이고 삶의 부분이거든요. 그러니까 그거에 내 삶을 어떻게 하면 더 풍요롭게 할 것인가의 관점에서도 저는 엑서사이즈 온콜로지에 충분히 방점이 이제 있을 거라는 생각을 가지고 있습니다. 그래서 그런 아웃컴을 무엇으로 볼 것이냐에 따라서 정말 이제 우리가 무엇을 위한 운동이냐, 무엇을 위한 이제 신체 활동이냐에 대한 관점이 다양할 거라고 생각이 되고요. 이제 그런 부분을 어떻게 이런 사이언스에서 받아갈 것이냐. 근데 그게 어떠한 특정한 아웃컴, 왜냐하면 종양 치료를 위해서 우리가 운동을 하는 건 아니기 때문에 이제 어떻게 이런 그 환자들과 생존자들이 더 건강하게 진짜 건강하게 지내는 것에 관점을 두고 좀 접근해 주셨으면 하는 바람이 있습니다. 그런데 이와 관련해서 오늘 같이 오셨던 이제 분들이 계속 오늘 강의도 하고 참석을 해주셨는데요. 이 체육계 분야에서 또 다양하게 역할을 해주시는 교수님들 같이 계십니다. 그래서 이승용 교수님부터 그 엑서사이즈 온콜로지와 관련해서 교수님께서 생각하시는 우리나라에서 이제 앞으로 좀 진행했으면 하는 방향이라던가 만약에 이제 가이드라인이 진행이 된다면은 굉장히 에비던스가 제한적이라는 건 정말 사실이거든요. 근데 이런 부족한 에비던스 가운데서도 어떤 점이 좀 강조되거나 필요할 것 같다라는 말씀이 있으면 좀 해주시면 좋을 것 같습니다.
네, 질문 감사드립니다. 처음엔 전용광 교수님께 질문하시는 줄 알고 제가 아무 생각 없이 있다가 갑자기 저에게 토스가 돼서 저는 사실 지금 뭐 인천대학교에서 교수로 재직하고 있고 그렇지만 지금 저는 한국운동생리학회에서 부총무이사를 맡으면서 이제 학회를 약간 대표해서 이제 이 자리에 있는 것으로 제가 이해하고 있는데요. 지금 제가 사실 오늘 오전부터 계속 진행을 할 때 제가 두 번째 세션에서 질문을 좀 드린 것이 있었는데 어떤 특정 암 환자군에 특이적으로 적용할 수 있는 어떤 운동 처방이 있는지를 아까 그 질문을 드렸었는데 사실 다 돌아온 답변도 그렇고 전체적으로 저도 모호하고 어려운 부분이 있는 것은 알고 있습니다. 근데 한 가지 제가 말씀을 드리고 싶은 거는 결국은 저희가 지금 국제적으로 통용되고 있는 그리고 미국에서 캐나다에서 그리고 가까운 일본에서 조금 전에도 발표해 주신 것처럼 각각의 가이드라인을 만들어서 지금 진행을 하고 있는데 사실 굉장히 일반적인 가이드라인으로 보이고 저희도 만약에 가이드라인을 만들어야 된다면은 그런 식으로 만들겠지만 저기서 한 가지 더를 추가한다면은 아마 이제 암군별 특이적으로 발생할 수 있는 그 증상이나 어떤 그 특이적인 케이스들이 분명히 있을 거예요. 그러면은 그거에 맞는 세분화된 그래서 그 세분화된 어떤 증상을 완화시킬 수 있는 특정 정말 그 구체적인 운동 처방이 들어가야지만 우리나라에서 만든 운동 가이드라인이 또 더 어떻게 보면 국제적으로 통용될 수 있는 운동 가이드라인이 될 수 있지 않을까 이런 생각을 하고 있습니다. 그렇지만 계속 말씀드렸던 것처럼 연구 자체가 굉장히 제한적이고 부족한 실정이라서 우선 뭐 대규모 RCT 자체는 당장은 어려울지 모르겠지만 소규모라도 해서 계속해서 이제 연구의 양을 늘려가는 것이 중요하다고 생각하고 그러기 위해서는 결국 연구자뿐만 아니라 임상에 계신 분들 그리고 국가적인 어떤 서포트가 있어야지만 이런 것들이 더 빠르게 진행될 수 있지 않을까 생각하고 있습니다. 이상입니다.
다음은 김현수 교수님께 좀 여쭤보고 싶은데요. 사실 이제 아까도 일본 가이드라인을 만드실 때 그러니까 이게 리해빌리테이션이냐, 엑서사이즈냐, 그리고 또 이제 피지컬 액티비티의 관점에서도 그렇고 뭔가 접근하는 방식이 다르다라고 생각이 되고 특히 뭐 치료라던가 치료의 특정 부작용이 집중하는 것 중 리해빌리테이션 개념이 더 맞을 것 같다라는 생각이 드는데 그 운동에 대한 가이드라인을 만들거나 이제 이와 관련해서 정리를 한다고 할 때 어떤 관점에서 이걸 접근하는 게 더 좋을 거다 생각이 드시는지 의견을 좀 부탁드립니다.
뭐 그냥 결론부터 말씀드리면 다 포함되는 것이 가장 좋겠죠. 네, 저는 먼저 전용관 교수님과 그 연구팀이 엑서사이즈 온콜로지 이렇게 계속 연구해 주시고 좋은 이런 심포지엄 결과 내주신 거에 굉장히 감사하면서 저는 들으면서 아 내가 20년 전부터 이런 걸 하고 싶었는데 못했구나 그런 생각을 했습니다. 근데 저희가 이제 한국인을 위한 신체활동 가이드라인을 2023년도 그리고 또 10년 전에 2번 발표한 적이 있었거든요. 근데 이제 가이드라인이라는 것이 대국민을 대상으로 하기 때문에 저희가 했을 때는 이제 복지부 정책과제로 했었습니다. 그랬을 때 그 무게감 때문에 사실 근거가 조금이라도 빈약하다는 것을 이제 대국민 가이드라인에 넣을 수가 없었어요. 그래서 사실은 WHO 가이드라인, 그 이전에 미국 신체활동 가이드라인에 거의 비슷한 수준의 가이드라인을 낼 수밖에 없었고 물론 굉장히 제너럴하고 보편적인 가이드라인이라 좀 아쉬움이 있긴 한데 그러니까 그렇지만 또 이제 암 운동 가이드라인도 이제 여러 나라에서도 했듯이 우리나라에서도 반드시 이제 만들어야 되겠다라는 생각이 필요하다는 생각이 더 들었고요. 이런 부분들을 에비던스와 그리고 여러 가지 전문가들의 그런 어떤 합의, 컨센서스를 통해서 좀 좋은 가이드를 만들어 가야겠다라는 그런 생각이 들었습니다.
네, 그리고 박세정 선생님, 실장님 같은 경우는 지금 스포츠와 관련된 많은 연구들을 진행을 하셨는데 사실 이제 엘리트 선수들 그리고 일반인들에서 이제 새롭게 저희가 암 생존자나 암 환자 관련된 관점으로 또 국립암센터와 올해 MOU를 또 맺으시면서 이게 관점이 더 넓어지실 수 있을 것 같은데 앞으로 스포츠의학 관점에서 이 분야에 대한 연구나 이런 방향을 어떻게 생각하시는지 좀 궁금합니다.
네, 우선 제가 박사는 클리니컬 엑서사이즈 피지올로지라고 임상운동 생리학을 전공을 했었고, 네, 운동을 전공을 해서 운동 처방, SSM 운동 처방사이기도 하고 우리나라 건강운동관리사이기도 하거든요. 근데 암 관련 연구를 한 번도 한 적이 없습니다. 한 2주 정도 됐던 것 같은데 전용관 교수님이 갑자기 전화를 주시면서 암 환자를 위한 가이드라인을 만들려고 하는데 같이 하겠냐라고 말씀을 하시길래 제가 전혀 망설이지 않고 바로 같이 하겠다라고 말씀을 드려서 전용관 교수님도 놀라셨던 것 같더라고요. 그러면서 말씀을 드리면서 저는 암에 대해서 잘 모릅니다. 배우면서 같이 한번 해보고 싶습니다라고 말씀을 드렸던 이유가 저희가 많은 분들 체육계에 있는 분들 다 잘 아실 텐데 국민체력백이라는 프로그램이 제가 2012년부터 한 해 빼고 계속 연구를 추진을 해왔었거든요. 그래서 이런 연구를 하면서 건운사들이 저희 76개 센터이고 건강운동관리사라든지 체력 측정 요원으로 300명 이상이 다 재직하고 있습니다. 아시다시피 국가에서 운동 관련된 자격증을 주는 나라는 많이 없는 걸로 알고 있고 이분들이 이렇게 진행을 하시면서 지금 국민체력백에서는 질환자들은 공식적으로 참여하실 수가 없습니다. 그래서 파큐를 통해서 질환이 있으시면 기저 질환이 있으시면 안 되고 의사 선생님들이 소견서가 있어야만 참여를 하게 되는데 현장에서 듣는 얘기들은 암 환자분들, 암 경험자분들도 많이 참여한다라고 하시더라고요. 근데 우선은 그런 얘기들을 전혀 없이 참여를 하시다가 체력 증진 교실이라든지 체력 측정을 통해서 그 사실을 인지하게 된다라고 하시더라고요. 그러면 조금 더 양성적으로 진행을 하고 이런 그 가이드라인이 나와서 사전 스크리닝 할 수 있는 것들이라든지 어느 상태에서 말씀 주셨다시피 저희가 관리할 수 있는 상황들은 뭐 일본 사례에서도 이야기하셨다던데 하신 것 같은데 뭐 프라이머리 트리트먼트가 끝나든지 스테이블한 환자들이 운동을 일반 지역사회에서 할 수 있는 사람이라면 저희 센터가 같이 할 수 있지 않을까. 그래서 이런 가이드라인들이 만들어진다면 저희가 뭐 암 환자를 위한 뭐 자격증이 새로 생긴다면 좋겠지만 지금 상황에서 재교육이라든지 워크숍을 통해서 저희가 할 수 있는 부분도 있을 것 같아서 이런 부분에서 조금만 더 사전 스크리닝 된다든지 저희 프리쿠션이라든지 컨트롤 인디케이션 정도만 알려주신다고 해도 저희가 현장에서 바로 뭐 조금씩이라도 내년이라도 조금씩은 실행해 볼 수 있을 것 같아서 되게 좋다라고 생각을 하고 특히 이제 암센터와의 MOU를 통해서 저희가 그런 것들을 조금 조직적으로 할 수 있을 것 같고 가능하다라고 하시면 저희 국민들 지금 160만 건의 체력 데이터가 있거든요. 그래서 암센터랑 같이 해서 암 환자들의 체력 수준이 어느 정도인지도 저희가 조금 더 세계 어느 나라에서도 하지 못한 것들을 우리가 앞서 나갈 수 있지 않은가 하는 생각이 듭니다. 그래서 우선은 여기까지 한번 생각해 봤습니다.
네, 정 교수님 그 답변하실 준비 되셨죠? 예. 그럼 작금의 현실에서 우리가 운동 가이드라인 제정을 하려면 실질적으로 뭐부터 시작해야 될 것 같아요?
운동 가이드라인을 시작하려면 일단 먼저 관련 학계와 사실 관심 가지는 사람들이 모여서 머리를 맞대야죠. 일단은 얘기를 시작을 해야죠. 그러니까 물론 아까 우리 교수님께서 말씀하신 것처럼 운동 가이드라인을 만든다는 게 사실 다양한 암 환자의 상태를 생각하면 쉽지 않지만 또는 여러 가지 부작용을 생각하면 이거 괜찮을까라는 염려를 할 수 있지만 사실은 저희가 먼저 머리를 맞대고 시작해 보면 사실 그렇지 않은 경우도 많거든요. 그러니까 저희가 처음에 이제 2010년도에 우리가 암 환자를 대상으로 운동을 시작을 할 때 수술 다음 날부터 저희는 이제 운동을 시킨다고 할 때 일본에서 미친 거 아니야? 네. 수술 다음 날 어떻게 운동을 해? 네. 근데 저희가 그 환자의 특성에 맞게 운동을 해줬더니 퇴원이 이틀이 빨라지고 그리고 환자 회복이 빨라지고 지금 뭐 그런 것들을 저희가 지금 계속 반복해서 우리가 흔히 얘기하는 RCT 근거를 계속 내고 있는 거거든요. 그러니까 이게 가능할까? 어려울 거야 하고 못하면 그냥 못하는 거고 하지만 만약에 우리가 교수님과 같이 머리를 맞대면서 그러면 이런 환자들은 이렇게 하면 어떨까요? 뭐 이렇게 만약에 우리 전문가들이 머리를 맞댄다면 저는 충분히 가능하지 않을까. 그래서 교수님 질문에 대한 답변을 드린다면 지금 당장 이제부터 해야 되는 거는 우리 전문가들이 마음을 열고 만나야겠다. 그리고 그 만나는 장이 있어야겠다. 이게 제 생각입니다.
그럼 마지막으로 정희철 교수님께 하나 여쭤보고 싶은데요. 사실 이제 말씀하신 대로 온콜로지 관점에서는 이제 치료에 집중이 되고 환자의 특성을 운동이 우선일 수는 없는 상황이긴 하지만 사실 그 환자들도 그렇고 니즈가 굉장히 많은 상황입니다. 일본 사례에서도 이제 재팬 어소시에이션에서 먼저 같이 문을 열어주시고 그 장을 같이 협력의 장을 열어주셨는데요. 만약에 운동 가이드라인을 암 생존자 대상으로 만들게 되면은 그 카스크 차원에서도 협조하시거나 하실 계획에 대한 게 혹시 있으실지?
예, 그건 당연히 뭐 암 환자들한테 운동이 중요하지 않다는 얘기가 아니라 암 환자에게 운동을 당연히 해야 되면 현재까지 어떻게 해야 되는지에 대한 가이드가 없다는 게 가장 커다란 문제가 되고요. 뭐 한 예로 이게 아스코에서 암 환자들 한 2,000명을 가지고 이제 설문조사를 한 거 보면은 그 중에 미국 사람들도 50% 정도는 25%는 나는 운동을 이때까지 해본 적이 없고 또 25% 정도는 나는 운동을 하긴 하는데 굉장히 서브 옵티멀하게 한다라고 하는 적이 있습니다. 그래서 사실은 이제 저희가 만약에 이제 모여서 뭘 시작한다 그러면 사실은 가장 좋은 첫 번째는 우리나라 아까 얘기도 하신 것처럼 우리나라에서 과연 환자들의 어떤 바디 컴포지션이 어떤 식으로 지금 변하고 있는지 그리고 암 환자들의 바디 컴포지션이 정상인에 대해서 뭐가 다른지를 먼저 보는 게 첫 번째고 그리고 환자들의 니드죠. 두 번째는 환자들이 정말 내가 암에 대해서 암 환자가 운동을 하는 데 있어서 어떤 점을 내가 환자분들이 궁금해하느냐에 대한 어떤 설문지나 이런 거를 통해서 암 환자들의 니드가 도대체 뭔지를 먼저 파악을 하는 게 중요하다고 생각하고요. 그다음에 이제 가이드라인 시점에서 보면은 가이드라인을 만드는데 아까 일본에서도 분명히 비슷한 고민을 하셨을 텐데 이 서바이버 쉽을 가지고 있는 사람들은 분명히 에비던스가 어느 정도 있지만은 사실은 현재까지는 트리트먼트를 액티브하게 지금 하고 있는 암 환자라거나 사기여서 지금 뭐 굉장히 컨디션이 안 좋은 사람들에 대해서 트리트먼트 운동을 어떻게 하느냐에 대한 가이드라인이 현재로서는 거의 없습니다. 그 얘기는 온콜로지 소사이어티에서 가이드라인에서도 그런 환자들한테 운동을 무조건 레커멘데이션을 하면 안 된다라고 하는 이제 그런, 그래서 저희가 맨 먼저 접근할 수 있는 거는 아마 서바이버십인데, 서바이버십이 5년 지난 사람이 아니라 선생님 말씀대로 지금 액티브한 트리트먼트가 끝난 사람들한테서 재발이 아니면은 온콜로지 그러니까 환자들이 얼마나 좋아지느냐를 느껴야 된다는 거고요. 하나 부언드리면은 사실은 이제 이 연구가 저희도 이제 이거 제가 이런 뭐 패널 제안을 받거나 논문을 조금씩 이제 좀 찾아봤는데 사실은 현재까지 데이터들은 운동을 하는 것이 암 환자들한테서 세이프하고 그다음에 피저블하고 그리고 이피커시가 있다라고 하는 것에 대해서는 거의 대부분 다 동의를 하시는 것 같아요. 하는데 이게 정말로 프랙티스로 들어오려면은 이피커시를 보는 게 아니라 사실 이펙티브니스를 봐야 되는 거거든요. 그래서 진짜 리얼 월드에서 얼마나 정말로 이게 제너럴라이저빌리티가 있느냐라는 거를 가지고 따져야 되는 거고, 그리고 두 번째는 온콜로직 아웃컴이 얼마나 좋아지나. 아까 이제 어떤 분이 발표를 하셨는데 클리니컬 베니핏이라 그러죠. 얼마나 오래 살고 재발이 안 되고 치료를 얼마나 잘 받을 수 있고 하는 정말로 클리니컬한 환경에서 환자들이 느끼는 베니핏을 우리가 엔드포인트로 삼아서 앞으로 연구를 한다거나 앞으로 가이드라인을 만드는데 이제 그렇게 언급을 한다거나 해야 되는 거고, 운동하면은 기분 좋아지고 카디오 펄머너리 피트니스 좋아지고 뭐 하는 거는 지금은 이제 다 알고 있는 얘기인 건데 이것을 어떻게 클리니컬 아웃컴으로 트랜슬레이션을 하느냐가 지금 현재로서는 제일 이제 우리나라도 물론이고 전체 그냥 어떤 그런 스포츠 온콜로지 소사이어티에서는 그것이 가장 중요한 거라고 생각합니다. 그래서 이번에 보신 것처럼 2025년에 아마 뉴잉글랜드 저널 오브 메디신에 결국은 수술을 한 대장암 환자, 항암 치료가 다 끝난 대장암 환자를 가지고 운동을 시키고 안 시키고 해봤더니 운동시킨 사람들이 굉장히 좋더라라는 데이터가 나오는 게, 그게 이제 뭔가 반향을 일으키는 거는 결국은 좋다는 게 그냥 좋은 게 아니라 진짜로 병이 재발이 되는 거를 막을 수 있고 재발되기까지 시간이 더 오래 걸리더라라는 데이터가 나왔기 때문에 이건 뉴잉글랜드 저널 오브 메디신 같은 데 나올 수가 있는 거거든요. 그렇기 때문에 결국은 우리 내부에서 사실 우리가 못할 건 아닐 것 같다는 생각이 들어요. 근데 이제 문제는 3년이라는 세월이 걸린 거고 환자를 인롤하는 데만 거의 10몇 년이 걸렸었기 때문에 운동을 3년 동안 시킨 거거든요. 운동의 효과가 금방 그렇게 나타나지는 않을 거고, 또 그거 자체가 나라에서 돈을 받기는 굉장히 어려운 이제 그런 거기 때문에 이제 그런 실질적인 문제를 어떻게 잘 이제 수능을 하면서 해보느냐라는 게 중요하겠죠.
좀 전에 이제 김현수 교수님도 말씀하셨지만 가이드라인을 만드는 것 자체는 굉장히 부담스럽고 힘들지만 그것이 있다는 것 자체가 정말 암과 운동이 얼마나 중요한가에 대한 인식을 또 바꿀 수 있는 시작이라고 생각이 됩니다. 이제 세션을 마치면서 전영관 교수님 마지막으로 좀 해주실 말씀 있으시면 마지막 메시지 듣고 세션을 마치도록 하겠습니다.
네, 교수님 저한테 기회를 주셔서 너무 감사한데 사실 여기에요. 그 되게 인터내셔널 엑스퍼트가 계신데 혹시 여기 우리에게 해주고 싶은 말이 있는지 한번 물어봐도 될까요? 네, Kristin and Anna May, and then also Nicole. I mean, he addressed the importance of not only efficacy but effectiveness. Actually, that's what you were presenting today in your presentation. But any one of you three, do you want to say anything? Now we are actually talking about maybe starting the initiation process for the physical activity guideline. but any international advice?
Yes, just how I should say. I would like to give you the advice to have a broad guideline and not focus on specific subgroups, because we still know that, for example, most research so far has been done in breast cancer. So if you want to make a guideline for specific cancers, probably the level of evidence will be low. What we also know from our studies where we pool all individual patient data and look into moderators, so whether there are subgroups who respond more than the others, we see that the effect is quite general. So also, for example, if in these data sets we look into whether there are different effects for younger or older people, we see that these are the same. And that is why I think at this moment I would not target a guideline but have a broad guideline. And this is what we did in the ACSM guideline. There we even put all evidence together from during and after treatment. In the ESCO guideline, for example, we looked into studies only referring to during treatment effects. But in both guidelines, we decided to not focus on specific cancer types. So I would recommend you to be not too small.
Thank you, Anna May. Anna May actually participated in ESCO guideline and also ACSM guideline. So I think she's the right person to give us advice. So now I'm going to speak in Korean. Yeah. 네, 그래서 저희가 사실 오늘 시간도 길지 않고 저희가 여기서 어떤 거를 뭐 결정하고 이런 자리는 아닌 것 같고요, 그죠? 그래서 하지만 여기 운동 생리학회 대표로서 오셨고 대한스포츠의학회를 대표해서 오셨고 사실 아까 그 마스크 여기 Korean Association of Supportive Care in Cancer 지금 회장님이세요. 그래서 아까 강남 세브란스 교수님이시지만 회장님으로서 오셨고 또 우리 스포츠과학원 실장님으로서 우리 다 사실 이렇게 모여서 이런 자리를 갖는다는 것만 해도 저희가 이제는 우리가 뭔가 다음 단계로 가고 있구나라는 생각이 듭니다. 그래서 저희가 앞으로 진짜 우리 사실은 국립암센터 중앙암생존자 통합지질센터 장님이시거든요. 그래서 저희가 앞으로 NCC 그리고 스포츠과학원 그리고 의학계, 체육계 다 같이 한번 머리를 맞대서 이제는 좀 뭔가 우리가 해야 될 때가 아닌가 그렇게 저는 생각을 하고 여러분들이 이렇게 와서 지지해 주시고 응원해 주셔서 너무 감사합니다.
네, 감사합니다. Time to wrap up. 오늘 좋은 토론 해주신 5분 그리고 끝까지 자리를 지켜주신 모든 분들께 감사 말씀드리면서 마치도록 하겠습니다. 수고하셨습니다.
그런데요, 우리가 사진을 한 장도 안 찍었네요. 혹시 우리 패널 분들하고 오늘 스피커 분들하고 네, 그래서 다 한번 international guest, we haven't taken picture yet, not at all. 사진을 한 장도 안 찍었어요. 그래서 아니면 저쪽에서 이렇게 찍을까요? 어떻게 할까요? 네, 그래서 제 생각에 그냥 한국식으로 가겠습니다. 자기가 30살 이상이다. 35 이상이다. 그럼 빨리 나오시고요. 네, 교수님과 뭐 다 나오시면 사실 우리 운동생리학에서도 많이 오셨는데 그래서 나이 드신 분들이 앞에 서시고 또 젊으시고 하신 분들이 이렇게 뒤에 서주실 분들 서주시면 같이 사진 찍겠습니다.